Good morning, everybody. Good morning, respected seniors and colleagues. I welcome you all to the third annual conference of the Society of Onco-Anesthesia and Perioperative Care organized by Tata Medical Center, Kolkata. It's my privilege to invite organizing chairperson of SOAPCCON 2021, Dr. Jyotsna Goswami, senior consultant and head, Department of Anesthesia, Critical Care and Pain at Tata Medical Center, Kolkata. Welcome, ma'am.
Okay. Good morning, everyone. On behalf of the Society of Onco-Anesthesia and Perioperative Care and Tata Medical Center, Kolkata, it is my pleasure to welcome all audience members, including all dignitaries, faculty members, and delegates to SOAPCON 2021. Due to the pandemic, we were unable to host this event last year. That said, we are happy to finally have everyone come together, even if on a virtual platform, for this great academic extravaganza. I welcome you once again to this long-awaited conference. Thank you.
It's my privilege to invite Organizing Secretary Dr. Anshuman Sarkar, Senior Consultant, Department of Anesthesia, Critical Care and Pain at Tata Medical Center, Kolkata. Over to you, sir.
Thank you, Dr. Hina. Good morning, everyone. Greetings from the City of Joy. I, Dr. Anshuman Sarkar, on behalf of the organizing committee, am deeply honored to welcome you all to the third annual conference of the Society of Onco-Anesthesia and Perioperative Care. It gives me immense pleasure to extend a hearty welcome to our chief guest, a man who needs no introduction, Padma Shri Professor Mamin Chandi. Dr. Chandi is presently the director of Tata Medical Center, Kolkata, and heads the Department of Clinical Hematology and Bone Marrow Transplantation. An alumni of Christian Medical College Vellore, he has been a pioneer in the field of bone marrow transplantation. In order to honor his vast contribution in the field of medicine for over 4 decades, he has been conferred the National Civilian Award, Padma Shri, and he is also the recipient of the prestigious Dr. B.C. Roy Award from the Medical Council of India. Dr. Chandi has been our guiding light at Tata Medical Center from the very beginning, and we all are deeply indebted to him. Welcome, sir.
Thank you.
I am deeply honored to welcome our guest of honor, Major General Dr. Sanjay Kapoor. Dr. Kapoor is presently the Deputy Director of Tata Medical Center, Kolkata. An alumni of Armed Force Medical College, Pune, he has a vast experience in conducting complicated cancer surgeries and has an extensive teaching experience. Besides being an experienced surgical oncologist and a passionate academician, he is also a MCI recognized professor of surgery and surgical oncology. He has been the editor of Indian Journal of Surgical Oncology and president of Indian Association of Surgical Oncology. He has been awarded with the Vishishta Seva Medal by the President of India for his meritorious services during insurgencies in Srinagar. Welcome, sir. I am truly delighted to welcome Dr. J.V. Divatia, Professor and Head, Department of Anesthesia and Critical Care, Tata Memorial Center, Mumbai. Dr. Divatia is the President of the Society of Onco-Anesthesia and Perioperative Care. He has also been the past President of All India Difficult Airway Association and Indian Society of Critical Care Medicine. He has also been the past Editor-in-Chief of Indian Journal of Anesthesia. He has numerous national and international publications. Welcome, sir. A warm welcome to Dr. Raghu Thota, Professor, Department of Anesthesia and Critical Care, Tata Memorial Center, Mumbai. Dr. Raghu is the founder secretary of the Society of Onco-Anesthesia and Perioperative Care and was the organizing secretary of our first SOAPCCON held in the year 2018. He is an executive member of the Indian Society for Study of Pain, Indian Society of Anesthesiologists, All India Difficult Airway Association, and a coordinator of Cancer Pain Special Interest Group. He has authored many textbook chapters and has numerous national and international publications. Welcome, Dr. Raghu Thota. A cordial welcome to Dr. Rakesh Garg. He is an additional professor, Department of Anesthesia at Dr. B.R. Ambedkar Institute, Rotary Cancer Hospital, and National Cancer Institute at All India Institute of Medical Sciences, New Delhi. Dr. Garg is an executive member of Society of Onco-Anesthesia and Perioperative Care and the editor-in-chief of Journal of Onco-Anesthesiology and Perioperative Medicine. He is also an associate editor of Indian Journal of Anesthesia and Journal of Anesthesiology and Clinical Pharmacology. He is a recipient of many awards. He has authored many textbook chapters and has numerous national and international publications. Welcome, Dr. Garg. Lastly, I welcome all the faculty members, speakers, panelists, chairpersons, and moderators without whom this conference would not have been possible. And I hope that this conference would be a grand success. A big thank you to all of you.
Thank you, sir. I invite all dignitaries for lighting the lamp with Saraswati Vandana performed by Dr. Aditi Gupta, consultant at Tata Medical Center, Kolkata. Yeah. like to invite President SOAPC, Dr. J.V. Devatya, Professor and Head, Department of Anesthesia, Tata Medical Center, Mumbai, to address the audience. Welcome, sir.
Good morning, respected Professor Momin Chandi, Director, TMC Kolkata, Dr. Sanjay Gupta, Dr. Jyotsna Goswami. It is indeed a great pleasure to have this third SOAPCCON being held. Although it's virtual and although we are at a distance, we are actually closer with Zoom and this virtual technology. We missed last year's conference because of this pandemic. We've missed coming to Kolkata this year, but we are going to have this conference nonetheless. So it's a great pleasure and an honor to have this conference at TMC Kolkata. So SOAPC has, although we've not been able to have a conference, SOAPC has been pretty active in the course of this pandemic. We've had fellowships starting in many centers, including TMC Kolkata. We've had a journal which we have sort of brought out, and Dr. Rakesh Garg is the editor-in-chief. We've had SOAPC guidelines for onco-anesthesia during the pandemic. We've had guidelines on opioid-free anesthesia. We have guidelines on HIPEC. So many of our members and our secretary, Dr. Raghu Thota, has been extremely grow further. And Tommy has been, and her team has been promoting and pushing. So thank you very much for hosting this conference. Thank you very much for moving onco anesthesia forward and for taking the lead. And I wish this conference all the very best. And I hope SOAPC, the Society of Onco Anesthesia and Perioperative Care, grows further and becomes stronger. So thank you and all the best once again.
Thank you, sir. Now it's my honor to invite our chief guest, Padma Shri, Professor Momin Chandi, Director, Tata Medical Center, Kolkata, to address the audience. Welcome, sir.
Thank you, Hina, Dr. Devatya, Dr. Jyotsna, Dr. Sudipto, the whole organizing team from Tata Medical Center, all the delegates who are attending this meeting. As director, it is my pleasure that Tata Medical Center, Kolkata is hosting this year's SOAPCON. 1 in 3 persons in the Western world will die of cancer. So cancer is the 3rd most important disease which has affected human beings and for which rapid progress is being made in terms of treatment. India too, as its demography is changing and we have more older people, will have a rising incidence of cancer. And I wonder how our healthcare system is preparing to meet the challenge of increasing numbers of patients who are older with comorbidities and where the discipline of cancer and the treatments are moving at a pace which is hard to keep up with. I believe that there are nuances in the management of cancer patients in terms of surgery, anesthesia, and perioperative care, which have to be understood properly if we are to give optimal care. Patients would have had previous chemotherapy, cardiac function and lung function may be compromised, and the anesthetist must be aware of all the complications of prior chemoradiation and be prepared and anticipate how to handle these problems. I am sure that your society will contribute toward increasing knowledge and awareness of managing cancer patients through surgery, anesthesia, and the perioperative period. So I wish this conference every success, and I trust that the knowledge you gain during these days of deliberation will help you to improve the quality of care when you actually deal with patients with cancer. Thank you very much for asking me to say these few words. Thank you.
Thank you, sir. It's my privilege to invite guest of honor, Major General Dr. Sanjay Kapoor, Deputy Director of our institute, to say a few words. Welcome, sir.
Good morning, everybody. Dr. Devitia, Professor Chandy, the entire executive committee of SOAPC and the organizing committee of SOAPCCON. We thank you all for choosing Tata Medical Center for the SOAPCCON 21. And we wish each one of you a very, very successful conference. As Sir said, cancer is here to stay and the epidemic of today. And even now, in spite of various modalities of medical oncology, chemotherapy, radiotherapy, and others that have come in, surgery still remains the mainstay of treatment. And over 90% of patients undergo some form of surgery, maybe an open lymph node biopsy, to multiple major surgeries for the disease, reconstruction, and subsequently rehabilitation. And for these surgery and surgical procedures to become successful and in extending pain relief and intensive care, the anesthetists and the complete department of anesthesia and the team and the fraternity of anesthesiology has come a long way over the last 2 decades. The contribution of the fraternity of anesthesia is significant, and their role today is much more than what the anesthetists contributed 2 decades back, where they were confined only to the OTs. Today, they are standing shoulder to shoulder with the surgeons from the initial prehabilitation, the pre-op management, the per-op management, the post-op, the pain, the intensive care, and participating not only in major surgeries which take many long hours, at times even 8 hours, 10 hours, 12 hours, but even at times 2 and 3 surgical teams working simultaneously on the same patient, especially where reconstruction or multi-system and multi-organ procedures are required. So the contribution of the anesthetist shall always be significant and remembered and acknowledged in cancer care. And we wish the fraternity all the best in future. And we hope that oncoanesthesia is recognized by our other organizing associations of the country, where it can come up with a DRNB or even a further doctorate degree where it can flourish further. So I would close now, conveying my thanks to giving us an opportunity to host the conference and for me to be part of this function. So all the best to all the delegates, and I'm sure that each one will benefit from this academic feast. Thank you.
Thank you, sir. Now I would like to invite our organizing chairperson, SOAPCCON 2021, Dr. Jyotsna Goswami, to address the audience. Over to you, ma'am.
Welcome, everyone. Society of Oncoanesthesia and Perioperative Care was formed in 2018 by like-minded oncoanesthesiologists working in various cancer centers across the country. It was created in response to the unique challenges we face as anesthesiologists while dealing with cancer patients in the area of anesthesia, critical care, and pain management, both acute and chronic. SOAPCCON is the platform which enables individuals in the field of oncoanesthesia to discuss and exchange ideas and knowledge amongst each other. The first conference was held in Mumbai in 2018, organized by Tata Memorial Hospital. The Indo-American Hospital in Hyderabad organized the second conference in 2019. And the third SOAPCCON, scheduled in 2020, organized by Tata Medical Center, Kolkata, had to be postponed to 2021 due to pandemic. Although we are unable to organize an in-person meetup, we are excited to take a step further in a new direction by hosting the third iteration of SOAPCCON virtually. We planned the scientific sessions carefully to include all areas of importance in the specialty. Our faculty include the most experienced teachers and renowned oncoanesthesiologists, both national and international, alongside a host of new generation of speakers. The scientific program is going to be a delight. We have a mix of lectures, pro-con debates, focused sessions, and master classes. We have tried to cover the entire range of topics related to anesthesia and critical care of cancer patients, as well as cancer pain management. Hope you find the blend interesting and informative. The audience here also has a major role, as most of the scientific discussions are related to debates and interactive sessions with issues that we face in our day-to-day practice. Their active participation is encouraged in the form of questions and comments to make these sessions more lively and interesting. The virtual platform has enabled the global leaders of oncoanesthesia and perioperative care to join the conference more than ever before. It will also enable the participants to adopt and tailor the scientific program and networking opportunities to their own needs. Alongside a comprehensive scientific program, the virtual platform provides unique opportunities to meet, collaborate, and share experiences with a truly global network of oncoanesthesiologists. I take this opportunity to request you all to actively participate to add to the richness of this conference and make it a memorable event. Finally, I would like to thank each and everyone involved in the organization of this event, and I wish all the participants a very successful conference. Thank you.
Thank you, ma'am. Now, may I please invite Honorable Secretary SOAPC, Dr. Raghu Thota, Professor, Department of Anesthesia, Critical Care and Pain at Tata Memorial Center, Mumbai, to say a few words. Welcome, sir.
Good morning, everyone. Good morning, Dr. Chandy and Dr. Sanjay Kapoor, Director, Deputy Director, TMC, Dr. J.V. Divatia, sir, President of Society of Oncoanesthesia and Perioperative Care, and Dr. Jyotsna Goswami, Organizing Chairperson of this third SOAPCCON 2021. And all my peer colleagues and my team members and faculties, national, international faculties. Thank you very much. So this has been a huge pressure for us working over the past 1.5 years or so under the stress of this pandemic called COVID. Though we planned to have this conference in 2020, but due to the COVID, it got postponed, and we are having this on a virtual platform in 2021. I thank Dr. Goswami for her sheer determination and persistence to continue this aspect and take the challenge to organize this conference even though there is a pandemic on a virtual platform. I hope this is going to be a wonderful feast of scientific knowledge sharing. Thank you very much for organizing this wonderful conference. Thank you, everyone.
Sir, it gives me great pleasure to announce the unveiling of cover of book, A Complete Guide to Oncoanesthesia, Critical Care and Cancer Pain. Before that, Dr. Neha Desai, co-editor, will give a brief introduction about the book.
Thank you, Hina. Good morning, honorable dignitaries, esteemed faculty, and dear delegates. As Dr. Chandy already said, the incidence of cancer is steadily increasing, and with oncological surgeries extending beyond the domain of specialized tertiary centers, more and more anesthesiologists are now managing these surgeries, which come with their own unique perioperative challenges. Fellowships in DM oncoanesthesia are already in place across the country, and super specialty DNB and FNB are in the pipeline, which would make a textbook or a reference book of oncoanesthesia a valuable addition to any student's armamentarium. With this in mind, we at Tata Medical Center, Kolkata, invited eminent anesthesiologists working at cancer centers from across the country to share their expertise with us in the form of a reference book, where we have covered all aspects of perioperative management, oncocritical care, and acute and chronic pain management and in cancer patients. We hope that this comprehensive textbook will benefit all involved in the management of cancer patients, making their perioperative journey better and safer. I now request our director, Dr. Maman Chandy, to unveil the book. Thank you.
Neha, thank you very much. I have great pleasure in releasing this book on oncoanesthesia. I've been sent a copy of the same, and I'm truly impressed by the large number of people whom you have put together to share their expertise. And this being a first, I'm pretty sure that it will be something which is valued by all the young people, as well as those who are practicing the specialty of oncoanesthesia, critical care, and pain. And I thank all of you, including all the authors and the people from TMC who have worked hard to put together this book. Congratulations and thank you.
I now invite Editor-in-Chief of Journal of Oncoanesthesia and Perioperative Medicine, Dr. Rakesh Garg, Additional Professor, AIIMS New Delhi, to give brief introduction and unveil the journal. Welcome, sir.
Thank you so much, ma'am. Thank you, the Society of Oncoanesthesia and Perioperative Care, for starting first of its own journal, which is Journal of Oncoanesthesiology and Perioperative Medicine. It is led by very eminent editors of all over India, and under the able guidership of or mentorship of Dr. Sushma Bhatnagar and Dr. J.V. Divetia. This journal has been successfully initiated, and we have also received good number of articles, not only from India, but outside India also. And I wish I take this opportunity to request each member of SOAPC and other eminent researchers to submit their valuable work to the Society of Oncoanesthesia and Perioperative Care Journal, which will be first of its journal in the world. And I would request to our chief guest, President Dr. Divetya, Secretary Dr. Raghu Thota, and Organizing Secretary Dr. Josna to unveil the cover page of the journal.
Congratulations, sir. Now, I would like to invite Dr. Sudipto Mukherjee, Organizing Secretary, SOAPCCON, to give vote of thanks. Welcome, sir.
Sudipto has not joined, I think. 1 minute, I just check.
Sir, ma'am, Dr. Sudipta is joining. Some connection issues. Joining in 30 seconds.
Okay.
Dr. Sudipto Mukherjee, welcome, sir.
Good morning, everybody.
Sir, I invite you to give vote of thanks.
Hello, everybody. A very good morning to you all. Greetings from Tata Medical Center, Calcutta. Myself, Dr. Sudipto Mukherjee, the Organizing Secretary of SOAPCCON 2021. It is an honor for me to have been asked to offer a vote of thanks to this esteemed gathering. I'd like to thank Dr. Josna and my team for the opportunity. First, I'd like to thank all the delegates who all have put their faith on us and have decided to join us for this conference. My heartiest thanks to them. Please be with us in next 2 days as it is going to be an excellent learning opportunity for all of us. We are really fortunate to have such an eminent panel of faculties and chairpersons with us, both from different parts of India and abroad. Some have agreed to join us even with a significant time difference. I'd like to thank all of them for sharing their valuable time from their busy schedule with us and to enlighten us with their knowledge, experience, and above all with their wisdom. I'd like to thank the Central Committee of SOAPC for giving us the opportunity to organize this program, and Tata Medical Center, our beloved Director Padma Shri Professor Mamen Chandi, and our Deputy Director, retired General Dr. Sanjay Kapoor, for letting us use the hospital facility for the same. I'd like to thank Meeting and More for creating such an excellent, easygoing platform and accommodating all our requests while organizing or preparing for that conference. I'd like to thank all our sponsors for supporting us for the conference. It will be difficult without your generous support, so thank you. And above all, I'd like to thank God for keeping all us safe during this pandemic. On behalf of the organizing committee, SOAPCCON 2020, and again, I'd like to welcome you all for the next 2 days of academic extravaganza. Let us be part of an emergence of a new subspecialty, that is onco anesthesia and perioperative care. Thank you. God bless you all.
Thank you, sir. I would like you to stand up in respect of national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
This concludes our inaugural ceremony. We would be starting a scientific session at 11:30 in Hall A. Thank you all. Good morning, everybody. Let's start our first scientific session of the day. I would like to invite the chairperson, Dr. Jayashree Sood and Dr. Sushma Bhatnagar. Dr. Jayashree Sood is chairperson, Institute of Anesthesiology, Pain and Perioperative Medicine, Gangaram Hospital, New Delhi. Dr. Sushma Bhatnagar is professor and head, Onco-Anesthesia, Pain and Palliative Medicine, IRCH, AIIMS, New Delhi. Welcome, ma'am.
Thank you very much. Thank you, Ina.
Thank you.
It's going on really well.
Thank you, ma'am.
Congratulations, Dr. Krishna. So now we will start the session. Dr. Jayashree, you are here?
She's joining. She got disconnected. She's joining.
Okay. So we will start the first lecture with Dr. Divetya. I think Dr. Divetya is well-known figure in all over India and in the globally. He is professor and head of the Department of Anesthesiology and Critical Care and Pain at Tata Memorial Cancer Center, Mumbai. He is also a very favorite teacher of our students for DM Onco Anesthesia. So our students are really overwhelmed with this teaching as well as his examinership. The way he takes the exam, he is teaching, he is giving knowledge, and he is very, very empathetic to the students. He has received many honorable awards and achievements. He is president, Society of Onco Anesthesia and Perioperative Care, the society which the conference we are organizing. He is past editor-in-chief of Indian Journal of Anesthesia, past president of All India Difficult Airway Association. He is also past president of Indian Society of Critical Care Medicine, and he has published over 145 publications. So we can start with Dr. Divetya's lecture.
Thank you very much for inviting me to speak at this SOAPC meeting and on this topic which has engulfed the world and which has occupied our minds and hearts for the last 1.5 years. I will be speaking on the COVID-19 pandemic and onco-anesthesia. Now, we all know that we are dealing with a pandemic which was declared by the WHO in March 2020. And as of 23rd September 2021, globally, there are 231 million cases of confirmed cases of COVID-19 and 404,734,000 deaths. And in India, we've had 33 million cases and almost 4.5 million deaths due to COVID-19. So we are still in the grip of this pandemic. And as persons working in onco-anesthesia, we need to understand what are the implications of cancer and COVID-19. So COVID-19 may make cancer patients both more vulnerable to catch the infection as well as more vulnerable to develop severe complications and severe disease. And that's because cancer patients are often elderly. They have comorbidities, especially smoking, heart disease, COPD, respiratory disease, all of which we know predispose non-cancer patients with COVID-19 to severe complications. Cancer patients may be immunosuppressed because of chemotherapy and other sort of drugs that they receive for cancer treatment, which also result in decreased physical function and cognitive function. Treatment-related toxicities can also complicate matters when COVID-19 is also they catch COVID-19, and patients who have been previously treated for cancer can also have cardiovascular, renal, or respiratory insufficiency, which can get aggravated or exacerbated when severe COVID-19 develops. So what is the mortality with cancer and COVID-19? Are cancer patients more likely to die if they catch COVID-19? So there was this study in the United States, a multi-center study of over 2,000 adults, 112 had cancer treated within 1 year. Mortality was almost 54% in the cancer patients versus 34% in others. And in a multivariate model, the active cancer was associated with a 2-fold increase in mortality. So that seems to be the case. Which cancers are more likely to develop complications? It is suspected that hematological malignancies may be more prone to develop severe disease and more mortality. However, in this large study of 800 patients from the UK, with COVID-19 and cancer. Half had mild disease. The mortality was 28%. So again, quite high, not maybe as high as was seen in the previous study, but 28% mortality. But active cancer treatment did not adversely affect survival related to the virus in patients with cancer and COVID-19. So at least in this study, presence of active cancer treatment, chemotherapy, did not adversely affect survival. In our own hospital, there's been published data of 230 patients on active systemic therapy. And of these, majority of them had mild disease and about 11% had severe disease. And 23 patients died, that's 10%, which is a little less than what has been reported in some of the other studies. But again, in this study, hematolymphoid malignancy, as opposed to solid tumors, did not predict for increased mortality. And what mortality depended on was the stage of cancer. So advanced cancers being treated with palliative intent, uncontrolled cancer status, severe COVID-19 infection status were predictors of mortality. Now, India had the first case in January 2020, and a lockdown was declared in the third week of March. And there were two sort of parallel things running here. One was the COVID pandemic, the viral infection, and the other was a lockdown. And between the two of them, it created a massive socio-economic upheaval, massive social, political, and economic consequences, but also for cancer treatment. Patients delayed coming to hospitals for cancer, they delayed going to seeking medical help. Even if they wanted to seek medical help, the lockdown made it difficult for them to reach their healthcare centers. And there was therefore a tremendous impact on the delivery of cancer care and access to cancer care during the pandemic and the lockdown. During this, this was a unique situation. None of us had ever faced a pandemic before. This disease was new to us, and we had very little information and very little to go on, except maybe have some references based on previous coronavirus pandemics of SARS and MERS and so on. And based on the best available evidence at that time, our professional societies, the ISA, the All India Defibrillator Airway Association, the ISCCM, came out with guidelines along with the Ministry of Health. They came up with guidelines to help us cope with this disease, to help us give us some information and some guidelines on managing these patients. The Society of Onco-Anesthesia and Perioperative Care also brought on an advisory on the management of oncosurgery during the COVID-19 pandemic. And essentially what we said was that the risk and benefit analysis should be done. And this analysis should take into account not only patient safety, but also the safety of the healthcare workers. So because that was a major issue, the fear of contracting COVID-19 in the process of delivering care to our patients, right? Now for cancer surgery, which although we may say is elective, but it is often time sensitive and essential to treatment, and failure to operate in time can make a operable or a curable disease inoperable and incurable. And therefore, there has to be some sort of prioritization of cancer surgeries. And of course, what to do, what not to do will depend on the available resources and institutional policies. Of course, emergencies should be attended to, but many institutions did take the route that major surgery, which was sort of not very curative, or like taking a chance, doing major surgery, occupying beds for non-COVID work, occupying ICUs, consuming oxygen for non-COVID work may actually be a problem. And especially during the second wave, many hospitals chose not to do even cancer surgery. Not our hospital, because ours, Tata Memorial Hospital, is a dedicated cancer center. But many hospitals chose not to do any elective cancer work and chose to conserve all their hospital resources for COVID patients. Head and neck surgery is a big part of oncosurgery and oncoanesthesia in India. And dealing with the airway is a higher risk of potential exposure to COVID-19. And therefore the SOAPC also brought out advisory especially for head and neck surgery, where we advocated that doing a airway examination from a distance with PPE and using video laryngoscopy as much as possible, even in cases which otherwise we might have done awake fiber optic intubation. We are now saying that try, and you may get away with a difficult airway with a video laryngoscope, right? when you're doing tracheostomies or you're sending patients out of the OR with tracheostomy tubes or endotracheal tubes, you need to make sure that some adequate barriers are in place to prevent the secretions from contaminating the environment and the healthcare workers around. Now, the combination of the pandemic and the lockdown brought about a huge reduction in the availability and access and delivery of cancer care. And this was a very nice study from 41 cancer centers belonging to the National Cancer Grid. And what they did was they compared the work done in 1919 and the work done in April and May, which is the height of the lockdown in 2020. And what they found, there was a 47% reduction in hospital admissions, 63% reduction in major surgery, and 70% reduction in minor surgeries. And apart from surgery, all the other modalities, whether they were diagnostic modalities like CT scan, MRI, pathology, or radiotherapy or chemotherapy, all modalities of cancer care had taken a big hit, and there was a huge reduction in the amount of cancer care delivered. Now, in our own hospital, we found that the number of registrations in 2020 came down from 44,000 in 2019 to 26,000 in 2020, a 35% drop. Preventive oncology, 59% drop. Second opinion cases, 46% drops. Number of theaters between March and December 2020 were cut down overall by 26%. So there was almost a 25% loss of operation theaters in Tata Memorial Hospital. The number of surgeries fell by 43%. And the number of surgeries in ACTREC also fell by 24%. So there was a huge reduction in the workload in Tata Memorial Hospital as well. In our own department, apart from the surgical workload, we found that the pre-anesthetic checkups, both in the general and the private clinic, dropped by 30 to 40%. Pain references, the work in the pain clinic dropped from 40 to 50% in general and private, and radiotherapy, outpatient anesthesia fell by 56%. So even our workload was significantly reduced. And major area was concern was how the staff were affected either by infection or by the need to quarantine because they were close contacts of people who had got infected. And what we found was that, the doctors, both the surgical as well as the anesthesia consultant and residents, about 8% had got an infection. Nurses in the main OT, 11.5% got the infection. In the COVID ICU, 16.6% nurses were infected as opposed to 9.5% in the non-COVID ICU. Very interesting, despite the fact that these nurses had access to all the personal protective equipment. The technicians and ward boys in the operation theater had a very high, 19% and 24% of these actually got the infection. And because some people got the infections, others had to be quarantined. And cumulatively, because of infection and quarantine, we lost almost 10 years of work days. Of course, we didn't lose 10 years of work because many of them were concurrent, but we did lose a lot of work days because of these sort of things. Fortunately, none of our staff, all our staff survived. So that was the good side of this. Now, in spite of all this, surgery, of course, went on, and we were concerned about what are the outcomes of surgery. The early experience from China was not encouraging at all. 34 asymptomatic patients who subsequently became COVID positive, and they all suffered from post-op COVID pneumonia, and 44% of these required ICU admission and 20% died. That was not good news at all. 20% post-op deaths in patients is not a good news at all. Here, a bigger series of over 1,000 patients with a positive RT-PCR, some of them before surgery, and most of them soon after surgery. Again, the mortality is very high, 24%, and pulmonary complications is 51%. And again, a meta-analysis found that the post-op mortality in COVID patients globally was 20%. So surgery in patients with COVID-19 doesn't seems to be associated with a very high mortality. And we had a similar experience in TMH. These were 62 patients who tested positive. Now 48 tested preoperatively, and therefore, except one emergency surgery, none of them were operated, but 14 patients were operated but tested positive in the immediate postoperative period, right? And out of these, 2 died. So overall, the mortality in patients who tested positive in the immediate peri-op period was 13%. So little less than the others, but still 13% is a very high mortality. On the other hand, when you looked at elective surgery in patients who did not have COVID-19, so these were 494 patients in 2 months in 2020. Most of them were untested because we are not doing routine testing, but they were being screened for symptoms and so on. And 117 tested for COVID before surgery. These were all COVID negative and symptom negative patients. And all of them, most of them underwent very major surgery, including Whipples and commandos and gastrectomies and so on. There were no deaths, and the incidence of major complications was 5.6%. So we had a reasonably good outcome, and we concluded that, that elective cancer surgery should not be deferred just because there's a pandemic going on. With due precautions, both for the staff and for the patients, they can be safely managed. Anesthetic techniques were modified as per the standard sort of norms and guidelines circulating at that time. I will not go into much detail except to say that video laryngoscopy got a massive boost. Aerosol boxes came and went. Nasal installation of betadine also came and went. And plastics, which we were trying to get rid of and become more eco-friendly, made a major comeback into the operation theatre. Okay. And now what we have sort of now come to realize after 1.5 years into the pandemic is that COVID is not just an acute illness and it's not just a respiratory illness. There is a post-acute COVID phase which can go on for up to 12 weeks. And then there's a post-COVID-19 syndrome which can go on for months after that, during which time patients have multi-systems can be affected. And these could be, cognitive defects or memory loss or something like that. Or there could be an endothelial dysfunction persisting in the form of thrombogenicity, thromboembolism, myocarditis, renal dysfunction, pulmonary function tests may be abnormal, exercise tolerance may be reduced, patients may have persistent cough and breathlessness. They can have elevated D-dimers, and we don't know the significance or the implications of that, but that is not an uncommon finding in patients who have survived COVID. Patients have diabetes, develop diabetes, or they develop hyperglycemia without overt diabetic features. So there are lots of symptoms and problems that can persist even after the patient has otherwise recovered from COVID and cleared his virus. And therefore, these patients who have survived COVID need to be assessed for long-term effects, both psychological and neurological, as well as those related to the cardiovascular system and the respiratory system. Now, this was and what we are now seeing is many survivors of COVID are now coming up for cancer surgery, either because their surgery was initially deferred or because patients have contracted cancer having had COVID sometime in the past. Now, this was a very nice study which gave us some guidance as to what is the optimum time after COVID when patients should be operated. And this study suggested that there should be at least a 7-week delay after the onset of COVID symptoms before elective surgery is undertaken, right? So in other words, you should wait for 7 weeks from the onset of COVID-19 before you do it. And if you wait that long, then the mortality is not high if the patient is asymptomatic, right? So patients should be asymptomatic and they should be 7 weeks post COVID. If you operate earlier, then the incidence of complications seems to be higher. Now, we did a study in TMH and ACTREC, and what we did was we did a retrospective study of COVID recovered patients who are undergoing elective surgery. These were diagnosed to be COVID positive between April and November 2020, and we looked at the mortality and complication rate in these patients who subsequently underwent surgery. There were 206 patients, and what was interesting is that almost all the patients, most of the patients had mild disease. They did not even require oxygen, and many were asymptomatic, right? However, 6 patients required oxygen, 4 required mild oxygen therapy, and 2 required high-flow nasal oxygen or non-invasive ventilation. 6 patients required oxygen. They were WHO severity scale 4 and 5. Okay. Now, they were distributed across the various sites, and interestingly, we did a number of cases who were 3 weeks from the onset of COVID, so of COVID diagnosis, right? So Most of the patients were in fact started at 3 weeks and went up to beyond 7 weeks. And there were no deaths. So this was a remarkable finding, at least in this cohort. For that period, there were no deaths. Intraoperative complication was seen in 4 patients. One was blood loss, so we will not really link it to the fact that the patient had COVID, but 3 other patients had cardiac or respiratory complications during surgery. And very interestingly, all 3 of them had a COVID score of 4. So all of them had received oxygen when they had COVID-19, and they were associated with cardiorespiratory complications as detailed over here. Now, morbidity was also seen, but again, it was not prohibitively high. It was seen in overall 20% of patients, and cardiorespiratory complication was seen in only 10% of patients. Now, we tried to see, okay, the numbers are small, so we don't really have a clear idea at all. But what does seem to be that when the COVID severity was 4, we had 4 patients who had a COVID of 4 and 2 who had a severity of 5. Now, these are the patients who had the maximum intra complications. Okay, so there may be that we may subsequently, once we see more data, it may be that those who receive oxygen or receive more than oxygen therapy during COVID may be more prone to intraoperative complications, but this is just a wild guess as of now. Based on all this and the literature that is existing, we have made a sort of protocol for pre-op evaluation, and that includes a chest X-ray. Patient should be asymptomatic, a chest X-ray, ECG and tropi levels in all patients, and a 6-minute walk test. HRCT and blood gases and echo, depending on certain sort of patients and depending on what they had during COVID and their other comorbid conditions. What we also believe is that the ASA grade may not just be good enough to risk stratify COVID patients, because they don't take into account the functional impairment after COVID, and maybe a score like the ECOG score may add this functional element to this classification of risk. And so even in ASA 1 or 2 patients, if they're ECOG 2 or 4, then 2 to 4, then they may actually identify patients at higher risk. What about intensive care outcomes? So in our own intensive care unit, we had 127 adult patients with cancer, 30 hematological, 97 solid tumors, 30-day mortality 47%, 67% in ventilated patients, and no difference in hem-onc patients versus solid tumor versus post-op patients. So again, the same sort of trend that hem-onc doesn't seem to be necessarily contributing heavily to mortality. The only thing, the only parameter which actually predicted mortality was the change in organ failure, the SOFA score. If it increased from day 1 to day 3, that predicted mortality better than any other sort of parameter. And we wanted to see how our mortality was compared to global mortality. And therefore, we did this systematic review and meta-analysis and published it. And here we found that, in 28 studies of patients with cancer and COVID admitted to the ICU, the mortality was 60%. And we believe this was not prohibitively high. And just because a patient has COVID and he also has cancer should not be a reason to deny him intensive care. And these patients should be admitted to intensive care on an individualized basis, taking into account the stage of cancer, the response to treatment, and the potential of cure or palliation of the cancer. So thank you very much for listening. I just want to end by saying that we've always been there for our patients. Patient safety has been very close to our heart. But in these difficult times, we have learned that we must be there for each other. And we must look after our health as our safety as a priority. We owe to ourselves and our family. And if we are healthy and if we keep ourselves safe, then we can continue to serve our patients, right? So take care, stay safe, get vaccinated, and thank you very much for listening.
Thank you very much, Dr. Divetya, for summarizing it so well. 1.5 year struggle, you have summarized it really well. Now I request we will take question answer at the end. Meanwhile, I'll request Dr. Jayashree Sood to introduce our next speaker, Dr. Vijaya. Dr. Jayashree, please.
Yes, good morning. And thank you, Dr. Divetya, for that excellent lecture. It's my pleasure to introduce our next speaker, Dr. Vijay Gotumukula. He is the professor, Department of Anesthesiology, Pain and Perioperative Medicine. He's also the associate head of the Institute for Cancer Care Innovation at the University of Texas at the MD Anderson Cancer Center, Houston. He has several achievements. He is the Vice President of the American Society of Enhanced Recovery, as well as he is the committee chair of the Texas Society of Anesthesiology of the Scientific and Education Committee. Dr. Vijay is going to speak on a very important topic, and that's the enhanced recovery programs in cancer care. This will be very interesting because of the enhanced recovery that we are following in other areas, and surely for onco patients also, it's very important. Dr. Vijay, please.
Us will benefit from mutual sharing of ideas, discussions, and research programs and protocols. I have no relevant financial relationships which will have any bearing to this presentation today. But however, I would like to dedicate this talk to all patients with cancer and their caregivers. They demonstrate so much courage, strength, and hope that it is an inspiring factor that pushes us every day to do our best to improve outcomes for our patients. So over the next 20 minutes, I'll briefly discuss cancer epidemiology and perioperative implications, overall strategies to improve oncological outcomes based on the best evidence we have to date, and what enhanced recovery programs have a role to play in these efforts. It's estimated that by 2030, across the world, there's going to be a 50% increase in the incidence of cancer and a 60% increase in mortality. We also know that in patients with cancer, 1 in 9 will recur, even if they have a margin-free resection in the first instance, and 2 in 9 patients are at risk of developing a second cancer. In addition to the mortality and morbidity that all these major cancer surgeries have, our patients go through tremendous other significant medical and financial burdens. While all this sounds gloomy, there is a ray of shiny hope in that, at least in the Western world from the 1990s, we have seen a gradual fall in the rate of cancer-related deaths. Now, what all of this means is that the cancer survivorship is increasing. So it's estimated that right now there are over 20 million cancer survivors in the US, about 2/3 of whom live for over 5 years, and 15% live for over 20 years. However, cancer survivorship does not mean cure from cancer. It is just that we have the cancer under control, that most survivors have a reasonable quality of life. However, they're always at risk of developing a recurrence or second cancer. And in addition, they will also need our services for non-cancer related surgical care. So if you really look at what is the surgical need or the procedural need on patients with cancer, it's estimated that over 50% of all patients with cancer will need our services during their stay in the hospital for any acute care needs. So overall, it's estimated that by 2030, over 45 million cancer operations will be needed across the globe. So what this means is that no matter where in the world you practice and what kind of a setup you practice in, for anesthesiologists and perioperative clinicians, it's becoming critically important that we understand the special needs and challenges for patients with cancer, whether we take care of them for their cancer care needs or even for their non-cancer procedural and surgical care needs. The interest in this topic of how we as anesthesiologists and perioperative clinicians can improve outcomes for our patients with cancer has started with the publication by exadactylists from Ireland, where they showed that women who have mastectomy under a paravertebral block had about a 17% overall better survival up to 3 years compared to women who have mastectomy under volatile opioid techniques. So the hypothesis here was that by attenuating the surgical stress response and thereby the opioid needs in patients who undergo regional anesthesia, this could result in a perioperative immune modulation, thereby decreasing the risk for local regional recurrence and therefore enhance survival. So over the last 15 years, there have been scores of retrospective and observational studies which looked at the association between regional anesthetics and oncological outcomes. However, there have been only 2 randomized controlled trials which have been done on this topic, and there have been a further 2 or 3 post hoc analyses of other randomized controlled trials which were done to look at relationship between regional anesthesia and improved survival. Unfortunately, none of these randomized controlled trials or post hoc analysis of previously conducted randomized controlled trials have conclusively shown that regional anesthesia or analgesia during the intraoperative period has any causality to improving oncologic outcomes. So absence of evidence is not evidence of absence. This is an exciting theme for anybody, any physician taking care of patients with cancer, because there is tremendous work that's being done across the globe in basic science, translational sciences, and clinical research programs to better understand the biology of cancer in the perioperative period, and if we can do anything in our care pathways to minimize the risk for recurrence and improving survival. The other question each one of us have to ask ourselves is, are we looking at this question the wrong way? We know that perioperative care is a multimodal, bundled intervention. And cancer being such a complex topic with significant variation and heterogeneity in the biology of cancer between different patients and the effects of neoadjuvant therapies and adjuvant therapies on cancer outcomes, and how either cancer or cancer therapies influence the physiologic function of the patient, thereby making these patients at a higher risk for perioperative complications and hence impacting outcomes. So as you can see, this is such a complex topic that if we're looking at one single anesthetic intervention during the perioperative care journey, whether it's regional anesthesia or opioids or anesthetic agents, making a dramatic improvement in cancer outcomes, maybe we are fooling ourselves. So we have to rethink at how we look at the question and what is our main goal in trying to improve outcomes for our patients. So it's very unlikely that any single intervention will make a remarkable difference in long-term outcomes for patients with cancer. And particularly when it's coming to surgical or procedural care, we need a comprehensive perioperative approach. And what is that approach? That approach, in my mind, right now, until we have further evidence on the effects of anesthetics and anesthetic strategies on oncologic outcomes, we have to focus our care pathways, our care paradigms on enhancing functional recovery for our patients and minimizing perioperative complications. And why is this important? As each one of you know, cancer patients are unlike any other patients. Say, for example, if you have a patient who comes for hip replacement, once the hip replacement is done and they're discharged from hospital, they undergo rehab, and for the most part, they're done with that primary complaint. However, patients with cancer, even though they have a margin-free resection and are discharged from the hospital, they still are under surveillance for either a recurrence or a second cancer. And more often than not, they have to have adjuvant therapies and they have to have ongoing cancer therapies. God forbid they have a second cancer. So it's all the more important for patients with cancer that when they come for a surgical intervention, we focus our efforts on getting the patient back on track to their baseline functional status as safely, as efficiently, and as quickly as possible. Because the significant factor which improves oncologic outcomes in patients who have had surgery is their ability to undergo adjuvant therapies. For most patients with solid tumors, that is usually in the cancer care plan. And there is enough evidence from breast, hepatic resection for colorectal malignancies, Whipple's procedures for pancreatic adenocarcinomas, and even after lung surgery, that having the patient initiate and complete their planned adjuvant therapies within 60 days or starting at 60 days significantly improves outcomes for our patients. And if you look at why patients in the post-surgical period are not able to undergo adjuvant therapies, the single most important factor is postoperative complications and their inability to tolerate adjuvant therapies. In addition, there is also enough literature in the same patient population in breast cancer, lung cancer, pancreatic cancer, and colorectal that, again, there is a direct correlation between postoperative complications and poor survival. So the question then becomes, can enhancing functional recovery and minimizing perioperative complications improve cancer outcomes? We at MD Anderson initially coined the term RIOT, which is Return to Intended Oncologic Therapy. And it was our belief that RIOT should become a quality measure for all surgical programs with solid tumors. And what we found that at baseline, 87% of our patients at MD Anderson coming for hepatic resection for colorectal cancers have undergone adjuvant therapies at about 34 days. However, after instituting enhanced recovery program, we've seen that 95% of our patients are able to get back to an adjuvant therapies in about 21 days. So a significantly higher percentage of patients are able to get to their adjuvant therapies at a much earlier time than the baseline. So now we are in our next phase of this research protocol to see if this indeed is going to make a significant impact on cancer-specific survivals. Similarly, at our institution, we also found that instituting enhanced recovery programs in our thoracic surgery patient population, there is a definitive decrease in the number of complications and a significantly higher number of patients in that cancer disease site are also able to get back to their adjuvant therapies at a much higher rate and at a much earlier time. At University of Virginia, Dr. Hedricks and her colleagues have found that in a multivariate model, the single most important factor for patients with colorectal cancers in their ability to get back to adjuvant therapies were for these patients to be enrolled into enhanced recovery programs. Now, would all of these enhanced recovery programs show any benefit in terms of 5-year or overall survival in patients with cancer? The only study to date is a retrospective observational study from Dr. Lundquist on his group, and where they have shown that adherence to an enhanced recovery after surgery protocol is associated with a 5-year survival after colorectal cancer surgery. So we have seen so far that minimizing postoperative complications, enhancing functional recovery would offer the patient the best chance to get back to adjuvant therapies when adjuvant therapies were in their planned cancer care plan. While to date, we have no randomized controlled trials to show any specific anesthetic technique or strategy improves cancer-related outcomes, there is a lot of emphasis on focus on minimizing postoperative complications and enhancing functional recovery. So in reality, the hierarchy of factors which affect patients' improved oncologic outcomes are cancer biology, patient-related factors, surgeon skill, and perioperative care. While we don't have any control on cancer biology and surgeon skill, we can improve preoperative patient's condition in the allowable time to the best of our abilities to minimize the risk of postoperative complications, and we can tailor a perioperative care plan to enhance functional recovery. So how would this look like? We have to focus on medical optimization and rehabilitation in the appropriate patient. We have to minimize surgical stress, minimize oxygen debt, minimize perioperative complications, institute rapid rescue processes of care in our individual hospitals. And when we do all of this, there is a higher chance that the patient can get back to their baseline or close to baseline functional status and thereby be in a best state to start and complete their planned adjuvant therapies in a timely manner. So this will give our patients the best chance for improved oncologic outcomes. But importantly, we anesthesiologists and perioperative clinicians have to earn our place in being an effective member of the multidisciplinary cancer care team. How would we do that? We would do that by earning the trust and respect of our oncologists, by showing a dedication, commitment, and passion to improve outcomes for our patients with cancer. And we have to really institute educational programs in our core curriculum for residency training programs across anesthesiology and perioperative care and in our fellowship, so that our trainees have a better understanding of cancer biology and the effects of cancer and cancer therapies on patient outcomes. We also have to become more actively engaged in cancer prevention and screening programs, have to invest in research related to improving cancer outcomes, embark on enhanced recovery pathways to improve perioperative care, and continue with our educational efforts for providers across all spectrum of experience and training so that our colleagues are more informed about cancer biology, cancer therapies, and their effects on patients. So coming to research opportunities, we know that no two patients are the same and no two cancers are the same. So when we design research protocols, we have to be aware that each of the trials have to be done in specific cancer disease sites. And we also have to realize that based on the stage of the cancer, the 5-year survival rate is going to be different. So this becomes important because if we take any high stage cancers, because the mortality is going to be so high, the effect of your intervention has to be so dramatic to show any significant changes in outcomes. On the other hand, if you pick cancers with a lower stage, their 5-year survival is going to be so high that, again, to show a statistically significant difference, you'll have to really look at a very large number of patients or follow the patients for a very long time, which is not feasible. For two reasons. Number one, the financial implications. Also, number two, because surgical and perioperative care is moving at a very fast rate. And with advances in technology, drug delivery, and our better understanding of perioperative period, we are getting better in taking care of these patients over a period of time. So we have to pick a cancer disease site and the stage in which we can clearly show a significant effect on improving outcomes in a rather relatively short period of time with a practical application of financial resources. So this becomes very important as we plan our future research protocols. So in conclusion, I would like to share with you that for us to have a significant improvement in outcomes for our patients, we have to become part of the multidisciplinary cancer care team. And number two, all our efforts have to be focused on minimizing postoperative complications, enhancing functional recovery, and getting the patient back to their baseline or close to baseline functional status as quickly, safely, and efficiently as possible, with the goal being back to home, back to family, back to therapy, back to work, back to life, and back to self. So with that, I'd look forward to an engaging discussion at our question answer session and wish you all a very successful meeting and have a good day. Thank you very much.
Thank you very much, Dr. Vijay. That was an excellent lecture. I love the slides as well. And of course, we'll have the discussion at the end. Will you be introducing the next speaker?
Yes, thank you, ma'am. Thank you very much. So our next speaker is none other than, we all know, our Dr. Bernhard Reddy. Dr. Bernhard and Dr. Vijay, they are the two people the most absolutely a friend of development of onco-anesthesia in India. I think they have both of them have played a great role in development of palliative care, onco-anesthesia in India. Dr. Bernhard is current designation is Professor, Director of Department of Anesthesia, Perioperative and Field Medicine at Peter MacCallum Cancer Center and the University of Melbourne, Australia. He is there are multiple awards and achievements he has received. His research interests have improved the understanding of perioperative factors that contribute to complications following major surgery, with the strategy for enhanced risk stratification, including measuring functional capacity with cardiopulmonary exercise testing and pre-operative optimization, including rehabilitation with exercise therapy to reduce complications after surgery. So everyone is working hard, and Dr. Bern, that how we can minimize complications and expedite patients' recovery so that they can go home. And Dr. Bernhard has played a vital role in this. His research has played an important role. Specific to the field of onco-anesthesia, Bernhard research collaborate, investigate the interaction of perioperative adrenergic inflammatory responses and anesthetic technique on tumor progression, signaling on the potential long-term post-operative complication and cancer recurrence. So Dr. Bernhard, please go ahead. Thank you very much for accepting our invitation.
Thank you, Dr. Shushma. It's exciting to join you, and thank you for the kind invitation. I'm going to share my screen with you. Can you see my slides?
Not yet, sir.
We can't see them, Dr.
Do you see slides now?
Yes, sir.
Yes, we can see now.
Fabulous. Let me just put it on PowerShare. Perfect. Thank you. Right. So I've been asked to talk to you about the risk stratification and specifically cardiopulmonary exercise testing, and then optimization and specifically prehabilitation. And it really dovetails nicely into the lecture that Dr. Vijay Gaudamakala just delivered, which was fantastic. And it's about the emphasis on trying to return our patients to intended oncologic therapy. Greetings from Australia. I have no conflicts of interest in this space. And the top right-hand corner is Peter Mack. All right, so let me firstly give you just context to this lecture, and Vijay has done an excellent job. But basically, we are in the game of quality improvement and trying to continually improve medicine. And we can see that anesthesia has become extremely safe. We function at a 6 sigma level. That's basically there's about 3 events in every 1 million episodes of care in terms of mortality. But the sad reality is the surgical journey functions at a 3 sigma level. And so if we say 6 sigma is like an airline pilot, 3 sigma level is roughly at the level of baggage handling. And that's the sad reality of medicine and surgical journey is we've got to try and reduce complications. So let me back up that statement. Well, first of all, mortality after surgery, within 30 days after surgery, is regarded as the 3rd most common cause of death, second to ischemic heart disease and stroke. And so post-operative complications and mortality are a major concern. Now, here we see the NISQIP database, and these are just different types of hospitals ranked on their mortality. But what we can see is they all suffer the same incidence of complications. When it's in terms of all complications, we can see that there's roughly 1 in 4 patients that suffer all types of complications. 1 in 6 patients suffer major complications. And then in a recent study known as the METS database study, which was a cardiopulmonary exercise testing study in abdominal surgery, 1 in 7 patients suffered complications. Now, Vijay highlighted well how the riot is an important sort of key performance indicator for us. We need to understand that about 25% of patients fail to achieve intended oncologic therapy in a timely manner. And the key drivers of those are poor functional status and frailty. And poor functional status is also a major driver of complications. And if you don't achieve your chemotherapy, you have a high incidence of subsequent cancer recurrence and mortality. Complications also drive, you can see as the number of complications increase, they also drive the length of stay in hospital, and as the consequence, the expenditure associated with the care. So now that we know that there's context to why we need to risk stratify and optimize our patients, let's focus on a dynamic risk assessment. So, and I'm going to specifically focus on cardiopulmonary exercise testing. This is a study of esophagectomy, and what we can see is as your functional capacity declines on the x-axis to the left-hand side, that the proportion of black, which is complications relative to each of those groups, increases. So the number of patients who suffer complications in the poor functional capacity is increasingly higher. And here's a recent paper published this year by West and the Southampton group in the UK, where they show that cardiopulmonary exercise testing has greater prognostic value than sarcopenia in patients having esophagectomy. And here we can see the Kaplan-Meier survival curves, where it's been dichotomized at an anaerobic threshold of less than 11 mils per kilo per minute or greater than 11 mils per kilo per minute. So functional capacity has been shown to be a risk, a significantly strong risk predictor. Here, the receiver operating characteristic curve is 0.83 for an AT of less than 11 or greater than 11. And if your AT is below 11, the odds ratio for subsequent complication is 7.56. We did a meta-analysis where we looked at that same dichotomous factor of taking anaerobic threshold below 11 versus above 11. And what we can see is that the incidence of complications, infection, wound dehiscence, pulmonary complications, cardiovascular complications, and GI complications are 3 to 5-fold higher in those patients that are deconditioned. This is some of our own major abdominal surgery, predominantly pelvic exenterations, but we can see that patients who are functionally fit, peak VO2 greater than 710 per square meter of body surface area, or they have a normal VE/VCO2. So VE/VCO2 reflects VQ matching in the lung. We can see when both of those are regarded as normal, they have a good 2-year survival curve. However, when one of those factors is abnormal, that's the red line, and when both factors are abnormal, that's the green line. And so they have more than 50% mortality within about 1 year after surgery. This is the METS database. We can see that the functional capacity is a risk predictor. So it was a prospective randomized study of 1,400 patients done multi-center across a number of countries, Australia, Canada, etc., in the UK, where they looked at markers of functional capacity to see whether they could identify the risk of postoperative complications. And what we can see is that the Duke Activity Score Index, the DASI, and BNP were predictors of cardiac mortality and death within 30 days. However, when it came to predicting complications after surgery, and these are the factors that determine whether a patient riots or not, a robust predictor was actually cardiopulmonary exercise testing. It was the anaerobic threshold and the peak VO2 that was the strongest predictor. We subsequently took the data and reanalyzed out of that METS database and did a sub-study. And what we looked at is we looked at the Duke Activity Score Index, which has got 12 questions, and said, which of those 12 questions are the most important? And what we found is that there were 5 questions that were independent risk predictors of having a functional capacity of less than 16 mils per kilo for peak VO2, as well as anaerobic threshold of less than 11. And so what we've now created is a tool that becomes an efficient triage tool that we can then refer patients that score low in these questions to cardiopulmonary exercise testing laboratories. And so when we added in the purple here a dynamic assessment on top of those 4 static questions, we can see that heart rates, the ability to mount a chronotropic response, it was added sensitivity to the 4-question questionnaire. And so using this triage tool, we can now identify patients that should be worked up further with cardiopulmonary exercise testing or a 6-minute walk test. So can we optimize these patients? Well, as Vijay highlighted, for perioperative medicine, it's an important part of oncoanesthesia. We need to focus on 2 components. We need to focus firstly on reducing clinician variability. That's ensuring that there's enhanced recovery after surgery pathways. But we also need to focus on reducing the modifiable risk of the patient, and that's the prehabilitation aspects. And then accordingly, adapt our peri-op pathways and peri-op management. So we've got to triage our patients to CPET clinics or 6-minute walk tests. We've got to prehabilitate them. We've got to educate our patients to be part of the surgical journey. And for the severely or debilitated patients, some of them need a shared decision-making clinic and understanding whether surgery is the right aspect for them. And then we need to support our patients through the intraoperative, but also into the postoperative period. So if we don't have access in HDU ICU, some patients shouldn't be on the ward. And so what we create is an extended recovery unit where we can run some noradrenaline to support blood pressure, etc. Create high acuity teams. So these are perioperative medicine teams that can follow patients up in the post-op period. The ERAS pathways Vijay's talked about significantly, and this is a cardiac risk or it's Lee Fleischer's work out of UPenn, and basically it's the risk of complications after cardiac surgery, where the anesthesiologist, you can't see any outlier. There were some surgeons that were outliers to the right-hand side in terms of higher complication rates and mortality, but it was the institutions, it was the pathways that were the significant component. And that's the whole aspect of enhanced recovery after pathway, is to line multidisciplinary teams. So what about prehabilitation? It's about enhancing the functional capacity of the patient to withstand a stressful event. It's about building resilience, minimizing the response, and increasing the recovery to the surgical insult. And so schematically, we can see standard of care is the gray line, where patients in the preoperative phase undergo a surgical insult. They may dip below the line of complications and mortality, and then they have a slow trajectory of recovery. Where in the purple is prehabilitation. It's about improving the resilience, minimizing the surgical response, and increasing the recovery phase. It's got to be multidisciplinary. It should not just focus on exercise, but it should focus on other aspects such as psychosocial, cognition, nutrition, etc. And so we address this in our preoperative clinics. We identify those with modifiable risk. We identify those who've got reduced functional capacity, who have alcohol or smoking, that need smoking and alcohol cessation, those with respiratory risk, anemia, nutritional impairment, psychosocial aspects. We try and bring our patients along with an educational component, for example, surgery school, help them understand what the ERAS pathway is about, and in severe cases, shared decision-making. We predominantly target the major abdominal surgeries because we know that's where most of our complications occur in the postoperative period. So does prehabilitation work? Well, what I'm going to try and show you is that we can get our patients fitter. Now, Lance Armstrong, who won the yellow jersey, was the poster boy for this, essentially, because we can see he had a phenomenal peak VO2 with chemotherapy decreased significantly down to about 66, but subsequently with his exercise strategy and blood doping, we can see that he improves his VO2 significantly. Now, our patients don't live up in this range. Our patients have peak VO2s of less than 16. And we try and get them above 16 or an anaerobic threshold above 11 to try and improve their outcomes. This work from the Southampton group showed that before esophagectomy, so that the preoperative chemotherapy, the neoadjuvant chemotherapy phase, that there's a significant decline in functional capacity with chemotherapy. But if you implement exercise in that group during their neoadjuvant therapy, that they enter surgery in a higher functional state. So this is some of our data, pre and post prehabilitation assessment of functional capacity. We can see we can improve, and you often have an outlier of patients who's an overachiever. But essentially, we can see that there's a number of improvement in peak VO2s after a prehabilitation program. But we do have to be careful that some patients decondition during that period. So here's an example of cardiopulmonary exercise testing over a series of 3 months. But what we can see is minimal work rate, minimal exercise. With time and improvement of medication and exercise, we can see that the work rate increases and they start delivering significant peak VO2 and CO2 production. And so patients get fitter, entering surgery in a better functional state. And we've published this and basically showed that we can improve the anaerobic threshold and the peak VO2 in the preoperative phase. However, there's a subgroup of patients who don't improve, and we need to understand who they are. And it may be those that have had or have underlying inflammatory responses related to the tumors. Prehabilitation is a significant factor for patients' well-being as well. Here we can see the SF36. The dotted blue line is their baseline SF36, and the purple line is post-prehabilitation. And we can see that patients have significant improvements in pain, vitality, social functioning, emotional well-being if they are prehabilitated. All right, so I've shown you that we can get our patients fitter, that they feel better, but does it improve surgical outcomes? Well, there's a small number of prospective randomized studies out there. For example, this study in major abdominal surgery randomized 62 patients into an intervention with prehabilitation and 62 patients in a control group. And we can see that there was a 50% reduction in complication rates, all-cause morbidity. And so there's a number of these studies that are now out there that are small randomized studies. This one's a respiratory exercise where you can see 48% reduction in pneumonia, but we're seeing in these small studies significant reduction in complications. In a meta-analysis of 21 studies, mostly with less than 100 patients in each of these prehabilitation arms, we can see that there's a significant improvement in the 6-minute walk distance. In the peak VO2, there's about a 2 ml per kilogram per minute improvement. And we showed there's a substantial reduction in length of stay, which in itself will be a surrogate marker for achieving adjuvant therapy in the postoperative phase. There was a significant reduction in pulmonary complications, and there was an insignificant reduction in all-cause morbidity. So importantly, when we assess our patients for optimization and prehabilitation, we need to triage them and do multidisciplinary assessment for functional capacity, for nutritional aspects, and psychosocial aspects. Here, for example, we can see that nutrition given after resistance exercise, that there's a significant increase in protein synthesis. So just underpinning the need for multidisciplinary prehabilitation. So when we refer patients to our prehabilitation clinics, 2/3 of them need exercise, but 1/4 of them need nutritional support, and about 12% need psychological support as well. So how do we improve access to prehabilitation? A lot of surgeons and hospitals will say to you, well, we don't have the ability to access our patients beforehand. Well, this Mike Grocott published this recently in the Perioperative Medicine Journal, and he showed that there was about 62 days between referral from a GP, undergoing cancer optimization or cancer diagnostic workup, as well as surgical processes, neoadjuvant therapy, etc., before they hit a pre-anesthesia clinic. And that is time in which we can triage our patients and use that to identify the high-risk patients and put them through surgery school, a prehabilitation program, etc. So we've got to identify and understand, based on the Macmillan model published in the UK, where the majority of our patients can all undergo universal prehabilitation. They can have educational components around functional capacity, education, being part of a pathway, identifying those that are at risk and putting them through targeted prehabilitation, for example, exercise and nutrition. And in severe cases, we put through specialist prehabilitation, where we try and focus on one-on-one prehabilitation. Now, with COVID, we've learned that there's a significant impact. And so we've had to adapt and adopt tele-prehab. And here's just an example how we've moved our surgery school from face-to-face into a virtual process, but we deliver a respiratory bundle of care to try and reduce our postoperative complications. Tele-prehab is also important, especially here in Australia, where our patients live extreme distances from the main cancer centers. And so engaging with them in a tele-prehab fashion is an important aspect of prehabilitation. When we surveyed our patients, we found that the majority of them do want to be part of a prehabilitation program. And so they want their surgeons and the anesthesiologists to inform them about prehabilitation. Majority of them live in rural areas. They do participate in virtual surgery school, and they prefer to do their exercises at home. And so we have to build and tailor our programs around that. And so this is the future of prehabilitation, where we can use wearables and engage with our patients in their home environment using telemedicine and various apps. And so my last slide, and to summarize this all, this is data that comes out of the UK, where they essentially showed that integrated care pathways, the ERAS pathway, where reduce the clinician variability, has a significant impact in the perioperative journey, with a reduction in cancellations, reduction in complications, 2 days reduction in length of stay, decreased readmissions, etc., but also reducing modifiable risk. Structured risk assessment, prehabilitation of our patients have a significant impact on the perioperative journey as well. And with that, we can allow them to have their adjuvant therapy. Thank you very much.
Thank you, Dr. Barnhart. Thank you, Doctor. It was such a wonderful and concise presentation. Now this session is open for discussion. Dr. Jayashree, before discussion, Madam, would you like to take a few words?
Yes, thank you, Sushma. This was an excellent session. Naturally, because we had such eminent speakers who have worked in this field for so long. And so it was truly enjoyable. Dr. Devetya, your data and the presentation, the statistics of the Tata Memorial has really impressed us, and surely we can learn from your data and do something as well in our own hospitals and see how our progress was. Thank you so much. And definitely we have to be prepared for the third wave, and learning from your lecture, we can see what are the requirements, that how we can make sure which patient to accept and which patient to not refuse for the surgery. I think these points that you elucidated have gone a long way. Iraz, Dr. Vijay, yes, you added so many more things than we usually normally talk about. And truly, this has helped all of us. Enhanced recovery, we talk all the time, but there were so many other things that you talked about, which have really helped us learn a lot. And so also, Dr. Bernhard, your lecture and your research shows how much you have done for this rehabilitation in the onco patients. So Sushma, you can now see, I don't think there are many questions, except there was one question.
There are two questions.
Yeah.
One is for Dr. Vijaya, and
Yeah.
this question is from Dr. Shiv Kumar. Dr. Vijaya, Dr. Shiv Kumar wants to know role of intravenous lignocaine in ERAS program.
Yeah, thank you, Sushma. I think for some reason I'm not able to start my video. Yeah, that's better. So lidocaine, intravenous infusions of lidocaine have become very fashionable, and a lot of people are using it in enhanced recovery pathways, but also otherwise. But the data is very limited. The meta-analysis has consistently shown that perhaps it reduces post-op nausea and vomiting. The opioid reduction effect is only seen in the first 24 hours. But for these effects to happen, we have to continue infusion at least for 24 hours. And at least in the US, we are not able to carry on intravenous lidocaine infusions on the floor for safety reasons. You only have to do that in a monitored unit or the intensive care unit. So practically, most of the folks have been using lidocaine infusions only intraoperatively or stopping in PACU. So with this practice, we are not seeing all the full benefits of lidocaine. So right now, at best, we can confidently say that it reduces post-op nausea and vomiting, and the opioid sparing effects are only for the first 24 hours. Anything to add, Bernhard, from your experience, or Jiggy?
Yeah, so Vijay, I agree with you that the data is limited. It's part of the enhanced recovery pathways, especially in colorectal, and the benefits are really, it's got strong anti-inflammatory aspects. It's got opiate sparing benefits to it as well. There's some very interesting anti-neoplastic properties, but those need to be studied. And partly the VAPOR-C study that we are undertaking at MD Anderson and Peter Mac and across a number of other centers will sub-randomize patients having TIVA versus volatile to lidocaine versus no lidocaine. But those new anti-neoplastic effects warrant further study before we can comment.
Thank you, Dr. Vijay and Dr. Bernhard. There was one comment which is from anonymous attendees in 2021. Has the admission come back to pre-pandemic levels? So I think the answer is we cannot say that where it has come back to normal or where it has not come back, because every hospital has a different protocol and policy. But as far as the AIMS IRCH is concerned, we have never stopped surgery. So almost we have analyzed, so almost the 1,771 patients we have operated only during COVID period. So it may be similarly, there must be a huge data from various hospitals. So we cannot say, but everyone is trying to come back as early as possible because we have lost a lot as far as cancer care is concerned. So all cancer hospitals are working hard so that they should come back to pre-pandemic level. One more question, last question. I think there are only 48 seconds and people are asking now questions that what non-opioid adjuvants are commonly used after major abdominal surgery as a part of IRAS program. So Dr. Bernard, would you like to answer this, please?
I see Dr. Vijay has typed a response there, but what I could add to that is we have a strong usage of intrathecal morphine, which we find significantly reduces systemic opiates. It gives good enhanced quality of recovery, less sedation post-op, etc. So intrathecal spinals with intrathecal morphine for us is a strong part of our abdominal surgery enhanced recovery pathways.
Thank you very much. And Dr. Vijay has also answered. I have seen the same. Thank you very much, Dr. Divetya, Dr. Vijaya, and Dr. Bernhardt for the fantastic presentations. And people must have learned a lot. And there is always something new to take from your lectures. Thank you, Dr. Madam.
Thank you. Thank you so
everyone.
much.
And thank you, organizers, for giving this opportunity to share this session. Thank you.
Same here. Thank you very much. Bye-bye.
All the best with the conference.
Thank you. Bye-bye.
Bye. Bye. Bye-bye.
Thank you for this session, ma'am. Now I hand over to Dr. Swati Reddy for the next session. Over to you, Dr. Swati.
Thank you, Meena. Now we will head on to the second session, that is on head neck reconstructive surgery. I take the pleasure to invite the chairpersons, Dr. Sarbari Spaika, Professor and Head, Institute of Postgraduate Medical Education and Research, Kolkata, and Dr. Amiya Mishra, Senior Consultant, Department of Anesthesia, Medicas Super Speciality Hospital, Kolkata. Over to you, ma'am.
Thank you, Dr. Swati. For this session to be started, I would like to request Dr. Amiya Mishra to start this session, please.
Sir will be joining soon. Till then, please, you can proceed.
Okay. So our first topic is a pro-con debate on flexible fibroscopy. Fiber optic bronchoscopy is the technique of choice in cancer patients with anticipated difficult airway. So the speaker for the motion is Dr. Sujata Ghosh. She is the Associate Professor in the Department of Anesthesiology, Institute of Postgraduate Medical Education and Research. She is the winner of Basudeb Guha Memorial Paper Presentation Competition, winner in Jaipur Award on Acute Pain. She is right now the Honorary Secretary of Indian Society of Anesthesiologists, West Bengal, and she's past treasurer of All India Difficult Airway Association, West Bengal. She has several publications in national and international journals. So I request Dr. Sujata Ghosh, please start your talk.
Thank you, madam. Thank you very much. At the outset, I would like to thank the organizers for giving me the honor of speaking before you in this pro-con debate. The flexible fibroscope is the technique of choice in cancer patients, in head neck cancer patients with anticipated difficult airway. as this is a head neck session, I would restrict myself more to the head neck cancers. I'm Dr. Shujata Ghosh with greetings from IPJMER. This is a picture which is very close to our heart. The first demonstration of ether anesthesia in the Bullfinch Amphitheater of Massachusetts. While
Madam, please make it slideshow.
Okay. Thank you, ma'am. While Sir William Morton was administering ether, Sir John Warren was operating on a vascular tumor in the neck and jaw of the patient. So head and neck anesthesia for head and neck surgery is from the dawn of anesthesia, surgical anesthesia. However, there has been a lot of transformation and a lot of sophistication, not only in the techniques, but also in the gadgets. And in head neck surgery, if we have a quick review, we find that the tumors and cancers that we deal with every day are the supraglottic tumors of the piriform sinus, a large goiter, a large submandibular mass, a pharyngeal carcinoma with metastasis. There might be a recognized difficult airway, but in an emergent situation, in case of piriform fossa tumors, obstructed tracheostomy trauma, angioneuritic edema, an unrecognized difficult airway may present in a lateral and midline tongue lesion, whereas iatrogenic difficult airways are present in recurrent vocal cord papilloma, subglottic hemangioma, glomus tumor, and epiglottis. Let us have a quick look at some of the pictures. Sorry. Sorry. So when you look at the patients, you will find that the airway is severely compromised in the head neck surgeries. Sorry, please allow me a minute. I think there is something going wrong in my presentation. It's not progressing. Anyway, so what happens is that often enough, you find that there is a small chink of space. The mouth is not opening properly. There's a large tongue. And after surgery and radiotherapy, there will be extreme difficulties in laryngoscopy and intubation. In the recent 4th National Audit Project conducted by United Kingdom, they found that poor judgment with inappropriate choice of equipment was the contributory factor in the airway morbidity and mortality. And they concluded that flexible fiber optic fiberscope maintains its important role in the difficult airway management. And after looking at all the pictures, which I have not been able to show you, but as all of you are oncosurgeons must have seen very clearly that the choice of anticipated difficult airway in head neck surgery are 3. The fiber optic bronchoscope, the awake fiber optic bronchoscope, and the awake fiber optic bronchoscope. There have been new findings and refinements in techniques from 1967 when Murphy demonstrated the first fiber optic bronchoscopy. There have been newer techniques, but the gold standard has remained the same. Radiotherapy itself also poses unique difficulties. There is limited neck extension, temporomandibular joint ankylosis, osteoradionecrosis of the mandible, and after surgical resection, there is difficult mask seal. Nasal access is difficult, temporalis contracture, and temporomandibular joint pseudoankylosis. Surgery of the tongue and the floor of the mouth and laryngeal surgery also causes trismus, fixed immobile tongue, limited mandibular space, increased tongue oral cavity ratio after flap reconstruction, and laryngeal stenosis after laryngeal surgery. These are some post-operative cases, and you can see that it is extremely evident. Can you really introduce a laryngoscope in this or a video laryngoscope? However, what really is the question is that you should have a strategy, a sequential plan of events that you should do instead of a single mode. Something seriously wrong. This is the picture of a recurrence of tumor after the surgery. And trust me, I would be happier and breathing better if I have a narrow fiber optic bronchoscope with a narrow tube, which I can safely introduce into this chink of passage and avoid bleeding from the tumor. Radiation poses unique problems. As you can see that there is extensive fibrosis after radiation. And if you look carefully, you will find that there is extensive fibrosis in this area. And very often what you really find is that when you try a laryngoscopy, there is either not enough space or manipulation is extremely difficult, whether it is a direct laryngoscope or whether it is a video laryngoscope. What choice would you take in these cases? I believe the best option for these cases would be flexible fiber optic bronchoscopes. I agree that fiber optic intubation in patients after radiotherapy is difficult. But when you do an extensive literature search, you will find that there are ways and means in which you can predict whether at all the fiber optic intubation will be difficult. And if you find that your fiber optic intubation is difficult, trust me, you should never ever go for laryngoscopy under general anesthesia. Moreover, when we talk about video laryngoscopes, we find that malignancy and previous surgery also leads to difficulty in intubating using video laryngoscopes, and there is no evidence to indicate that video laryngoscopes reduce the number of intubation attempts or the incidence of hypoxia, especially after direct laryngoscopy has failed. And now the question comes about tracheostomy. Often enough, previously, what we used to do is that if you're not sure whether you can perform a proper laryngoscopy or not, there was an option to do an elective tracheostomy, but there has been a total paradigm shift, and tracheostomy is now not necessary after every major cancer resection and reconstruction. And post-operative ventilation with an endotracheal tube is an option, and we can wait for the edema to subside and take appropriate measures after that. And greetings and thank you. I'm sorry there has been a mishap in the slideshow. Anyway, thank you and hope you use the fiber optic bronchoscope while intubating these patients. Thank you very much.
Sir, you're muted. Sir, you're muted. Please unmute.
Yeah. So our next speaker who will speak against the motion, Dr. Namrata Ranganathan. Her current designation is she's the professor of anesthesiology in Kidwai Memorial Institute of Oncology, Bangalore. Madam, would you please start?
Yeah, ma'am. Good morning, ma'am. Can you see my slides?
Yes, you make it slideshow, ma'am.
Yeah, just a moment. Oh. Good afternoon, everybody. Flexible bronchoscopy is the technique of choice in cancer patients with anticipated difficult airway, the concession. I'm Dr. Namrata. If you always do what you've always done, you'll always get what you've always got. Just a moment. I'm not getting my picture there.
Yes, ma'am, it's not full visible. Can you put it on slideshow?
If, just a sec. Can I just have only my picture there?
Slide is visible, but half. Can you stop and share again?
Okay. Wait. Mm-hmm.
Yeah, now it's visible. Now it's visible. Perfect.
Okay. I'm just not getting any picture there though of mine. Can you people see me?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
But
We can see you.
I'm not able to see myself.
It's fine, ma'am. Your slide is
I
visible.
can
You
just...
are also. We can see you. Everyone can see you, and your slide also. Put it on slideshow.
Okay.
Yes, ma'am.
Only thing is, I'm not able to see myself.
It's okay. It's fine, ma'am. It's fine, ma'am.
Okay. Flexible bronchoscopy is the technique of choice in cancer patients with anticipated difficult airway. I'm against the motion. Dr. Namrata from Kidwai. So if you always do what you've always done, you'll always get what you've always got. This comes from this study where they did about 188,000 patients studied prediction of difficult airway management, and they saw that out of 929 anticipated difficult airway, only 25% had an actual difficult intubation. Should this finding surprise us? I don't think so, because all of us in our clinical practice also go through this. A very disappointing study, though, that what we are doing is not right. When we come across such kind of lesions, how to manage them with so many options? You can pre-oxygenate them, you can give different kind of anesthesia, different types of mask ventilation, direct laryngoscopies, video laryngoscopies, tracheal tubes, stillid, bougies, fiber optic. And if I have a situation where can't intubate and can't oxygenate, I can use a supraglottic device. And ultimately, when the going gets tough, our team can perform an emergency surgical airway with several devices and techniques. Can we really say that difficult airway does not exist? Yes or no, I leave it to you. But for me, it's a complex situational interplay of patient, practitioner, equipment, expertise, and circumstances. So is flexible bronchoscopy the technique of choice? I don't think so. There is no universal best approach. A right personnel using the right equipment with which they are familiar and skilled at the right time and right location. Yes, holding measures are often useful and high flow nasal cannula should be available. Going through the literature, when you see there are editorial with time to event and awake fiber optic intubations, make video laryngoscopy the prime technique for anticipated difficult airway, add it to your skill mix, a direct approach to awake intubation. We have enough literature. We have innumerable RCTs. We have 6 RCTs where video laryngoscope versus fiber optic bronchoscope for awake intubation says that for awake intubation, video laryngoscope with a shorter intubation time is as effective and safe as fiber optic, and video laryngoscope may be a useful alternative to fiber optic. These are the RCTs done. So what we concluded that video laryngoscope appears to be easier to learn, and in order to reach competence with fiber optic scope guided intubation, anesthetists may need 25 intubations, but with video laryngoscope, 1 to 6 may suffice. So what video laryngoscope does is that it provides us with a fixed wide view of the glottis that aids recognition of airway landmarks in presence of both normal and distorted anatomy. It creates a space within the airway, allowing for effective aspiration of secretions and blood from the airway under direct vision. And at the same time, under direct vision, we can give atomized local anesthetic to the glottis and trachea. One thing, another big advantage of video laryngoscope is that placement of the tracheal tube is observed throughout the intubation process. What does that do? It reduces the potential for airway trauma and also reduces the risk of impingement of the tube at the arytenoids, which is very common in fiber optic. And the best part, that it can be used for preoperative airway assessment in awake patient in order to assess whether really the patient needs awake intubation or not. Another important thing, it does not have a restriction on size and type of endotracheal tube we use. If I railroad a 6 or a 6.5 or 7 tube on a fiber optic, and when I am pushing the tube and it's not going and I want to change the tube, I need to take out the scope. But what in video laryngoscope? I can just change the tube, I can put a bougie, I can put an airway exchange catheter, ventilating bougie, stillet, any gadget I want to use at that juncture. Yes, video laryngoscope is good for teaching too, but may not be the right choice in some of the head and neck cancers. What constraints we are having with fiber optic? Yes, the biggest one being availability, requires skill, uncomfortable to patient, less suited for supraglottic and tracheal stenotic lesions, have restriction on size and type of ET2. The presence of edema, excess airway tissue, secretions, or blood in the airway will obscure the image. But what remains ignored is that at no time during insertion of tracheal tube over a fiber scope can the tip of the tube be seen directly. So when we are trying to push the tube blindly on a fiber optic scope, we can damage the airway, which can cause bleeding, edema. So we need to be very careful when there are pathological changes to glottis and the surrounding tissues. Yes, it is not a safe technique with advanced obstruction from a periglottic tumor. We require a calm patient. We need local anesthesia may not act. We may not be able to distinguish the anatomy. We require minimal blood and secretions. And worse come worse, we can have cock in the bottle situation where whatever airway the patient had, our scope has blocked, or while pushing the tube, we have blocked it. And we have an agitated, restless, and a hypoxic patient. But as we are seeing with the literature that as new airway equipments are coming, the use of fiber optic is declining, but it still plays a vital role in difficult airway management as it allows the anesthetist to have a safe managed plan for the anticipated difficult airway and a rescue strategy for the unanticipated difficult airway. Anesthetists should have a low threshold for using fiber optic when necessary, and if the decision is made to undertake it, serious consideration should be given. As I went through the literature and I saw the latest DAS guidelines, they have put more stress on using combination techniques. So people have started using combinations of video laryngoscope and fiber optic. And if you see this article where video laryngoscope assisted fiber optic bronchoscopy was used for difficult intubation in upper airway cancer. In what they did, they took 16 patients who were having little obstruction and they were posted for upfront tracheostomy. But with this combination technique, they could do In 9 cases, a successful intubation. They used this combined technique for huge goiters. They used video laryngoscope for nasopharyngeal mass. They used video laryngoscope for periglottic tumors too. So if I give you this scenario of oral cancers, I'm sure if 10 of us are here on the screen, and I would say that 6 of us or 5 of us only may have a common way of managing this case. Others may have a different way to do it. If a patient is like, definitely, how Sujata said, I am going to do fiber optic. When there is post-RT, there's restriction, there's trismus. If we have a tongue lesion, again, I'll decide depending on the size, the site, the friability of the tumor, whether base of tongue is involved. Depending on that, I will decide what is my plan of airway management. If it's a supraglottic tumor, would I want to put a video laryngoscope and bleed, or I would use a fiber optic, bypass it, but at the same time, when I'm pushing it, I may injure it. So again, it depends on the lesion. If it's a glottic tumor, the kind which is shown here, I would just go for an awake tracheostomy. Coming to intraglottic tumors, whether the thyroid is just indenting the trachea, or thyroid is infiltrating the trachea, or it's a retrosternal goiter. So it all depends on what type of the lesion is there in the airway, which will make me decide what I want to use. None of these thyroids, fiber optic was used. I'm not saying that it cannot be used. Yes, I did a pre-op bronchoscopy before. We used our images to decide what we should do. But I would never like to push a fiber optic in a narrow trachea deviated to one side. Instead, I would intubate the patient, put the fiber optic conventionally and put the fiber optic through it and see where the obstruction and decide whether I want to push the tube beyond it or where the lesion is. Yes, post-surgery, as Sujata showed, plays a really important role. Fiber optic plays a role, but again, it depends on the type of surgery, whether mandible was removed, post-CTRT, or coming for a redo, or there is so much of fibrosis that even the tracheostomy may also be difficult. So what I would say that in an anticipated difficult airway head and neck oncosurgery, different intubation devices may be suitable for different difficult situations. And I would like to emphasize more on a non-technical skill where the team should realize that we are failing in the first plan. So it is the right time to shift the focus to another plan, which is much more crucial than to have a plan A, B, and C. Thank you.
Thank you, Dr. Namrata. I would like to request Dr. Sujata to say some for 1 minute over Dr. Namrata, if you have anything to say.
Honestly speaking, I think Dr. Namrata and me, we have agreed on one basic point. That is that it is not just a single strategy that should be taken. It should be a sequential strategies that should be kept in mind, planned pre-operatively. But I would still go for head and neck surgeries. I would still maintain that if you really think of safety, a weak fiber optic bronchoscope is also in your mind as one of the safest procedures. I do not agree that video laryngoscope cannot be used. No, certainly it can be used and we are using. But so far as the technique of choice, the gold standard is still the fiber optic solution. But of course, I do agree very much that, and I have also done it, that we are starting, we are shifting, and we are doing more hybrid intubations rather than a single intubation. That's true. But so far as the gold standard is considered, fiber optic bronchoscope is still the gold standard. I have not been able to show much literature regarding that, but of course, there are there. Thank you.
Okay, thank you, Dr. Namrata, Dr. Sujata. It was nice debate. And I think always a preoperative assessment, judgment, and appropriate choice of equipment is very, very important whenever there is difficult airway in case of head neck oncosurgery. Thank you. Thank you again.
Thank you.
Good afternoon, everybody. Now we are going to the next session, a panel discussion on post-operative airway management in head and neck oncoplastic surgery. It is my great pleasure to introduce Madam Dr. Arati BH, Associate Professor, Department of Anesthesiology and Pain Relief, Kidwai Memorial Institute of Oncology. Madam will moderate the session. And now we have 4 panelists in this session. It is my pleasure to introduce Madam Dr. Sheila Narayan Maitra. Madam is the professor and Department of Anesthesia and Critical Care, Tata Memorial Hospital, Mumbai. She was the past president of IDA. And Dr. Sabyasachi Das, Professor of Anesthesiology, Medical College, Kolkata. Dr. Manas Khan, Consultant and Coordinator, Department of Anesthesia and Perioperative Care, Narayana Super Specialty Hospital, West Bengal. And Dr. Jerry Paul, the Clinical Professor of Amrita Institute of Medical Science. I request all the panelists to be ready, and I request the moderator to start the session.
Good afternoon, everyone. Are we visible, all of us? All 5 of us. Yeah, good afternoon. Thank you, SOAPCCON, for giving me this great opportunity to moderate this session. Greetings from Kidwai Memorial Institute of Oncology. Securing and managing airway is all our specialty skills. Securing and managing a difficult airway is all our favorite challenge. I think all of us agree with that. When it comes to head and neck surgeries, all of us think of a difficult airway. We think of planning and anticipating, assessing, plan A, plan B to secure and manage the airway. How much are we prepared to manage a airway post-operative? Should we really plan for the post-operative airway management pre-operatively? Yes, definitely we have to plan, because the compromised difficult airway which we see pre-operatively becomes more compromised, more difficult, giving us a bigger challenge in post-operative period. Hence, we have a very interesting discussion today on post-operative airway management in head and neck oncosurgeries, a panel discussions. I have 4 eminent panelists, Dr. Sheila Maitra, Dr. Das, Dr. Manas Khan, and Dr. Jerry Paul, and all of them been already introduced. I welcome you all again for this interesting discussion. I'm sure all our panelists are going to enrich our knowledge on post-operative airway management. Thank you for being there. My first question is to Dr. Das. Dr. Das is there. Yes. So how can you just highlight the difficulties, what we can come across in managing the airway in post-operative head and neck surgeries?
Yes, this is very important thing that post-operative patients with oncosurgery, particularly in the head and neck, they create a complex problem in the post-operative period, both immediate and these are basically the compromising of the airway and after operation, and these are multiple things that might happen. That is the loss of airway, and many life-threatening issue might come in the immediate post-operative period. So there we have lots of choices, and to be on the safer side, people used to do tracheostomy earlier to be on the safe side, and elective tracheostomy was done earlier to prevent that.
Is there any protocol you follow in your institute?
There are protocols. Recently, I got an article of Dr. Sheila, and there is lots of information in this article. And they also follow a certain protocol, and they did in a large number of cases. So earlier also there was protocol, but that was not very effective. Earlier protocol which I came across, they were not that very effective in predicting the criticalness or urgency of doing tracheostomy. And in fact, tracheostomy in all over the world are done more than anticipated, actually.
Okay, thank you.
More number of tracheostomy than it should have.
Thank you, sir. Thank you. Let's move on to Dr. Sheila. I know you have done a lot of studies in this already. I've read your articles. So in your view, do we have to go ahead with tracheostomy, or do you have any other plan post-operatively in managing these cases? And can you give some criteria, and then how do you go about deciding it?
First of all, I want to thank the organizing committee of SOAPCCON for giving me this opportunity. And thank you, Dr. Aarti, for steering this discussion very nicely. You've asked a very relevant question, and I think this is the most fundamental question in airway management in airway head and neck cancer. That should we do an upfront tracheostomy or should we have a tube in patients post-operatively? Because this is, we know tracheostomy isn't without complications. It's the easiest thing is to just have a tracheostomy, right? But tracheostomy itself has complications. It gets blocked, it gets dislodged. There are various complications. Now we have enough data to support that overnight extubation, delayed extubation, the outcomes are better, faster return to speech, feeding, speaking, all that is much better and quality of life is better. However, the fundamental question is which patient should we do overnight keep a tube and which patient should we do a tracheostomy for? I'll tell you, about 20 years back, I was at Sloan Kettering in New York, and there, the big cancer center, and there almost every patient they were doing tracheostomy. And in Tata Hospital, few we were doing tracheostomy and few patients we were doing overnight intubation. So I really wanted to know that why are you doing tracheostomy for all your patients? And they said, no, we want to be very safe and we don't want to have any mishaps. I'm sure practices have evolved over time. So this is a very important question as to what you should do. And to tell you very honestly, it's very subjective depending upon what is this experience of the operator, what is the infrastructure available, and what is the post-operative backup that you have for this. So what we decided at Tata Memorial Hospital, being a very high volume cancer center, we said, let us try to find out that which are the patients that you can safely extubate. Because of course, some patients will definitely need a tracheostomy when you have a very extensive dissection. There is no question that you will. So those patients definitely will have. So the best way to do it is to do a randomized control trial where you can, decide some will get extubated and some will. But this is a very dangerous approach and it is unethical because, the patients who will have, airway compromise or stridor after extubation will need to be, an emergency tracheostomy will need to be done. So what we did is we took another approach. Over a 1 year period, we looked at all patients who underwent major oral cancer surgery. And there were about 5,000, close to 5,000 patients. And what we did is, depending upon the institutional protocol, we left it to the surgeon because for some patients, surgeon would do a tracheostomy, and for some patients, they would leave a tube. And let me tell you, these practices have evolved over the last 50 years in Tata Memorial Hospital. So we have become more and more bold, and we are putting tubes in more and more patients, which earlier we were extubating. So it is a very good, I would say, a very good case mix in which to do this study, because a lot of patients are getting extubated, which in some centers maybe more tracheostomy is being done. So just in short to tell you, basically what we did is we screened about 4,500 patients. We excluded all the minor surgeries and the non-major oral cancer surgeries, and we came down to about 720 cases. And then in this, there were about 303 tracheostomies and 417 patients underwent overnight extubation. So this was left to whatever the surgeon wanted to do. Now, overnight extubation means we don't have a protocol of extubating in the evening. We keep the tube overnight, and in the morning we extubate these patients. If we have a concern that the patient may require reintubation or it may be a complicated case, then we may do it over a tube exchanger or a bronchoscope. Otherwise, we just extubate the patient directly. Now, not a single one of these patients had a compromised airway which needed a reintubation, or that obviously was because of the experience of the patient. So we looked at all those who had a safe extubation. That means they underwent extubation and did not require reintubation or tracheostomy. And then we did a multivariate analysis to look at what are the characteristics, what are the criteria that you can use to safely extubate these patients. So definitely these patients you can safely extubate. Of course, there will be some patients who underwent tracheostomy also who we can safely extubate. We may have missed few, but it is better to err on the side of doing more tracheostomies than, it's okay to do from a safety point of view. So just to tell you the results, what we found was that if you have had no neck dissection or unilateral neck dissection, if it was a T1, T2 tumor, if there was no neck radiation, and if there was no extensive neck dissection, extensive resection, then these patients could be safely extubated. And when we talk about extensive resection, what we mean is that mandible, not more than 1/3, not crossing the midline, maxillectomy, not extensive maxillectomy involving the genital tubercle, and tongue either total glossectomy or near total glossectomy, crossing the midline basically. So this is what we meant by extensive. So if you didn't have any of these criteria, then so we found out objective criteria, and these are anatomical criteria, so there's less chance of subjectivity. We could use this criteria to safely extubate the patient. So this is what we recently published in Oral Oncology, and I think this is very useful because at least these patients can be safely extubated. No doubt this has to be validated in another cohort of patients to establish the validity of this criteria.
Yeah, that was a very good study, but probably I read it 2-3 times. So whatever you were telling, I knew all the data. It was a very good. Now we'll go on to the next question to Dr. Manas Khan. So we already know Dr. Sheila already told us about the advantages, but what is your experience of advantages of delayed extubation over tracheostomy, or the advantages of tracheostomy? All of us prefer tracheostomy because we feel very safe. So what is your experience, Dr. Manas?
So good afternoon, everyone. Am I audible, by the way?
Yes, you are audible.
I sincerely thank the organizing committee to begin with for inviting me for this panel discussion. And thanks, Dr. Arthi, for the nice question. Now, fortunately, Dr. Sila has done my job easier, right? She has categorically told the situations where we think of delayed extubation strategy after major head neck oncosurgical procedures. Now, I want to emphasize once again, as Dr. Sila said as well, that delayed extubation is not a substitute for tracheostomy. Tracheostomy has to be done in a subset of patients where it is due to maintain a patent airway post-operatively for a safe outcome. Now, we have a subset of patients for delayed extubation. And I would like to repeat, those situations where we should think of keeping the tube overnight for a later extubation, maybe the next morning. Now, the situations are, I'm just repeating what Dr. Sila said. One is no neck dissection or unilateral neck dissection, number 1. Early stages of tumor, T1, T2. Number 3 is no preoperative radiotherapy. Number 4 is absence of extensive surgical resection. This is important. Now, what are the situations where extensive surgical resections are done, or what are the extensive surgical resections? Number 1 is the glossectomy crossing the midline. That means near total glossectomy or total glossectomy. Mandibulectomy, where genial tubercle is removed. That means, extended mandibulectomy or central arch mandibulectomy. Next is your maxillectomy, mainly medial, if it involves a soft palate. And lastly, absence of any bulky or big free flaps. So if there is primary closure, there is faciocutaneous flap, then probably we can think of delayed extubation strategy, because no doubt delayed extubation strategy has shown overall airway related and other benefits over tracheostomy. And if you go by figure, it is almost 4 times less complications in the delayed extubation group compared to tracheostomy. Second point is that in the delayed extubation strategy, once the extubation is done uneventfully, and obviously the extubation is done in the PACU or surgical ICU or HDU, depending upon the infrastructure, and there is no acute or sudden airway related complication, what happens? The recovery of those patients are really faster. So I repeat, if we can nicely identify those where delayed extubation can be applied or considered, and once the extubation is done the next morning, obviously after certain criteria are met, then the recovery is really fast. Because the certain problems of tracheostomy, like namely dislodgement, blockage, frequent suctioning, bleeding, ongoing, injury to the trachea, or even respiratory tract infection.
Dr. Jerry has the same question next. Dr. Jerry,
so these problems will be there in the ward itself if the patient is tracheostomized, right? Now, there are other certain advantages of doing a delayed extubation strategy. Number one, rapid return to oral intake, very, very important. And figure-wise, again, 2 days earlier compared to tracheostomy. Another is faster return to speech, which is very encouraging for the patient, very encouraging. People love to, get back their speech as early as possible. And delayed extubation strategy offers that if we, objectively identify those subset of patients. And overall, the hospital stay also reduced in the delayed extubation strategy group compared to tracheostomy. So essentially, to brief, probably if we can objectively identify those patients where delayed extubation can be applied, we can probably quote unquote prevent few unnecessary tracheostomies. That is precisely the idea of this discussion. So that is, I think, what I can say in favor of delayed extubation compared to tracheostomy.
Thank you, Dr. Manas. I think we are giving idea for the organizers of SOAPCCON next year. They will have a pro-con session on delayed extubation and tracheostomy. I feel that is what it's going on like that. I know we have a lot of advantages of delayed extubation, which we are ignoring probably. With this, we are making people are aware how important is delayed extubation. But however, we still prefer tracheostomy, difficult airway, and we want to be safe. We go ahead with tracheostomy. As Dr. Sheila already mentioned, some cases which are not required also, we are landing up in tracheostomy. So unfortunately, many patients are landing with upfront tracheostomy. So now the next question is to Dr. Jerry Paul. So we are landing up with so many tracheostomies. What are the complications? Why are we now doing a study on delayed extubations? What are the complications early or late with the tracheostomies? Dr. Jerry Paul.
Okay. Thank you, organizers, for having invited me here. And thank you, Dr. Arthi. And now the thing is that I thought the question was a little different. I was asked whether it is an emergency tracheostomy, practical difficulties. Is that what I'm supposed to talk about?
It's also there. That is also there. We'll talk about emergency. This is elective tracheostomy, the difficulties.
Now, elective tracheostomy.
Little bit, Dr. Manas covered a little bit.
One of the most dangerous complications that we have seen with elective tracheostomy is, suppose it is an intubated tube patient. We have seen quite a few of those. Now the surgeon makes a very small incision for that. Okay. And then he asks us to pull the tube out and then tries to introduce the tube from the side. And he says the tube is well inside, I'm very confident. And you connect your circuit and try to look at the entire carbon ductus, no entire carbon ductus. Then I start having an argument with the surgeon saying that, see, it is not in. The surgeon says it is in. And you start ventilating, the gas goes into the mediastinum and causes a mediastinal air collection. See, this is very dangerous. Okay. It happens mainly because the surgeon's technique of trying to introduce from the side. Now, when they are making a small incision, the best way is either use a bougie and ask them to thread it over that, or introduce it straight down. Okay, that's one of the issues. Bleeding is rarely a problem because they have a lot of control over this. Okay. Now, the delayed complications that I've seen quite often is, one is that when you use a double lumen tube, okay? When you use a double lumen tube, that is, you have an inner tube, you have an outer tube. Now, the inner tube, the patient goes to the ward with the inner tube. Okay, you give instructions to the nurses there to take care of it. They are not aware of, or they are not familiar with this kind of a arrangement. And what happens is that the tube gets blocked. Okay, and the people who come after that are also not aware of it. They try to ventilate from above, and they try all sorts of things, and eventually the patient dies. Okay, that's another issue that I've seen. When you send the patient to the ward with an inner tube. All right. The other delayed complications, like going into, some bleeding issues and all those things, are kind of rare, but these are the more dangerous ones that I've seen. All right. Infections and all those things.
Infections, okay. Stenosis also. Stenosis is one of the.
Okay. Oh, you're talking about stenosis. Generally, in head and neck, we don't see too much of stenosis because we don't retain the tube for long. It is only just to maintain the airway that it keeps. Okay, and you can always monitor the cuff pressure, and they are very careful about the tracheostomy because the anatomic understanding is quite good. So we don't generally see it unless, like in medical ICUs, where you tend to see a lot of stenosis. Okay, so I think that's about
Tracheostomy. So tracheostomy has some commitment. We think we are very safe with tracheostomy. It is not so. We are having a lot of complications which may ignore it because it may have, we might shift the patient to ICU or HDU, then we might see these complications. So we are safe at that time. We feel we have secured the airway, we are safe. But we have to keep these complications in mind. Now let's move on to Dr. Sheila again. So now we are insisting that delayed extubation is a good choice if you can go ahead with it. But Dr. Sheila, what I want to know is, we are keeping the tube for 24 to 48 hours depending on the situation. And in our practically, they have to maintain that tube. There are so many issues, pressure cuff. How do you go about it? The practical difficulties of keeping the tube.
This is a very important. Firstly, I'd like to thank Dr. Maynas for outlining all the criteria so beautifully and highlighting this, about the criteria for delayed extubation versus tracheostomy. Now, Aarti, what you have asked is a very, very important question. And I want to tell you how our practice has evolved over time. So though delayed extubation has specific advantages, if not done carefully, even this can lead to catastrophic complications. So you have to be very cautious. I'll tell you, in the beginning, when we used to do small tongue lesions and all, we used to extubate these patients in the evening. And often, I would go home and I say extubate. Never, over time, we have a protocol now. We don't extubate any patients in the evening. We do this in the morning. So we keep the tube overnight. Now, keeping the tube overnight also is not a safe approach because there can be blockage, there can be dislodgement. We're not so much worried about tracheal cuff pressure because we're just keeping it for just 6 to 8 hours. Now, the advantages of this approach is not only the safety of having more staff in the morning and more people around and the surgeons around, but also you have a lot of postoperative edema. So, all this and settles by morning. And the other thing is, in case there is some bleeding or in case there is some complication, this is a patient in whom you've done a hemiandibulectomy. It's difficult to re-secure the airway. So you have enough time. So if there's some bleeding or something, you always already have the tube in place. So these are the two unique advantages that keeping of delayed extubation. Having said that, in foreign countries where they keep the tube, they don't keep it without ventilating the patient. They put them on pressure support ventilation. So spontaneously breathing, but they don't leave them like this the way we do. Now, because of the high numbers, we are just keeping them with the TPs and connecting them on oxygen. So to prevent any kind of blockage, what we need is very good humidification. For this, we have to nebulize these patients. We have to also do a suction. And one of the most important things is that, this is a tube we are keeping for a very long time. And often the tube may be right endobronchial. And this does not happen with the tracheostomy, but happens with the endotracheal tube. And you might have by the next morning a left lung which is collapsed. So one part of our protocol is to definitely check the position of the tube after shifting that the tube is in the right position. Second is that the tube is properly fixed, that we are giving adequate humidification to prevent blockage. We manually also check with an ammo bag the patency once in the night and do suctioning. So these are some of the precautions, and secure it properly to avoid any kind of dislodgement, because this all again is a problem. And in case there is any emergency or the patient bleeds or anything like that, with this tube, the patient is taken to the operating room. And the other thing is, unlike the tracheostomy, which is in place, when you take out the tube, if the patient cannot maintain airway patency, the patient will have to be reintubated. So if there are any borderline cases, then we do it over a tube exchanger with the surgeon present. Otherwise, we just routinely extubate. So I think that with the tube itself, you have to take a lot of precautions. It's not something you can take lightly. And the last point I'd like to make is, though a nasal tube is quite well tolerated by patients, we still need to give them some amount of sedation. Now, this can be very tricky because if you sedate them, then, they might have respiratory depression, etc. So we give them intramuscular morphine or sometimes even morphine. But this also, you have to be very careful what sedative you have to use. So they tolerate the tube very well, and this is something we're using over years. But at the same time, I would say if you're giving IV infusions, then you have to be careful because this is not a patient you're ventilating. So the monitoring is the key in these patients, maintaining patency, the sedation, and preventing accidental extubations.
Yes. Thank you, Dr. Sheila. That is, even at Kidwai, we also follow the similar protocol because we face this. We keep the patient delayed extubation, even we extubate after 24 hours in the morning itself. We see a lot of, sometimes the tube gets blocked. Sometimes if it is a oral intubation, patient bites the tube. And as you said, the night staffs are less if they may not give it. These are the practical difficulties, however much we talk. Then we will have to take precautions if you're leaving the tube. All these precautions has to be taken care. And cuff pressure, I know it is not so important, but still we have seen one patient had a Colcott palsy after the delayed extubation. So that's what I was asking. Thank you for enlightening on this topic. Now let's go to Dr. Sabyasachi Das again. Sir, we have done a lot of studies on this. We are coming to a conclusion of the delayed extubation tracheostomy, but there are studies on the scoring systems. Can we highlight on this onto our audience? What are the different scoring systems and how good they are?
There are different scoring systems, of which we can name that Cameron scoring system, the Strauss scoring system, Gupta's system. These systems, they actually collate all the things which we discussed right now. For example, if there is a tumor in the posterior part of the tongue, it is scored as 4. For example, if it is done in the anterior part of it, it is scored as 1. If there is the mandibulectomy, the score is higher than if it is not there. If bilateral neck dissection is there, score is higher. So in that way, there is a score of total 20 or 25. In general, score more than 5 or more than 7 suggests there may be a need of tracheostomy. So this is all about the scoring, whatever available in the literature. And basically this compiles all the things which we discussed right now. The radiation, the preoperative radiation and all other things. These are the basis of scoring system. And anyway, all the way, if score is more than 5, they usually advise to go for a tracheostomy.
So yeah, we have some different scorings. CAST, Cameron, Gupta scoring, none of them are not so valid. I think CAST is a little bit acceptable.
Their sensitivity and validity and positive predictive value is not that high to recommend it universally.
I'd just like to add a point, if you permit. So we have a lot of scoring systems, but they have not been validated.
Right.
And you can never definitely say who needs a tracheostomy, but you can definitely say who can be safely extubated, because there will always be patients who will do a tracheostomy which may be extubated.
Yes.
So that is why we took this approach. And I just want to add one point.
I agree.
Very critical reviewers who said, oh, study from India, so what if 5,000 patients and things like that. And I said, look, this is the place to answer this question, because you have very early lesions, you operate them very fast. So you don't have patients who need a tracheostomy. You can extubate all of them. Whereas we have the whole range of disease, because we have patients who present very late. So we are in the perfect position to answer the question, whether you need a tracheostomy or whether you need a tube. Just want to add this point.
I just want, thank you. This I wanted to highlight people. There are scores, but they're not so validated. Most of the time, we are landing up in more of tracheostomies when we use those scores.
Yes, unnecessary.
Just wanted to mention that. So let us move on to our next question, Dr. Manaska. Till now, we are talking about elective tracheostomy and delayed extubation. It was like a debate, and we all are in favor of delayed extubation right now. So, but still, as Dr. Sheila, so sometimes we may fail in extubation. We may land up in doing emergency tracheostomy. So what is your plan of action? What are the issues we come across? Emergency tracheostomies.
Thank you, Dr. Arti, once again. This is really a tricky situation. But fortunately, a true emergency tracheostomy is uncommon. And most likely cause of this situation is the sudden upper airway, obstruction, where the patient cannot be intubated. This is the only situation. Now, this can happen if a patient presents with stridor in the emergency department because of some, say, pharyngeal or laryngeal pathology, or it may happen in the HDU or surgical ICU, where we are extubating a patient after the delayed extubation strategy. This can happen as well, because the airway may not be, kept patent after the extubation, and we may lose the upper airway, requiring emergency tracheostomy. Now, next point is that, because it is an emergency and patient cannot be intubated per se straight away, this procedure is done awake and under local anesthesia. There is no doubt about it. Now, the question is, what kind of front of neck, access is to be adopted? Now, whether it's cricothyrotomy or tracheostomy straight away. Now, fortunately, we work in a head neck cancer unit. So we have very expert surgeons who are very, very, expert in doing tracheostomy straight away. Why cricothyrotomy unnecessary, right? Something like that. So at the end of the day, cricothyrotomy or tracheostomy will depend on the time available, before the procedure is done, the resources available, and as I said, the expertise of the surgeons, right? Now, this is, as I said, it's a very tricky situation in the sense, if the patient comes in the emergency, we are getting an airway which is unseen and unassessed, number one. And if we face this problem in the surgical ICU or HDU, then the problem with the altered anatomy of the front of neck, if it is post-surgical, right? The second problem. Third problem is giving oxygen to the airway is a big problem. Upper airway is basically blocked almost. And I personally would suggest an HFNO in this situation because of giving high FiO2, a humidified oxygen, a little bit of CPAP. Fourth point, the fourth problem is basically the position of the patient. Patient can hardly lie down because of the distress or stridor. And last, the acute complications of tracheostomy is much higher in emergency tracheostomy, be it bleeding, be it, identification of anatomical structures, then false passage of the tracheostomy tube, disastrous situation that can happen because of the edema, the loss of planes, etc. And that's why even if an emergency tracheostomy is done, we have to make sure it is confirmed by capnometry. And if fiber optic bronchoscopy is available, it should be used to reconfirm the position of the tracheostomy tube inside the trachea, as well as the tip position from the carina. I think that, the answer from my side.
Thank you. That's good. Very well explained. Now we have last 1 minute left. The last question also for this session. Dr. Jaripal, failed extubation. We spoke about failed extubation when we may not be able to safely extubate all the cases. So how do we actually, question should have come before the tracheostomy. In head and neck surgeries, post-operatively, when we fail to extubate, how do we plan for re-intubation?
All right, this is quite a dangerous situation. If you fail, one thing which will give you confidence is how was the intubation prior to the surgery? Okay, if that is okay and it is not caused after the surgery, does not disturb the airway, you need not worry too much about it. Now, why has the patient failed? Is it because of edema or something? Then that's dangerous. So if it's a surgery at the base of the tongue, in the tonsillar area, and maybe very close to the epiglottis, these are the very, very dangerous ones. Okay. Or following the surgery, they have put up a big flap in the mouth and your access is limited. That's another situation. Okay. Now, our priority at this point would be just like in bradycardia. When you get a patient with bradycardia, what do? You have to start thinking of pacing. Likewise, here, you better think of the surgeon first. Okay. Ask somebody to call him. In the meantime, you start your work. Okay. Our priority will be to get the equipment organized, at the same time try and oxygenate the patient until we can hold them on, until we can use the equipment. So what are the ways we can do? We can probably start with the high flow of oxygen, like 15 liters of oxygen with mask. It may not work. Try and put an nasal or oral airway into the FT and try and oxygenate. The other option is if you have an ICU NIV, you could probably use that with a high FiO2. That's probably a good thing, provided the face will allow the mask to be fit. Okay, this is something which I found to be useful, but the anatomy has to be good enough for us to do that. Okay, these are some things that you would do. Now, if for some reason the patient goes into the state where I cannot do anything on top, this is where I would try something like an endotracheal tube through the nose. Make sure it ends in the pharynx. Okay, I'll close the other nostril, keep the mouth closed, and ask a second person to help me ventilate with an ambu bag with supplemental oxygen. It might help us maybe get some oxygen into the system. Okay, it might buy us time. In the meantime, if you have a video scope or something, get it ready, try it. You should never use a fiber optic at this stage because it can be very, very dangerous. Secretions can be in the way, all sorts of difficulty you face with the fiber optic. Okay, so video laryngoscope is probably the best option at this point, but the quicker way to get the airway is probably to use a conventional scope, because with the video scope, you need a tube, you need a stillet. It should be curved in such a way that it should go in easily. Those are the problems. Whereas, try with the conventional scope. That doesn't work, you go with the video scope. Okay. In the meantime, get ready for the surgery. You can even clean the area for the surgeon so that there's no delay in starting the procedure. So this is how I would go about doing this thing. Okay.
Thank you, Dr. Paul. It was a great information. Actually, we all of us got into a lot of practical knowledge about how to go about managing the post-operative airway, like from deep, delayed extubation and the complications of delayed extubations, complications of tracheostomy and emergency tracheostomy and emergency re-intubation. Very great, good information. I feel all of us had a very thought-provoking discussion. We always think of securing the airway, when you don't discuss about the post-operative airway. I think we're giving some ideas about ProCon session next year time also. I think we're up to time is also up, I think. Is there anything to be added by the panelists?
Can we just add 1-2 quick points? Just listen to the discussion, excellent
Please,
discussion from Dr. Das, Dr. Manas, and Dr. Jerry Paul. So one thing about extubation I want to say is extubation is always elective. So we should try not to fail, because don't be in a hurry to extubate. So intubation, you may not be able to, but, have time and you may need to intubate. But extubation is an elective procedure. So you must do a proper assessment and you must plan for failure. You must, if you think it's a borderline case, have the surgeon ready there. Use a bougie, extubate over a tube exchanger, use a bronchoscope. You can prevent failure. So it's not acceptable to have a failed extubation in this sense. So I really feel we should focus more on preventing this. And the second point, Dr. Manas made a very important thing, discussion on emergency tracheostomy. From my experience now, I have seen that one, if a patient presents in stridor, I never give them anesthesia. And the second place where high flow, as he said, has a very good role is sometimes you're doing one case and a patient has come with stridor. We saw that so often in a cancer hospital. And you start them on high flow. And this really stents the trachea open. It makes the patient much more comfortable while you're waiting for an emergent tracheostomy for the surgeons to do. Just start them on high flow nasal cannula oxygen. It really gives the patient a lot of symptomatic improvement, and it also helps you tide over that time while you're waiting for the tracheostomy. Just 2 points I wanted to add. Thank you.
Anybody else who wants to add on so many points?
I just want to add one point. See, this is in emergency tracheostomy. Okay. What the surgeon has typically finding the trachea? It can happen. Post-radius neck, it's looking like a wood, and then they are not able to identify the trachea. What we do, recently I started doing, is use the ultrasound, identify the trachea, put a large one needle into the trachea so they can trace and go into it. Okay, that started helping the surgeons a lot these days. Okay, I just wanted to make this point. The other thing is that when they do an emergency tracheostomy and then they are struggling, we should not be standing on this side and say, bradycardia, saturation dropping. See, we're trying to rush them. Don't do that. We should give them that moral support they require to make sure. This is a team effort, and we all want the patient to be safe, isn't it? Our idea is to keep the patient safe. And so always support them and be with them all the time. Encourage them and say, I'll take care of my side, don't worry. Thank you.
Thank you.
Thank you, sir.
This delayed extubation strategy, which was being followed in many centers. I had gone through a paper which was published in 2005 by IRCH AIMS by Professor Sushma Bhatnagar and Seema Misra. They had followed over 2 years on 264 patients. They didn't do a single tracheostomy. All delayed extubation and with overnight intubation with fentanyl midazolam infusion, and they found a very good result. So by this we can curtail unnecessary tracheostomies. And but one thing, if we find after the extubation, we should be more vigilant. It needs multidisciplinary approach because many patients, other than the surgical complications, many are geriatric and patients with cardiopulmonary issues, and they suffer from cardiopulmonary failures. Although they have distress, they need post-op extubations followed by intubations 2 to 3 times, and they deteriorate afterwards because every intubation is very stressful for those patients. So it is not that easy to conclude that tracheostomy is not required in many patients, but because of they are geriatric with so many comorbidities, and at times there is gross upper airway edema, bleeding, all those issues, many patients, they require emergency tracheostomy or emergency fiber optic intubation in the second or third post-op day.
So thank you all the panelists, and thank you, Doctor. So we had a wonderful discussion, and very, very thought-provoking, and everybody will start thinking then how do we go about whether delayed extubation, delayed extubation, or a tracheostomy. And it's a very good discussion. Thank you, everybody. I think we're all.
Thank you, everybody, for enriching our knowledge with your valuable inputs.
Thank you.
Thank you.
Thank you, madam. Thank you, Sheila, madam, Dr. Shobhashachi Das, Dr. Jerry Paul, and Dr. Manas Khan for your extensive experience sharing with us. Thank you so much.
Thank you, madam. Thank you.
Thank you.
Our next session is on hypotension in microvascular reconstruction surgeries, how to manage. The speaker is none than Dr. Rakesh Garg. He is the additional professor, Dr. Brayark and the National Cancer Institute, AIIMS, New Delhi. He was executive member of he is the executive member of Society of Oncoanesthesia and Perioperative Care, editor-in-chief, Journal of Oncoanesthesiology and Perioperative Medicine. He is associate editor, Journal of Anesthesiology and Clinical Pharmacology, associate editor of Indian Journal of Anesthesia too. He had many awards during his tenure of anesthesiology, like Dr. Y.G. Bhojraj Award, ISA Bhopal Award, ISA Bhopal Proficiency Award, Outstanding Scientist Award, Biography in Who is Who in the World, and second best research paper awarded by Singapore Medical Association. He had many, like 250 publications in different journals, and authored many book chapters of the books. So may I request Dr. Rakesh Garg to please start your lecture.
Thank you so much for your elaborate, kind words, ma'am. Thank you so much. And thank you, the whole organizing committee, including Dr. Josna, for giving this opportunity to talk on this important topic. Because when we talk of oncosurgical interventions, microvascular reconstruction are important part of it, because it leads to a lot of facial disability, and hence timely microvascular reconstruction is important. But since we are doing it for cosmetic purpose, for filling the gaps and so on and so forth, we should be very cautious about its survival also. The graft should be patent, the graft should be working, and it should give a cosmetic outcome also. So I bring greetings from my institute. I work at Cancer Center of All India Institute of Medical Sciences, New Delhi. When we talk of microvascular reconstruction, flaps or grafts, they are units that are transferred from donor side to recipient side while maintaining its own blood supply. And the flaps are usually classified based on the blood supply composition and location. And accordingly, depending upon the site involved, depending upon the defect, they can be of various type of flaps that we used. When we talk of free flap, it's an island flap detached from the body and reattached at a distant recipient site for the reconstruction purpose. And it requires microvascular anastomosis. And this is one of the usual flaps that would be done for various surgical procedures. Now, before I go say hypotension, what are the concerns? Why are we concerned about the hypotension? Because the survival of a microvascular free flaps, the journey of the flap during surgery, there will be three basic period of it. One, primary ischemia, second, reperfusion, and third, secondary ischemia. All the three phases are very, very important because the survival will depend upon various concerns in these three phases. In primary ischemia, the vessels are clamped. There will be pro-inflammatory mediators which will collect in them. And the severity of this collection will be proportional to duration of the this graft harvesting. And this issue with high metabolic rate, they are more sensitive to ischemia. So this means we have to create an environment in which these pro-inflammatory mediators are flushed off. And hence, if the perfusion is not good, maybe because of hypotension, the survival will be affected. Similarly, the reperfusion injury that can happen in these when the clamp is declamped after the anastomosis. In that situation also, if some amount of those inflammatory mediators which are present, they can cause reperfusion injury. And this is again an important aspect because it will again have an impact on the survival of graft. Secondary ischemia. This can also happen, and the primary reason in these situations are the result of flap hypoperfusion. And the reasons could be many. Maybe hypotension could be one of the reasons for it. It occurs after flap transfer and reperfusion, and there could be association of some thrombosis or edema in the flap transfer issue, or because of a surgical trauma, there could be edema. And in this situation, this ischemia can be tolerated by muscles for some time, but if it persists, it will lead to irreversible damage to the grafted tissue. And hence, we have to minimize this insult as well. And that's why the perioperative anesthetic management has an important role. We have to maintain a hemodynamic stability. Both hypotension and hypertension, both are not good for them. We have to avoid these things so that a desired regional blood flow into this flap structure is maintained. And this may be influenced by the technique that we use, changes in the blood volume, the use of certain drugs, anesthetic drugs, and at times the vasoactive drugs also, wherein we try to attempt for the hemodynamic stability. But the crux is, we have to maintain the perfusion pressure for this. We have to avoid the hypotensive episodes. And this can be done by adequate anesthetic depth, choosing the anesthetic technique appropriately. Analgesia has to be appropriate. And simultaneously, the fluid resuscitation has to be done very judiciously. Both hypo or hyper infusion of the various fluids, whether crystalloids or colloids, they can hamper the flap. So we have to be very concerned about the maintaining of normal volemia in these patients. At times, these patients would require some of the drugs, and these drugs should be used appropriately so that they again do not compromise the newly grafted flap. And we know there are a couple of studies where they have mentioned various factors which affects the flap perfusion, including the mean arterial pressure or the vessel diameter that can decrease because of the surgical cause or because of vasospasm, and along with the blood viscosity. So this means, again, hypertension is one, but other factors are in sync with it. So we need to, when I say that management of hypotension, it's just not the hypotension that can affect the graft. Simultaneously, other things can happen, and we should be very, very conscious. And these are the patient profile in which we would expect that these things can happen with regards to flap viability. And again, this the hemodynamic management or avoidance of especially hypotension remains the important parameter. So if you see the management plan, so you can see that half of the slide is primarily again based on the hemodynamic stability, prevention of hypotension, maintaining the flap perfusion pressure, preventing the vascular narrowing, which is again a regional hypotension. Maybe the patient is having a normal blood pressure, but a regional hypotension because of this vasospasm or happening of the vascular narrowing, that also needs to be taken care of. So we should not be always looking for a invasive blood pressure monitoring or a non-invasive. Yes, blood pressure is okay, but what is actually happening to the graft tissue, we also need to look for, because there could be a regional hypotension, and hence we should be cautious in preventing it. The flap survival becomes better. When we talk of regional anesthesia, yes, it has many benefits, but yes, there are some advantages and pitfalls. Because of sympathetic blockade, they can cause profound hypotension. It can also cause steel phenomena, especially if you're talking about the lower limbs degrafted or some flap surgeries. May not be a big issue in head and neck surgery because we don't use regional blocks much there. But yes, lower limb surgeries, when we use hypotension, this could be the potential pitfalls, though it provides a good analgesia, but we should be aware of this phenomena also. So this means, to summarize, there are many reasons for hypotension to happen in this patient. Obviously, the surgical blood loss, that can be there, but also the anesthesia-related effects, the constraint of stick fluid management, still there's some controversy, how much fluid is appropriate, and the concerns related to vasopressors. In other surgeries, we go ahead and use the low dose of noradrenaline or phenylephrine or other drugs to maintain the pressures. But in this, there are certain concerns which, though not well proven, but yes, there are concerns. But if we talk of management strategies, I will just put it this way. We have to look for the other factors which I mentioned earlier. We have to prevent the vasospasm. The surgeons use a good surgical technique. They use a local vasodilator, prevent a good analgesia. These are one aspect. But the other aspect is maintenance of intravascular volume replacement appropriately using crystalloids or colloids, and blood pressure support. So we have to use the vasoactive drugs judiciously once we have maintained the normal volemia. There should not be hyperhydration or overhydration. Overzealous hydration is not good because it can lead to the flap edema, and it can again cause regional hypotension in the flap. So we should be very cautious, and we have to think of both, just not the blood pressure by the non-invasive blood pressure or radial artery monitoring, but we should be looking towards the flap also. And if we see this study, there are data that whenever the fluids goes on a higher side, like for example, this study, wherein they found that around 5.5 liters, there was increased medical and surgical complications. If there remains more than 7 liters in the perioperative period, the flap-related complications were the independent risk factor. Even more than 20-30 ml/kg in another study over 24 hours, again increased morbidity with regards to flap. With regards to type of fluid, crystalloids, yes, normal volemia is good, but if you give excess, local edema will happen, will compromise perfusion again. Colloid, hydroxythiol starch has been used, but gelatin has also been used. They have all plus and minuses. They expand plasma, decrease blood viscosity, better perfusion, and hence possible survival of the flap. Now, if you just try to summarize this, irrespective of fluid, we have to maintain the hemodynamic perfusion of the flap, looking after the systemic effect and the local effect, and that becomes very important. For the systemic consideration of fluid, we may use the cardiac output monitor, we can use the arterial monitor, we can use the urine output as a good marker, and this will give you that overall perfusion of the body is good. But simultaneously, we should also be looking for the factors of the regional hyperperfusion or regional hypotension in the flap area, and that also needs to be looked locally along with the surgical intervention that is being done here. Blood transfusion is another strategy because we have to give them appropriate blood transfusion so that oxygen carrying capacity is good. But simultaneously, we also need to realize that these are oncosurgical procedures. We were discussing in the morning also that these patients are very prone. Any immunomodulation by blood transfusion, unnecessary blood transfusion, can lead to possible increased chances of the cancer recurrence or cancer metastasis. So we have to be very cautious. Now, vasopressors, I think this is one of the controversial event, and many of the surgeons and the anesthesiologists have a huge concern whether to use or not to use. What vasopressors at what dosages? Now, these are major issues, and the controversy is still existing, though they say that we need a no maintenance of blood pressure and cardiac output. If you are using cardiac output, a stroke volume variation of less than around 10 to 12%, okay. PPA, you should try to maintain between 60 to 70 millimeter of mercury for these patients so that perfusion and expectedly regional perfusion will be maintained. Now, let's see this good article wherein they have found certain factors which can affect the blood, and they were looking for the intraoperative hypotensive episodes when this surgery was done for head and neck cancer patients. And they found that almost they reviewed around 450 patients of big head and neck surgery procedures, and they tried to find out through logistic regression that what were the variables here. And they found that the intraoperative hypotension and the large volume fluid administration. Now, this is the standard practice. If hypotension, the first management plan is fluid management. So having hypotension with fluid resuscitation, but if it becomes overzealous, this was associated with flap loss. Neither blood pressure liability nor vasopressor administration was significantly associated to the primary outcome, which was here the flap failure. So this means the regional perfusion has to be maintained, hypotension has to be avoided. Fluid is not the only media, only source, only strategy to maintain the perfusion. You have to look for the other agents, and vasoactive agents have been found safer in this large cohort of almost 445 patients. So that's why the authors conclude that intraoperative hypotension is associated with flap failure in head and neck surgery, and as is the large volume fluid administration, and probably the use of vasoactive agents, vasopressors, probably are supporting that it can maintain perfusion and should be used for this. With regards to what fluid and how to monitor it, yes, whether it should be liberal or restricted or goal-directed. And this is an interesting study where they have used goal-directed therapy in a cohort of a big patient group where these patients were requiring microvascular free flap reconstruction after the breast surgeries. And they found that the goal-directed fluid therapy using minimally invasive cardiac output monitor, the pulse pressure variations, They found that the hemodynamics were well maintained, and the rescue fluid administration during the perioperative period was restricted. So this means if you're targeting and goal directed using some objective monitor, probably we are able to maintain the hemodynamics better with appropriate total fluid requirement in these patients. That means the goal directed therapy appears to be good for this. Now, another study, when we talk of vasopressors, again in head neck constructive surgeries, last studies where they look for the effect of free flap outcome when they have used intraoperative vasopressors for the free flap surgeries, and they were looking for flap survival, the thrombotic phenomena, the revision surgeries because of the some cyanotic phenomena that is happening in these patients. And they found that the perioperative use of vasopressors, again, they were not adversely affect the outcome in patients requiring head and neck reconstructive free flap surgeries. And this means they just concluded that it is beneficial considering the avoidance of complication of liberal intrafluid management. So this means if we just try to summarize it, a judicious fluid management along with, if required, use of vasopressors probably would be a good strategy for maintaining patients with free flap. We should not be afraid of for using vasopressors, but yes, after maintaining some goal-directed fluid resuscitation and then using them would be appropriate. And this is again the concerns when we talk about the vasoconstriction and potential secondary ischemia that I was talking in the beginning, leading to necrosis of flap. Various drugs like epinephrine, dopamine, or phenylephrine, whether they decrease or increase. So again, in this study, they were able to conclude that the administration of vasopressor did not affect the rates of reoperation, complete flap loss, partial flap loss, or fat necrosis. So this means, again, I think we are reiterating again and again through various evidence that we have that the perioperative use of vasopressors, even like noradrenaline, will not affect the free flap outcome in these patients who are requiring microvascular reconstructive surgeries. And the background of this, if we see the detailed conduct of methodology of this section, most of these studies were using some goal-directed fluid management. So there was nothing called the liberal fluid management was not done. The restricted fluid management was not done. So there was some goal-directed, there was some endpoint, and then they were using vasopressors. So probably if we not target some goal-directed and remains restricted fluid regimen and then try to give vasopressors, probably we will lose the flap. But if we combine them effectively, some objective parameters of fluid management and then give vasopressors, yes, it is. And that's why this is a good review where they have tried to summarize the free flaps management, and this is a good survey. If you see the clinical practice guidelines, majority of people in this survey, when they were asked that what type of preferences they use for managing the hypertension, majority of patients, more than 98% of patients, were using fluids. And they were concerned of vasopressors. Vasopressors were the last choice in many of these patients. So there are concerns here. And probably the overzealous fluid administration probably would be a concern. So I think we need to understand a balanced approach would be more appropriate. And when we say fluid administration, the ringer lactated, yes, it remains one of the good choice, was the preferred solution for resuscitation in these group of patients. The use of colloid and dextrans, they have been found some useful in maintaining the viscosity, maintaining the perfusion. The dextran has been mentioned in some study, hypotonic saline has been mentioned, but they do not have been mentioned much role nowadays because we have other strategies to follow. We have some goal-directed therapy and hence we have found them useful. Now, this is a wonderful meta-analysis that solves all our problems now. And a recent one, where they have looked for vasopressors used in free flap surgery, a very big meta-analysis of 14 studies finally, which they have included. And when they say that the use of vasopressors, they did a meta-analysis, so we can see from this that the effective use of vasopressors after fluid resuscitation, goal-directed, the use of vasopressors were favorable for the flap survival. So this means we should not be afraid of. And similarly, not only this, the occurrence of thrombosis were less in patients in which the perfusion was being maintained using adequate fluid and vasopressors. So this, I think this is a very good analysis, and we should be very sure that we should not be afraid of using vasopressors like phenylephrine or noradrenaline. Some people do prefer dopamine for increased perfusion. They can be used in these patients and the survival will become much better. Even for even if you see the oral flap complications like thrombosis, ischemia, necrosis, wound occurrence, The oral complication, they say again, there is not much difference. This means the use of vasopressor is not increasing the overall complication. They're not favoring it, but they are not increasing the complication. So this means we are rest assured that we should be okay with the use of vasopressors in case if it required after fluid resuscitation. So that's why in this analysis, they found that we can use the vasopressors appropriately, but yes, we need a more big, robust controlled trial, randomized controlled trial to look for which vasopressors are safe, at what doses they remain safe, because we have not talked about the dosages here. So we need to look for that, whether at what dose of vasopressors like noradrenaline or phenylephrine would be safe in these patients, because some patients may require higher doses, so that we should be cautious. So this means the management strategy, the traditional, when we say fluid administration may not be appropriate nowadays. We have to use appropriate combination of fluid and vasopressors to maintain the hemodynamics that is very much required. So all the controversies, so I'm not going to read this slide, I have discussed it, but I have mentioned this slide, there has been a lot of concerns, but then we need to emphasize here that we have to use them judiciously, being norepinephrine, epinephrine may be the first line of treatment for ongoing intraoperatively and post-op hypertension after fluid resuscitation, and then you can use epinephrine as a rescue in case if you still have the hypotensive episodes. The judicious use of phenylephrine and ephedrine to treat hypotension is acceptable. I think this is the crux once you have taken care of the fluid resuscitation. Regarding fluid, again, just to summarize here, we should maintain the normovolemia. A surrogate marker could be the urine output. If you have the availability of a cardiac output monitor, that can be used. Crystalloids are the preferred one. Be cautious because these free flaps are devoid of lymphatic drainage. Any excess fluid, bolus fluid, can affect the outcome by causing more of a reperfusion injury. So be cautious about it, and use of goal-directed therapy is always an important aspect. Use balance out solutions. The use of hypotonic solutions, absolutely no. Maintain the perfusion. You can use colloids like hydroxythioesters if available, but be cautious about its contraindications. Transfusion, yes, if required. I mentioned earlier, you can give blood transfusion as required on an individual basis. All patients should not be targeted of 10 gram of hemoglobin. Probably 8 gram per deciliter would be appropriate with good perfusion. Vasospasm, this is again this is a regional hypotension. So the type of surgical intervention, if they have a tight suturing or there's some stress, because about it, try to take care. Surgeons will help to use vasodilators. Sympathetic block, epidural block, especially the lower limb surgeries, be very cautious about the steel phenomena and hence use them cautiously to prevent this. To summarize, prolonged intraoperative hypotension can affect the free flap. Maintain a mean arterial pressure. Fluid should be targeted using a goal-directed manner. Use vasopressors in the setting of normovolemia, and large prospective trials are needed. So thank you so much.
Thank you, Dr. Garg, for your extensive lecture. And it's really very lucid. Still, can we be able to make the surgeons aware of using vasopressors during free flap surgery? I think many of the surgeons do not believe in and do not like to using this vasopressors during free flap surgery. What is your opinion in your institution?
Yeah, I think we should have a team.
After having so many studies on using the vasopressors, it has got a limited role, or if we can use it judiciously. But we are not being able to make them understand.
I think it's a tough with close interaction, with understanding, and giving them out a good outcome. Probably it will help the situation, because when they see that we are using this combination of drugs or fluids and the outcome is good, I think nothing to worry about. Because finally, if they see 5 patients are having a good outcome, in spite that you have used vasopressors, so once they start seeing your good outcomes, they will have full faith on you, and then whatever you do, it's acceptable to them. Yes. Any change in practice is little difficult. I fully agree, because if somebody is for last so many years is not comfortable with vasopressors, and you said on one fine day that doc, this is surgeon, this is having hypertension, can I use vasopressors? So there will be little concern. But then finally, we have to be cautious that whatever we are using, if we use it more evidence-based scientifically, probably the outcome becomes better. And when you start giving good outcome, the surgeons have good faith on you. And we can always interact with them. Okay, let's see if they are absolutely not comfortable. Let's have a clinical combined presentation of 2 or 3 cases, and let's see what we missed it. And when we try looking for evidence, I think that interaction, that combined seminar or combined interactions or combined grant rounds will help to resolve this issue. I think, yes, this is doable.
Okay, thank you very much.
Dr. Gaur, I have one question. So far as vasopressor use is concerned for perioperative maintenance of flap perfusion, first of all, we have to maintain the normovolemia, and to maintain normotension, that to maintain the mean arterial pressure above 65, we have to add the vasopressor. And the first line of drug is norepinephrine or dopamine. But what's about epinephrine and phenylephrine? Many literatures they show that phenylephrine and epinephrine, they have some deleterious effects so far as hypoperfusion of flap is concerned, and they may cause vasoconstriction and thrombosis also.
Absolutely, I fully agree. We do not have a very robust evidence comparing and about the 3 drugs that you just mentioned, adrenaline, noradrenaline, phenylephrine. But if you see the literature, the first line of therapy mentioned in majority of studies which they have used is in norepinephrine, and they have found that it causes good perfusion to the vascular organs without causing intense vasoconstriction. Dobutamine has also been considered because it causes a little vasodilatation and probably will be helpful on the background of normovolemia. But what the literature says that in case if you are not able to maintain good perfusion with the use of noradrenaline and normovolemia has been maintained, then as a rescue measure, the phenylephrine or epinephrine can be used. But yes, when you start using them, the compromise of vascularity of the flap tissue can happen. So you have to monitor it very cautiously and try to look for the reason of hypotension, because there would be some underlying disease. There would be, say, maybe some amount of toxemia, because reperfusion injury, when it happens after long surgery, the toxemia can lead to cardiac depression and decrease in the blood pressure. So simultaneously, we should be looking for the reasons for hypotension, try to correct them, and temporarily we can add on the vasopressors and try to taper off them as soon as possible.
So we have a question actually for Dr. Garg. Should cardiac output monitor be used in every free flap cases? Your suggestion?
I think it's not required. We are not using it for every patient. Usually it depends upon the extent of surgery. If you have a major dissection, patient has some associated comorbidity, you are expecting that there will be a major blood loss. In those situations, yes, cardiac output monitor will be a good option. A small surgery, usually head and neck patients do not have much of blood loss. So in those situations, probably we can look for the other surrogate markers, including the blood pressure and the urine output. And if required, you can always measure the lactate levels. That again is a good indicator of the perfusion of the end organ tissues. So they will be a good marker. So the cardiac output monitor is not an absolute requirement for each and every free transfer. If required, in specific individualized situation, we can use it. And the reason would be associated patient comorbidity, major surgical procedures with extent of major shift in third, major fluid shift, or major blood losses.
Okay, thank you, Dr. Garg. So let us ending our session. My heartfelt gratitude to the organizers, Dr. Jyotsna Goswami and her team, for giving me this opportunity as a faculty of SOAPCCON 2021. Thank you all.
It was a wonderful session. Thank you, ma'am. Thank you, sir. Now I hand over to Dr. Noor Fatima Akram for the next session.
Dr. Divyendu Khan, Consultant Cardiac Anesthesia, Apollo Hospital, Kolkata. And Dr. Punita Chokalingam, Associate Professor, Adyar Cancer Hospital. Welcome, sir. Welcome, madam. Over to you, sir and ma'am.
Ma'am, please unmute.
Good afternoon, everyone. So I would like to invite the panelists, Dr. Sanjay Upate, Dr. Dilip Thakkar, and Dr. Negha Desai to this session on cardiothoracic oncoanesthesia. Dr. Sanjay Upate is Professor and Head of Department of Anesthesiology and Critical Care, Asian Cancer Institute and Kambala Hill Hospital. Dr. Venugopal Kulkarni is Consultant and Head of Department of Anesthesia, but I think unfortunately he couldn't join us. Dr. Dilip Thakkar is Department of Anesthesiology and Perioperative Medicine, University of Texas, MD Anderson Cancer Center, Houston. And Dr. Neha Desai, who's an Associate Consultant at Tata Medical Center, Kolkata.
Hello.
Yeah.
Can I share the screen?
Yes, sir. Now you can share.
Yeah.
Can we start the panel discussion on recent advances in thoracic oncosurgery?
Yes. So I welcome all the panelists. Dr. Punita has introduced the panelists to all. And I welcome all the panelists for this wonderful discussion on recent advances in thoracic oncosurgery. Now, in last 1 decade, we have seen so much of evidence has come in field of thoracic anesthesia. And I would like to sort of touch upon each particular aspect of these sort of different evidences which have come in last 1 decade. So to begin with, we'll start with the case discussion. So we have a 69-year-old patient who is 173 centimeter tall, farmer by occupation, and a chronic smoker. Is presented with a cuff with hemoptysis and a weight loss. His current weight is 52 kg. CT scan shows a right lower lobe CA lung, and he was planned for a right lower lobectomy or right lower bilobectomy. So the approach would be a open posterolateral thoracotomy. And his pulmonary function tests are like this. So FEV1 is 2.01 liter, that is 55% of predicted. FVC is 2.52 liters, which is 70% of predicted. FEV1 by FVC ratio is 79. DLCO is 75% of predicted. Bronchodilator reversibility is not significant. So his predicted postoperative functions are coming as, for right lower lobectomy, the PPO FEV1 is coming to be 39% of predicted. PPO DLCO is 53% of predicted. And for bilobectomy, PPO FEV1 is coming as 31% and PPO DLCO is coming as 42%. So this sort of picture we quite often face in our clinical scenario, where the patient's PPO FEV1 values fall below 40%. So the first question to my panelist is, I would like to start with Dr. Upadhyay. So do you want any additional test in such circumstances? I mean,
the preoperative FEV1 and DLCO look fairly okay, but what is worrisome is the PPO, DLCO as well as FEV1. Now, with single lobe excision, there is a sizable drop, and with double bilobe excision, the drop is even more, and therefore they could fall in a category where you will find yourself in a dilemma whether to operate or not. Now, question is, we cannot leave them like that here. We must find out more whether the picture is true or not. So I would rather have patient go for a 6-minute walk test, find out whether he performs it well and can be satisfactory. That is one indication that we may still operate on this patient. And I think the best way to go is to do a CPET, that is a cardiopulmonary exercise testing, which gives you the value of VO max. If the VO max can be satisfactory, above 15 ml, 20 and more is what ideally you want. But if it is more than 15 ml per kg per minute, I think you may still go ahead with this case, because FEV1 and especially FEV1, you still, or even DLCO, you cannot be still sure whether the values may be truly indicative of the patient's capability. So ventilation perfusion scan will find out more about whether how much these to be resected segments are contributing to the whole picture. So I would also like to find out more about VQ mismatch. All these tests I'm referring to are to find out more about this patient so that he can be brought back into the situation where you can operate. Now, even arterial blood gas analysis can to certain extent help you if your PCO2 is higher than 45. That's a bad indicator. All these tests I would like to have more than this.
Thank you, sir.
There is a product nowadays they suggest FEV1 multiplied by PPO FEV1 multiplied by DLCO, and it should be somewhere around 1650 or more to put him into. Lastly, and not the least, if you can avoid biolobectomy by doing a pulmonary sleeve resection, you may still operate on this patient. So consider talking to the patients and the surgeon to find out if it can be done, so that you can restrict your surgery to single lobe excision. And prehabilitation suggestion, prehabilitate and bring back.
Right. So, Dr. Sanjay Upadhyay just now discussed about the perfusion scan, which can give us a real-time idea of how much the each lobe of the lung is contributing to. So, definitely yes. I would like to ask Dr. Dilip Thakkar, in which particular cases do you send the patients for CPET examinations? Dr. Thakkar?
Okay. So at practice at AMD Anderson, what we do is anytime we have just done the basic pulmonary function testing based on the patient's clinical history, whether it's any cardiac history or any other pulmonary history, basic PFDs, if they are borderline, like, 60% or 30% or less than 30%, we sort of decide. So if it's, predicted postoperative values of FEV1 and DLCO is around 60%, then they can proceed for the surgery because they are low risk now. But if the predicted postoperative value of FEV1 and DLCO is anywhere between 35 to 60%, then we kind of do either a shuttle walk test or stair climbing test and see if they pass. If the stair climbing, the standard recommendation is 22 meters and the shuttle walk is about 400 meters. If they can do that easily, then again, they can go for the surgery. The next thing is if the FEV1 and DLCO predicted is less than 30%, then you do CPAT. Or if they fail the shuttle walk test or stair climbing test and FEV1 and DLCO post-op predicted are anywhere between 35 to 60%, then they can go to the CPAT. And the CPAT typically, helps you to kind of rule out whether this patient is not meeting the criteria due to either cardiac problems or the pulmonary problems or any other systemic issues that the patient has. And then again, the standard values at our institution is anytime Vmax more than 20 ml per kilo per minute or more than 75% of the predicted post-op, they are clear for the surgery. They are considered as a low risk. If it's anywhere between the 15 to 20 or 10 to 20 ml per kilo per minute, then we consider them as a moderate risk. And then anytime it's less than 10 ml, then they're high risk. So CPAT has value, but we traditionally do the spirometer and basic predicted post-operative values of FEV1 and DLCO.
Thank you. Thank you, Dr. Thakkar. Any role of minimally invasive surgery? Would we be able to improve the outcome by doing a minimally invasive surgery in this particular case? Can Dr. Neha answer this?
Yes. Thank you, Dr. Swapnil. So it has been shown in various studies that patients with marginal or poorer lung functions, like this kind of patient, do benefit from minimally invasive surgery because it reduces the morbidity associated with a large thoracotomy incision. So it has been shown that these patients benefit in terms of reduced post-operative complications compared to open surgeries in these similar kind of patients. So there are complications which include air leaks or atelectasis or mobilization. And there is not much benefit in terms of mortality, but in post-operative morbidity, minimally invasive, whether it is thoracic wax or robotic wax, there is definite advantage for patients with marginal lung function.
Right. And as Dr. Sanjay Upadhyay also suggested, a sleeve resection, which is a pulmonary parenchyma saving surgery, may help in these particular cases. Thanks, all the panelists. So last, my question to all the panelists, what is the least PPO values that you would be okay with, considering a lung resection surgery? Just one single word answer. Least PPO values that you are okay with. Dr. Upadhyay, please.
40%.
40%.
40%. If none of the tests are available to me.
Okay, Dr. Thakkar. Please unmute yourself, please.
Yeah, I agree with Dr. Upadhyay. About 40% is typically we consider.
Around 35 to 40% is what we consider.
In recent times, there have been few papers which have compared the outcomes when the PPO values were falling between 30 to 40%. And some of the papers with the better preoperative optimization, minimally invasive surgery, a good thoracic epidural analgesia, and of course the battery of investigations in the preoperative settings, we can sort of stretch ourselves to somewhere near 30% around. But we'll move to the next topic, which is there have been a fair amount of newer lung isolation devices which have come up in thoracic anesthesia practice. And one of these particular device which has been everybody's interested about is VivaSight DLT. So I'll request all the panelists, whoever has used this particular device, can you share your experience with this particular device? Dr. Thakkar, please.
So this was originally designed in Israel, and we did the original study at MD Anderson. I think we did about 60 cases at that time. And we were kind of initially not optimistic about the device, but we started using it because they sponsored the study. So we had an interest in doing it. And now we are exclusively using VivaSight in most of the patients. They come in different sizes. They come only in the left-sided tube, not the right-sided tube. So they haven't yet figured out how to make a right-sided tube. The tube is as good as any other double lumen tube as far as the texture of the tube is concerned. They come from 35 to 41. Those are the sizes it come in. It doesn't come in the pediatric sizes. At our institution, typical intubation is done with video laryngoscope. In majority of the patient, it's a standard now instead of DL. So we use a video laryngoscope and to insert the tube. The insertion of tube is not a problem, but we really have to be careful in advancing the tube through the vocal cords, because any secretions when it falls on the camera, because there's a camera at the tip of the tracheal lumen. If there's any secretion, then your view can be a problem. And that's the challenge. So you really have to be careful and make sure that when you advance the tube to the vocal cords, you bring the camera side of the tube at almost at a 12 o'clock position. And once the tube has gone through the vocal cords, then you can literally look at the video screen on the tube and advance the tube and position it on the left side, which is usually not a problem. It goes on the left side. But again, if it goes on the right side for some reason, then you can still, if the camera is still functional, then you can reposition the tube. So that's the one challenge comes. But the advantage of this tube is, especially before, we used to turn the patient to 90 degrees. And when you do that, then you don't have control or you have to repeatedly do the fiber optic. But the VivaSight, if you turn the patient, then you have constant visualization of the carina. And you can tell, is it if there's a problem, the tube displacement, or it's very easy to see the right side, the right mainstem bronchus, if the camera is clear. So those are the things. And then there are some options on the tube. Tube comes with a little port. As you can see, there's a port on the right side here that is designed to flush the camera. If there's any secretions or something like that, you can use saline to flush it and suction it out, or you can use some air to flush it and suction it out. So those are some of the options you have to keep the camera clean. And so basically it's very useful tube. Once you get used to it and you have done a few times, you get a good idea of it.
Thank you, Dr. Thakkar. One question to you, does that completely obviate the need of a pediatric fiber optic bronchoscope, or do you still keep it ready in the OT?
We don't keep the fiber optic scope in the operating room because we have learned, we have been using it for, I think, probably more than 2 years now. And it's, that's what we've been using. And okay. So with experience, we have figured out that even though the view is kind of blurred, we are able to figure out the position of the tube because still the camera is good enough to give you some impression. Unless it's completely blocked, then you lose it. And in that case, we ask for the pediatric bronchoscope.
Okay, thank you. We move on to the next device, which has sort of recently been introduced in Indian market, and this has been the Easy Blocker. And I know this has been sort of around in the Western world, it has been around since a decade, but in India, it's been recently sort of marketed. So Dr. Neha, do you have any particular experience in using the Easy blockers?
Yes, so we have been using it here at Tata Kolkata for about almost 2 years now. And right now, this is the blocker that we mainly use wherever indicated in esophagectomies and in certain lung surgeries also. So compared to the other blockers, we found that the ease of insertion because of the presence of the two balloons is obviously easier, and it takes less time in placing it in the correct position. The bronchoscope is obviously necessary, but it gives the advantage of lesser time taken to manipulate the blocker and place it into the correct bronchus as required. The only prerequisite is the correct positioning of the tube, that you need adequate space between the tip of the tube and the carina to allow for the Y of the blocker to open up. So about 4 to 5 tracheal rings, which are necessary between the tip of the tube and the carina, which allows easy placement, straightforward placement into the respective bronchi. So with fiber optic, you confirm which balloon is in which bronchus, they are color coded. And that's how it helps in isolating. And we've not faced many problems with it until now, except one defective piece where the two balloons kind of were interconnected. So both of them kept getting inflated alternatively. But until now, except for the main, for pneumonectomies and right upper lobectomies, we've been using the blocker extensively and fairly without any complications.
Thank you. One of the sort of the tips of these particular blockers are quite pointed, and in fact there in the literature there's been one case report where the blocker has actually pierced and perforated the bronchus. Any such sort of complications?
No, we've not had any incidents of any complications, but yes, because it is as it goes with any blocker, the time to desufflation of the lung takes more time, and since this is a 7 French tube and it is very fine, so the desufflation of the non-operated lung, the operated lung takes slightly longer compared to other blockers and DLT, obviously. But so far, we've not had any complications related to injury of the airway.
Thank you. So I come to the next particular set of devices, which are the disposable pediatric fiber optic bronchoscopes. Now, these have been recently introduced in Indian market, and they have actually revolutionized our practice because earlier our pediatric fiber optic bronchoscopes used to be very fragile. We used to have a lot of wear and tear of these bronchoscopes, and many a times it used to happen that we are not having a pediatric fiber optic bronchoscope during the thoracic surgery. But with these disposable bronchoscopes, I would like to ask Dr. Upadhyay, do you have experience with these sort of bronchoscopes, and how do you take care of them? How do you re-sterilize them, or do you use it only for the one patient, or is there any way by which means you can use it for other patients also?
We have been using the disposable pediatric or even adult bronchoscopes of a given company for about 3 to 4 years now. And I hope our discussion is not illegal by saying that we re-sterilize them, because it is recommended that they should not be used after one use. They are disposable, as the name suggests. So we cannot afford to throw them away because they are in good shape after the use. And we do put them into Sidex as you put any other non-disposable bronchoscope into Sidex for about 20 minutes before use. Clean them, put them in Sidex, clean them again with saline, and get back into using them. ETO should be more advisable for sterilizing them, but it's not practically possible because ETO cycles are long, and ETO cycles require a particular amount of material for them to use it frequently. They cannot do it. So no CSSD will help you in doing the ETO. Do we have any cross connection here?
I suppose we have. We move on to our discussion further. Now, in recent times, the main concerns about intraoperative or the postoperative outcomes has been the postoperative pulmonary complications. And one of the causes which has been identified for the postoperative pulmonary complication has been the acute lung injury, which occurs to both the lungs during the thoracic surgery. And the incidence which has been described around 2 to 5%, and it severely affects our mortality as well. Yeah. So the question that comes for the thoracic anesthetist is what care should I take during ventilating, during one lung ventilation? And so that brings us to the principles of protective one lung ventilations, which have been laid down recently. So I'd like to ask Dr. Thakkar, which particular mode of ventilation do you use during one lung ventilation? Whether it's do you prefer pressure control, or are you okay with volume control as well? Please unmute yourself, sir.
So at MD Anderson, we are about 18 thoracic anesthesiologists. So we have a specialty subgroup. So we are 18 people in the group, and everyone has a different opinion about which mode they want to use. And we have residents and fellows. So it's a teaching institution, so slightly different practice. But I would say 50-50, pressure control versus volume control, because at the end of the day, all these new ventilators are pressure limited, so they won't let you deliver more than a certain amount of pressure. Many studies have done different advantages and disadvantages. There is not much of a difference in those studies. Maybe slight advantage of volume control, pressure control ventilators, where you have a little bit of better left ventricular function because of pressure control. But at the end of the day, the goal is to maintain the tidal volume, recommended tidal volume, and the peak airway pressures and the pleural pressures to prevent the barotrauma and postoperative pulmonary edema and ARDS situation. So the tidal volume is a criteria we use, no matter which mode we use. We maintain the pressures, peak and pleural pressures within normal limit. We do allow a certain amount of hypercapnia or permissive hypercapnia to occur around 50 to 60. 60 is easily tolerated by the patient, and there are some advantages and disadvantages. So you have to be really careful with that. We do try to keep the FiO2 down as little as possible. Typically 50-50, patient tolerates the oxygen saturation on the pulse oximeter. Anything around 90 is our acceptable limit. 88 to 90 is our acceptable limit. And then, of course, we use some PEEP or CPAP if required during the procedure. So those are the standard lung protective mechanisms we use, but not particular about either pressure control or the volume control.
Thank you. So I think you had answered almost all of my questions. So I may skip some of the questions here. The other question that comes to our mind is how much PEEP do you individualize the PEEP, or how do you choose the actual PEEP? Can Dr. Neha answer this?
Yes, so we start with about a 5 to 6 centimeters of PEEP in almost all patients, which is almost routine even for non-thoracic surgeries nowadays. And after that, depending on how the patient is tolerating the one lung ventilation and a combination of that and the hemodynamics and how much the saturation falls and how quickly the saturation falls. So based on that, we gradually increase the PEEP with intermittent recruitment of the lung. I think we usually go as far as 8 to 9 centimeters of water in rare patients with really bad lung function, where we may need to increase it to 10 to 12. But usually 5 to 8 or 9 is how we choose it. And there's no fixed formula for depending on each patient's parameters, how they maintain hemodynamically and how low the saturation falls is how we choose the peak.
So you mainly rely on the oxygenation parameters to determine, right?
Yes.
So is somebody, or is any of the panelists being sort of using the PEEP based on the driving pressures during one lung ventilation? Anyone can answer. Dr. Thakkar, please.
Okay, so in reality, what my experience is at MD Anderson is it's rarely effective. You try people 5, it typically in majority of the patient, 5 or 10 doesn't help much. So we start with the CPAP and then go to the PEEP and try not to exceed the one over another, because then you can have, because the mechanism here is mainly in 90% of the patient, it's a shunt problem. And applying of the PEEP sometimes can worsen the shunt. So because you're increasing the intra-alveolar pressure now and the shunt can get worse. So we use PEEP, but in my experience, the PEEP is not that much of a benefit. Most of the time it's a hemodynamic issue of the hypertension. And if I raise the blood pressure up a little bit and increase the cardiac output, then I see the improvement in the oxygenation.
Thank you. So again, as I said, I may skip some of the questions like recruitment manuals or permissible hypercapnia has been already answered by panelists. We move on to the next different or the newer approaches of thoracic surgeries which have been practiced nowadays. So robots have come to the field of thoracic surgeries as well. So I would like to ask Dr. Upadhyay, what are the difference that you face when you anesthetize a patient for a robotic thoracic surgery as compared to VAT surgeries?
If you look at the surgical aspect of it, the surgeon probably will tell you that robotic surgery is more preferable to VAT because it can dissect out lymph nodes from the chest, especially from the mediastinum, pretty well. But that is the surgical part of it. As far as anesthesia is concerned, the position of the patient on the table for robotic surgery is drastically different from what it is for open surgeries or VAT. The open surgeries or VAT, the position is bang lateral, either of the sides. But in robotic surgery, the position is either supine or slightly one side raised. So it is more or less, I take it as supine. And that advantage of the blood from non-dependent lung flowing massively to the dependent lung is lost. And therefore, the incidence of hypoxia, non-correctable hypoxia, difficult to correct hypoxia is much more with robotic. That is number one. Number two, I'm a little skeptical about using blockers in robotic surgery, though I had to use in 1 or 2 cases because the intubation with double lumen tube was not possible because of difficult airway. But since there is no haptic or tactile feedback to the surgeon, what he's operating on, though he can see better than VATs, but there is no tactile feedback to him. So it is possible that he may dislodge my blocker and cause a problem.
So you are worried about the dislodgement of blockers during the surgery. Any particular, so in our case, in our center, the robotic esophageal surgeries are done in almost prone position. Yes. And many a times we also place sometimes because we do have the atrial fibrillations during the surgeries and all. So we do keep the pads also attached to the patient, transcutaneous defibrillation pads attached to the patient before the robot is docked. So that's something we had faced in recent times.
But I have a question. When you do esophagectomy in a prone position, your intention is to let the lung fall and collapse, not exactly collapse, but fall away.
Right.
So you probably do not need a one lung ventilation.
Yes, some of the surgeons still use or still demand one lung ventilation. In fact, they also use capnothorax at the during.
Yeah, that will suffice perhaps.
Yeah, yeah.
Patients, the capnothorax suffices. We keep a blocker in place in case the capnothorax is not enough to give the adequate surgical field that is required.
Well, we'll move to the last particular topic, a quick answer from Dr. Dilip Thakkar, and this has been sort of a recent, sort of a new direction in which the thoracic surgeons are moving, is the non-intubated VAT surgeries. And there's been a growing evidence in favor of that. A recent meta-analysis has shown it's better for the post-operative hospital stay and all. So any experience regarding these non-intubated VATS resections in your institute? Dr. Dilip.
As you know, the indications are wide variety of simple, small procedures. Typically, at our institution, we do VATS non-intubated patient in the cardiopulmonary lab. In the operating room, patient who comes, most of them are intubated. So the patients who get non-intubated VATS are typically either lung biopsy or pleural biopsy, or those are the patients we do in cardiopulmonary lab, and those are done by the pulmonologists. Our surgeons, when the patient comes to the operating room, they are typically bigger procedures. But again, the sedation is the main thing. Patient cooperation is the main thing, and the communication between the surgeon and the anesthesiologist and the whole team plays a major role. I think, but the most importantly, the patient's cooperation and understanding that this will be done under deeper sedation is the main thing. The advantages are there for doing this, but then there are also indication and contraindication not to do this procedure, especially in the obese patients or the airway issues or those are kind of things where you may lose the airway. So we don't do typically because another issue is awareness of the procedure and litigation, because you're trying to maintain the sedation within an acceptable limit and you're concerned about losing the airway. So only procedures we do in cardiopulmonary labs are small biopsies and the pleural biopsy and the veg resections.
Thank you. Thank you. That's a great view on the non-intubated. I think most of the evidence has come from the Eastern countries, I think from the Chinas and Japan. That's where the evidence has been arising a lot about these non-intubated VAT surgeries. Some of the times we also do tracheal resections without proper intubation, with the help of either a LMA or with the help of a small catheter which is passed across the two ends of the cut trachea. So these are the other sort of other sort of applications of non-intubated resections. Because we are short of time, I would like to stop here, and I would like to thank all the panelists for their excellent contributions and excellent views on different aspects of thoracic oncosurgeries and thoracic anesthesia. Thank you all.
Thank you.
Thank you.
Thank you. I thank all the panelists and the moderator for the wonderful session. May I request Dr. Dilip Thakkar to give the talk on complications and challenges of thoracic anesthesia?
Sure. Let me. All right. Okay. Well, thank you so much for inviting me. It's about 3 o'clock in the morning in Houston. And I appreciate inviting, and I hope I do a better job in going through this chapter. So basically, I was asked to present to you the complication and challenges of the thoracic anesthesia. And I'll share some of, it's such a big topic, but I'll share you some of the practical aspect and my experience when I came across certain cases, which I did. So these are the most common procedures we do at MD Anderson in operating room. As you can see, from tracheal resections to the lung resections we don't do the lung transplant. We don't do lung volume reductions, but we do rest of the procedures listed in this list. And these are some of the complications you may come across in post-thoracotomy patients: cardiac arrhythmias, myocardial infarction, pericarditis with constrictions, tamponade, cardiac arrest, cardiac hernia, intracardiac shunt, pulmonary hypertension, post-thoracotomy syndromes, pulmonary embolism. Aspiration is not uncommon. ARDS is not uncommon. Lung torsion is a rare. Sub-Q emphysema or mediastinal emphysema can occur. And bronchopleural fistula or any kind of fistula. You can have fistula between the trachea, between the pleura. You can have fistula between the pericardial sac, or we had a case where we had a fistula, bronchial fistula with the subarachnoid space. So that was kind of one of the rare case. And prolonged intubation, we call it another complications. Airway injuries and different leaks from either chyle or blood in the space. And these are some of the immediate post-operative issues we kind of consider as a complications, as a CO2 retention, prolonged ventilation, failure to extubate. Majority of our patients are extubated, even if it's extrapleural pneumonectomies or regular intrapleural pneumonectomies. We try to extubate them in the operating room because of the disadvantage of keeping them intubated. Air leak, atelectasis, bronchospasm, exacerbation of the underlying disease because you're manipulating the lung for a prolonged period of time. Symptomatic cardiac arrhythmias, most common is atrial fibrillation, and other rare complications. So this is one of the cases I would discuss with you. This was a 52-year-old male with a history of pleural mesothelioma. He underwent extrapleural pneumonectomy. A number of cases we do now are much less as compared to a few years ago for the extrapleural pneumonectomies because the criteria for surgeries have changed. Patient was extubated in the OR and transferred to the ICU for the recovery. At night, patient started to have a dusky face, neck and upper torsion distension of the neck vessels. Patient becomes hypotensive, not the hypertensive, is sorry for the misspelling, tachycardic and hypoxic. And patient was given fair amount of fluid and placed on the inotrope with no response. So this is typically what happens in the extrapleural pneumonectomy. It's a fairly one of the largest thoracic procedure, if I have to say, where the entire lung is taken out with the parietal pleura, with the pericardium and the diaphragm. It causes significant hemodynamic shift during the surgical procedure, and even after the surgical procedure, there is a fair amount of hemodynamic issue. We restrict the fluid volume, try to keep it around 3 liters so that the patient doesn't get postoperative pulmonary edema or ARDS. We try to limit the blood transfusion because, again, the same risk of TRALI and ARDS postoperatively. We keep electively on some vasopressors to keep blood pressure in a fairly reasonable limit. On the left side, when you do it, you have to deal with the left ventricular compression. On the right side, there is venous return issue. But basically, you repair the pericardium, you repair the diaphragm, and at the end of the case, you transfer the patient extubated from the OR to the ICU. So that patient, this is the initial X-ray of the patient, preoperative X-ray. As you can see, the lungs are fairly okay. The mediastinum looks fine. The heart shadow looks okay. This is immediately post-operative X-ray, and as you can see, the right side chest, as you can see after the pneumonectomy, and the left lung field looks fairly clear, no issues, and heart shadow also looks okay. This patient has a Swan-Ganz catheter, which you are not able to see in this particular picture here. This again taken right after the patient was taken to the ICU and when the patient became hypotensive. As you can see, the left lung field looks okay, but there is something unusual on the right chest wall. As you can see, there's a little shadow here and a little projection coming out here. And immediately there was thought that there's something has gone wrong. The echo was done on the bedside, the transesophageal echo, and you could not visualize the heart because the heart was displaced from the midline. This is the echo done post-op when the patient was taken to the operating room and done the echo to see how much improvement has occurred. And what the diagnosis was that this patient had a cardiac herniation on the right side. Even though the pericardium was repaired, but patient developed cardiac herniation, and we don't know at what phase of recovery that cardiac herniation occurred. And basically what has happened when we took this patient to the operating room, the right atrial appendage was herniated to the pericardial defect, and that was causing the problem with the venous return to the right ventricle. This picture again shows you that after rethoracotomy, when patient was taken to the operating room and the pericardium on the right side was repaired again, and the Swan-Ganz was placed, and you can see Swan-Ganz in a good position. So basically on that particular case, what I wanted to discuss is this herniation can occur anytime during the post-operative period, but what we have seen is most crucial period is immediately post-extubation when the patient is either doing a Valsalva or forceful expiration, or if you do forceful positive pressure during the extubation, you may have a mediastinal shift and have herniation. Or when you're moving the patient to the left side or on the stretcher or the right side on the stretcher and patient kind of coughs, that's the time when you can have herniation. Or this can occur in the ICU as well, when typically what we see is that patient moves to the ICU and the X-ray is taken and patient is lifted from his back and Valsalva occurs, and this particular situation can occur. So the problem is if it's on the right side, then there is a counterclockwise rotation of the heart and impairs the venous return. If it occurs on the left side after the left thoracotomy, then typically heart herniates to the defect, and there is sort of strangulation of the left ventricle, and you can have either cardiac arrhythmia or myocardial infarction. So you have different kind of problems, either right side or left side herniation. But again, this is a very rare complication. One has to think about intubating this patient in the lateral decubitus position many times. What we had done is intubated this patient when he came back to the OR in the lateral decubitus position, because putting the supine again can worsen the hemodynamic response. So you have to be prepared to put the patient in lateral decubitus. And again, when you intubate lateral decubitus, it's usually a single lumen tube. You don't need a double lumen tube because this is a post-pneumonectomy patient. This is another patient. Let me go back. This is another situation which is called post-pneumonectomy syndrome. There are so many things can happen after pneumonectomy because of physiological changes and a shift in the mediastinum. 56-year-old female, right pneumonectomy 6 months ago, came to the emergency room with a history of shortness of breath, dysphagia, heartburn, and tachycardia, basically. And the X-ray was taken, plain X-ray was taken in the emergency room, and as you can see, the left lung field is hyperinflated, and the right chest is typically post-pneumonectomy, and you can see the trachea is shifted to the right side. This was a CT scan done after, and as you can see, the post-pneumonectomy changes, and the trachea shifted extremely to the right side on the chest. And what happens is, this is one of the rare complications where the trachea and the bronchus on the non-operated side is kind of compressed. And I have mentioned here some of the common situation where this occurs, especially in children's, most common with the right pneumonectomy, because your left main stem is much longer, and usually it gets compressed between the aorta, pulmonary artery, and the vertebral column, and causes compression of the normal bronchus, so the difficulty in ventilating on the same particular side. So at that point, the anesthetic consideration was very important, that how we're going to fix the problem, because what the problem was that the left main stem bronchus on this patient was compressed and had a difficulty in exchanging the air through the left side. And so the plan was to take this patient to the operating room and reposition the airway so that the trachea comes into the midline and the left main stem bronchus is decompressed. So we had to think about how we're managing the airway, how we're intubating the patient, what lines we need, how we're going to oxygenate, and what's the plan for the extubation. So this is a post-pneumonectomy patient, so double lumen tube was not an issue at that time. We don't need double lumen, but we need a long single lumen tube. We didn't have a typical long single lumen tube at that time. So what we did is we took 2 single lumen tubes and cut the one and put the second one, the smaller one, and then extended the length of the tube. So I think it was a 5.5 and 7 millimeter tubes, which were kind of used to put it together and intubate the patient's left main stem, and this intubation was done while the patient was still awake, fiber optic intubation in the left side. As you can see here, post-surgery, the right side, we used breast implants, silicone breast implants, to fill up the space on the right chest. And as you can see, the trachea is in the midline and the left main stem is now open after the surgery. And this is again, the CT scan post-operatively. As you can see here, the mediastinum is in the midline. These are the silicone breast implants, and the left main stem is, this is actually just above the carina or at the level of the carina, but you can see there's a remaining of the right main stem, and this is the left main stem completely open now. So this is kind of a rare situation of post-pneumonectomy syndrome, but it can happen in rare cases. And this was the fiber optic bronchoscopy after the correction. As you can see, the conduit of the right main stem and the left main stem is completely open. Just to kind of bring up what happens to the lung, the thoracic cavity after the pneumonectomy, because there are some physiological changes occurs. And what happens is, this is radiograph shows you before, and now this is post-pneumonectomy. On the left side, you start having a fluid accumulation from the rough surface of the pleura start secreting, and the air remaining in the chest wall in the thoracic cavity slowly decreases over a period of time. And typically you have about 1 to 2 ml of fluid per day accumulated, 1 to 2 rib cage, sorry, not the ml, 1 to 2 rib space of fluid accumulates every day. And over a period of about 7 to 10 days, you have about this much of fluid, about 2/3 of the chest cavity is full. And now here, as you can see, this is about a month or 2 months after the left pneumonectomy. You can see the complete opacification of the chest thoracic cavity with narrowing of the rib space, slight elevation of the diaphragm, and the mediastinum is shifted to the side of the surgery. So those are some physiological changes occur after the pneumonectomy. Some of the other rare complications, but not uncommon, is fistulas. Like I mentioned, we have seen fistulas between the esophagus in the pleural space with the pericardium, and even 2 cases we had where the fistula developed between the subarachnoid space, where the patient came with the air in the subarachnoid space when the CT scan was done. So these are the examples of some of the bronchopleural fistula. And let me go back. This picture is cutting off. Okay. So again, bronchopleural fistula is not an uncommon situation. One has to keep it in mind that how we are going to manage this patient as far as anesthesia is concerned, because these are the patients who are very high risk for aspiration if it's bronchopleural fistula. And patient usually presents kind of a little bit of sick, they're tachypneic, tachycardic, hypoxic. So those are the things you have to keep in mind. How you're going to intubate this patient is very important. Are you going to use a spontaneous ventilation, or you're going to put patient under anesthesia with muscle relaxant and do the insertion of the double lumen tube? All that based on the patient situation at that time. We have done both ways, double lumen tube insertion or single lumen tube insertion. Typically you need, if it's a pneumonectomy, post-pneumonectomy, you need a single lumen tube, but if it's after a lobectomy or bilobectomy, then you may need a double lumen tube, which can be inserted with AVIC fiber optic intubation, considering in mind that patient may have a higher risk of aspiration and contamination of the other side of the lung, which can be a problem. We had 2 cases of post-operative hypoxia, and they were the cases where patient had a shunt through the heart, and patient had a history of PFO. And I think a day or 2 after, patient became hypoxic. And on the echo, it showed that this patient had persistent foraminal valve. And this patient had undergone right pneumonectomy. So it's typically much more common, this condition after the right pneumonectomy. And the classic presentation is the patient is doing fine in supine position, and as soon as patient sits up or stands up, patient becomes hypoxic. And again, when it lies down, the hypoxia goes away. So there is some sort of mechanism where the PFO opens up or ASD opens up, and the shunt becomes worse when you're standing up. So ideally, you want to manage this patient with a little bit of fluid and go back and fix the defect in the atrial septum. That's the most common. But that could be other factors, which could be extracardiac shunts, which could be a problem as well. But I think 90% of the time, there's an intracardiac shunt, which needs to be fixed if he needs a good outcome. Atrial fibrillation is not uncommon. At our institution, the atrial fibrillation is about anywhere from 15 to 20% of the patient in lobectomy or bilobectomy. Wedge resections had much lower incidence of fibrillation. The pneumonectomy patients vary anywhere between 25 to 30% of the patient can develop atrial fibrillations. Typical second or third day are the common where patient can develop atrial fibrillation and some hemodynamic issues. These are some of the procedures which, as I mentioned, that low risk, moderate risk to high risk for the atrial fibrillations. Like I said, the right side pneumonectomy and right bilobectomies have much higher incidence than the left side. And these are some of the basic mechanisms where patient can develop atrial fibrillation. Most common is surgical manipulation and irritation of the atrium caused by the surgical manipulations and inflammations, and some of the pre-existing condition. If patient had a history of atrial fibrillation, can make it worse. These are some of the drugs which can be used as a prophylaxis. We have tried all possible scenarios, but now we don't use any prophylaxis for the atrial fibrillation because any of these drugs we use have some adverse side effect and cause some hypertension and bradycardia during the surgical procedures. So we don't do any prophylaxis for this atrial fibrillation. And we treat, if that happens, immediately post-op. Another situation, you can have torsion of the lobe, especially on the right side. If you do right upper lobectomy, you can have a torsion of the right middle lobe. We had 3 patients where patient came with a torsion, and they usually present to the emergency room with shortness of breath, tachycardia, sudden air leak stoppage, and less breath sounds, as you can auscultate, will be on the right side. These are the x-rays. You can see this is a normal x-ray, and this happened, something happened, and you can see there is a herniation, a torsion of the right middle lobe. And on the CT scan, you can see that this is a hemorrhagic lung, which completely torsion. And the way of the diagnosis, there is like a little tapering of the hilum because that part of the lung is torsion, almost like anywhere from 90 to 360 degrees. You go back, look at the bronchoscopy, and make sure you either untwist with the thoracotomy, or you may end up doing a lobectomy of the remaining lobe, or occasionally you may end up doing a bilobectomy or pneumonectomy because there is so much torsion and the lung is completely infarcted. These are some of the differential diagnoses you may need to keep in mind. I think those are some of the complications I thought I can discuss.
Thank you, Dr. Dilip Thakkar, for sharing your experiences at this hard hour. May I ask you, like in open thoracotomies, what is the dynamic hemodynamic monitors that you generally use?
So in open thoracotomies, we have changed our practice lately. If it's a pretty safe with minimum comorbidities, then we do without any arterial line, but we do standard monitoring, EKG, blood pressure, pulse oximeter. But if it's anything bigger than lobe or bilobectomies, then arterial line is our standard monitor on those patients. But we don't use any other invasive monitoring like a Swan-Ganz catheter or anything like that. Occasionally we use TEE, especially with the extrapleural pneumonectomies, we do that. But arterial line is, number of arterial line we place are much less now.
Okay. Thank you. And what about the fluid management, sir? You restrict to...
Fluid management is again, have changed over a period of time. If we are doing an esophagectomy, then we do the fluid management as usual. There is no limitations. We use either crystalloid or colloid. Try to keep around within fairly reasonable goal-directed therapy. So we have a goal-directed therapy. We try to manage according to what the numbers look. But if it is esophagectomies, around 3 liters to 3.5 liters of colloid and crystalloid together with the goal-directed. But pneumonectomies, we are kind of limited, try to limit our fluid volume. But again, it's a goal-directed therapy.
Okay. Thank you so much, sir. So can we call the end of the session?
Sure, unless there is another question, yeah.
Thank you, speakers and chairperson. Now it is my privilege to invite Dr. J.V. Devatia, Professor and Head, Department of Anesthesia, Critical Care and Pain, TMH Mumbai. He is the President of Society of Onco-Anesthesia and Perioperative Care, and Dr. S.S.C. Chakra Rao, MD, Care Emergency Hospital, Canada, Chairman, Indian Resuscitation Council, and member of Constitutional Committee, WFSA. I welcome you, sir. Over to you.
Good afternoon. We will now have a keynote lecture by none other than Dr. Anil Gupta. It's a privilege and honor to invite Dr. Anil Gupta to SOAPCCON and to deliver the keynote lecture. Dr. Gupta is the Associate Professor and Senior Consultant at the world-famous Karolinska University Hospital and the Karolinska Institute. He's got several awards from international and national societies, lots of publications, and he's one of the key leading researchers in the effects of anesthesia and cancer recurrence. And I now request him to speak to us on looking backwards to point the way forwards, anesthetics and cancer Dr. Anil Gupta, please.
I'm sorry, I'm not able to find my screen. One second. So, are you able to see my screen now?
Not yet, sir. Please.
That's strange because I've got it here.
You want to just share screen.
Yeah, now it's visible.
Can you see it now?
Yes, sir, you're on.
Okay. First, I would just like to thank Dr. Devatia and Dr. Rao, as well as Jyotsna Goswami, for asking me to present this keynote lecture. So far, I've been watching the conference this morning. It's been working perfectly, and I'm really impressed with the development over the last year that Zoom has taken. So once again, thank you very much indeed for asking me to give this lecture. Let's see. Why is it not moving forwards now? Okay. I'm working in Sweden, and many people confuse Sweden with Switzerland. So I thought I'll just show a map of Sweden. This is one of the Nordic countries with Norway, Finland, Denmark, and Iceland. And I'm working at in Stockholm. It's a beautiful city, and the archipelago is almost 24 to 30,000 islands. And I'm working at the Karolinska Hospital, which Dr. Devatia just mentioned. They award the Nobel Prizes here. So if anybody is keen on cancer and anesthesia, I'm sure that there will be an opportunity for you to get a Nobel Prize at some stage, hopefully. Okay, so today's discussion is going to focus on oncological outcomes that are of interest, and we need to take into account these when we present our results in research journals. I'm going to talk a little bit about what has been happening in the last couple of years. I'm not going to go back to 2006 when the first publications came, but just focus on the last 2 years in anesthesia and cancer outcomes using retrospective study data. I'm then going to present a little bit about the prospective RCTs that have been published, very few, but I'll just talk a little bit about them. And then I will speak a little bit on the future, and then finally conclude. So the oncological outcomes of interest, if anybody has not read this article, I would advise you to do that. It's a systematic review on consensus definitions published in 2018. And there are a lot of definitions they've taken up, but I think the focus would be on these ones that I've mentioned on the slide: recurrence-free or disease, sometimes called disease-free survival, overall survival, return to intended oncological therapy. This has become quite popular in the last few years. The time to recurrence, and recently even the number of circulating tumor cells. And I will talk about that briefly in a few minutes. So just to look back, what has been done in the last couple of years, and most of the anesthetics have focused on a comparison between total intravenous anesthesia and volatile anesthetics, a comparison between regional combined with general, of course, versus general anesthesia alone, which means that do anesthetics have any effect on, regional anesthetic techniques have any effect on outcomes, and local anesthetics versus placebo, whether these play any role, local anesthetics play any role in outcome for patients. It's important at this stage to just mention that there is a hierarchy of evidence which all of you are very well aware of, and the highest evidence, really speaking, is the systematic reviews. However, I'm a little concerned about many systematic reviews because they combine studies with different endpoints, different methodologies, different outcomes, And so the evidence grade, although is said to be high, may not necessarily be correct. And therefore, my standard of care is still the classical RCT, which I think is a gold standard. It is costly, but it is definitely gives much better information as to the causes or outcomes which are best using different techniques. However, there are alternatives like the observational studies. They're not perfect, they're far from perfect, but they're pragmatic. And the most important thing is that they're much, much, much cheaper compared to the RCTs. And therefore, possibly we should be thinking about these in the future also. Okay, so if we just go to the meta-analysis that have been published on the field of anesthesia and cancer outcomes, I could locate two in the last 2 years. And the first one is from 2019, published in Canadian Journal of Anesthesia. The authors studied total intravenous anesthesia versus volatile anesthetics. They had mixed all kinds of cancers when they presented their results. And the results, as I think most of you are aware, how these forest diagrams are looked at. One has to see this line of 1. Anything on the left side of this line favors total intravenous anesthesia, while everything on the right favors, sorry, there's some disturbance here. On the right favors volatile anesthetics. So as far as recurrence-free survival is concerned, in this particular meta-analysis, there was no advantage of total intravenous anesthesia. The next study that was, or systematic review that was published was recently in Anesthesia Analgesia. Here, the authors once again compared propofol versus volatile anesthetics. And once again, they looked at all cancers. And this is, as you all know, a real problem. You cannot mix breast cancer with colorectal cancer with pancreatic cancers. They all have different outcomes. But nevertheless, these authors have looked at all cancers. And when looking at total intravenous anesthesia versus volatile anesthetics, once again, you see that there is it is a better outcome for patients who are having total intravenous anesthesia compared to volatile anesthetics. And this is significant. This is overall survival, mind you. But if you look at recurrence-free survival, then there is no difference between total intravenous anesthesia and volatile anesthetics. So why is it that we have different results in different meta-analysis which have looked at identical, all cancers and comparing these two anesthetic techniques? Firstly, the first analysis was published in 2019, and the studies that were included were until 2018, while the next one was published in 2021, and the studies included were until 2020. But recent studies have shown predominant negative results, and that might be one reason why the new meta-analysis did not give any benefit in recurrence-free survival. Also, there is a problem, as I just mentioned earlier, that we need to be looking at specific cancers and not all cancers. And this might be another reason why there are different results in different studies. So looking at specific cancers, for example, in colorectal cancers, still studying retrospective data, not prospective studies. This was one study published from Denmark recently, and the authors looked at total intravenous anesthesia, once again, compared to inhalational anesthesia in colorectal cancer surgery. And what was interesting here was that they did find an overall difference between the groups. So it favored the use of total intravenous anesthesia. However, it was clear here that this favored total intravenous anesthesia was better if the patients were healthier, which is the Charlson comorbidity index they've looked at. It was healthier patients, as well as in elective surgery, not acute surgery. And so they've come to the next step in the process where they've shown that, okay, total intravenous anesthesia is good, but it's in a subgroup of patients that are healthy, that undergo elective surgery and not acute surgery. What about breast cancer? Well, there's one study published from Sweden, including over 6,000 patients. Retrospective study, breast cancer, once again, identical comparison, published in ACTA. And here you see an advantage, once again, for propofol anesthesia, which prolongs overall survival. One more study published also on breast cancer, comparing identical outcomes in breast cancer, but this was from Seoul in Korea. And here they found no difference between total intravenous and inhalational anesthesia. Very confusing. Some centers suggesting a benefit, other centers suggesting no benefit of total intravenous anesthesia. So what is the problem here with breast cancer surgery? Firstly, there could be a country difference. As I mentioned, one study was done in Sweden, the other one was done in Korea. And there could be obviously differences in management, perioperative management, which is resulting in different outcomes. And there could be differences there could be inconsistencies in how we in Sweden manage patients as compared to how you manage in Korea or in other countries. And this is why one has to once again look at specific cancers, specific group of patients, specific countries where they're being studied, probably specific the stage of cancer, whether it's stage 1, 2, 3, or 4, and so on and so forth. We need to go into a little bit more specific. Surgeons don't treat, or oncologists don't treat patients post-operatively on the basis of any cancer. They go into more specifics on the type of cancer and which patients will respond to which kind of oncological therapy, which means that the individual patient has to be the focus of attention rather than grouping patients into large groups. It'll not give any good results. I'm fairly certain about that. So now we'll just focus a few minutes on prospective studies that have been done on anesthesia and cancer. And I will talk about total intravenous and volatile anesthetics, comparison between the two, regional and versus general anesthesia, and local anesthetics versus placebo. Not many studies published, but the few studies that have been published, I will talk about these. The first one is on breast cancer, and this is a very large study, including over 2,000 patients. It's a randomized study. In one group of patients, the patients received a paravertebral block and propofol as the anesthetic. In the other group, they received sevoflurane and opiate. That means no paravertebral block and sevoflurane instead of propofol. And the primary outcome they studied was the percentage of patients that had recurrent. Found in this study that there was no difference between the total intravenous compared to sevoflurane and opiates in the management. As I said, this is a very large study and the results are quite interesting. However, there are problems with this study. Firstly, it took almost 12 years to include patients. They started in 2007 or 8, if I remember correctly. And so the management technique could have changed. Obviously, there could be some anesthesia, but in surgical techniques, in oncological management, and so on. They followed up the patients for only 36 months. As you know, breast cancer, patients today are surviving, 95% patients survive up to between 12 and 15 years. So it was a very short follow-up time. They used a combination of propofol and paravertebral block. And as we know from previous studies, both propofol and regional anesthesia can affect outcomes. They studied all cases of stages of cancer from 1 to 4. And the number of patients who died in this period of follow-up was about 10%, which I suspect is a group of patients that have a very high malignant tumor, because as we said, that the recurrence rate for breast cancer is not that high. So in a small group of patients with aggressive cancer, probably total intravenous anesthesia combined with regional anesthesia may not be better than sevoflurane combined with opiate. And the final point, of course, is that there could be a center effect because 50% of the patients were recruited from China. And when one looks at the center effect, you see immediately that there is a direct opposite results from China as compared to many other countries. The next study, which is also a prospective randomized study from our institute, we looked at colorectal cancer patients, very small study, only 185 patients. Unfortunately, it's not easy to randomize patients to getting either epidural analgesia or patient-controlled intravenous anesthesia because the standard of care has been, in most institutions, epidural analgesia for pain relief perioperatively. So we had some difficulty in recruiting patients, and there was some discussion with the ethics committee, of course, but we managed to convince them that this is not a real issue. What we looked at was a disease-free survival, and we followed up patients for almost 5 years. We found no difference in the adjusted hazards ratio in this group. That means the disease-free survival, there was no advantage of patients having an epidural compared to a PCA intravenous technique. Criticism, of course, with this study is that it was a very small study. But however, we had a long recruitment period of a long recruitment period of almost 5 years. The advantage was that the surgeons like to usually follow up these patients for 5 years after surgery, which is what roughly we did. The epidural was confirmed that it was a functioning epidural before we started the anesthetic. And the care for these patients is standardized all over Sweden, oncological therapy as well as surgical care. So there were some advantages, but obviously problems also. What about local anesthetics and cancer? Well, local anesthetics, this is not an analgesic effect. It's important to remember. We're talking about the direct inhibitory effects of local anesthetic on cancer cells, which means that local anesthetics prevent proliferation or multiplication of cancer cells through voltage-gated sodium channels. They stop the differentiation of these cancer cells. They stop migration and adhesion of cancer cells onto vessel surfaces, which means that they reduce the risks for cancer spreading during the per and postoperative phase. They also have an indirect effect via reduction in inflammation. And this is a well-known advantage of local anesthetics. And also there is some discussion that perhaps they may also inhibit these circulating tumor cells. And I will get back to that in a few minutes. So there may be several advantages of local anesthetics in addition to the known analgesic effects on cancer cells. So we did one study. This was just a pilot study to understand whether patients who are undergoing late stage ovarian cancer surgery, where we do cytoreductive surgery. And the idea here is that the cancer is spread, of course, in the entire abdominal cavity, and the surgeons are trying to remove all the macroscopic tumor which they can see with their eyes, and try to reduce it to the minimum amount of residual cancer. However, there is a fair bit of microscopic tumor that is still remaining, and this can start getting, these microscopic tumor cells may start multiplying during the perioperative phase when the immune system is not working properly in the first maybe 48 to 72 hours, and the cancer starts spreading. So our idea was that, okay, when surgeons have removed all the macroscopic tumor, we put in local anesthetics, not inject, but put it into the abdominal cavity. And then at the end of the operation, we put a small catheter into the abdominal cavity and inject either placebo or local anesthetics, ropivacaine, intermittently over a 72-hour period, so that we can stop these cancer cells from multiplying and moving out into the circulation. All these patients had an epidural analgesia, which was confirmed before starting the operation. And our hypothesis was that intraperitoneal local anesthetic compared to placebo reduced the time to riot. I think that there was some discussion, if I remember this morning, on riot. Riot is return of intended oncologic therapy. For different cancers, you have a different time phase when oncologists would like to restart for those patients who are eligible for oncological therapy as soon as possible. In ovarian cancer, it is said that it's best to start oncological therapy within 4 weeks, because then the outcome for patients is improved dramatically as compared to more than 4 weeks. So our main aim here was, when can we start oncological therapy after surgery? And our results showed very clearly that patients who had intraperitoneal local anesthetic, as you can see from this diagram, had earlier start of oncological therapy within 21 days compared to the placebo group that was almost 29-30 days approximately. And already after 40 patients, this was a statistical significant difference. We, as anesthesiologists, did not react so much to these findings, but our surgeons, gynecologists were extremely impressed that we were able to see this already after 40 patients. And therefore, they are now performing a larger study with over 250 patients, where they are looking at return to oncological therapy as well as long-term outcomes for these patients. Once again, the problems are that small study, just a pilot study, no long-term outcome data is available today, because we finished the study around 2018 and we need to follow up these patients for at least 5 years. So we are awaiting the results of whether we were able to improve even outcome or not. Now, just a mention about the circulating tumor cells, which I had mentioned earlier. As you know, that during surgery, there is some amount of tumor cells that come out of the tumor, and they go both through the lymphatic system as well as the circulatory system into the blood. And one can today, using very advanced techniques, study the amount of circulating tumor cells in the blood. And these circulating tumor cells obviously will spread the cancer perioperatively, and in the initial phases, maybe 6 months, 1 year, 2 years, the cancer might remain dominant because there's just a few small cells. But slowly, when the environment is correct, these cells might start multiplying, which results in cancer recurrence. So in one study, the authors studied breast cancer patients and looked at the number of circulating tumor cells. They looked at 210 patients, which is extremely large number of patients, considering that it is expensive to actually analyze these circulating tumor cells. They compared patients undergoing breast cancer surgery with sevoflurane and with propofol anesthesia, total intravenous anesthesia. The number of circulating tumor cells that they found was 1. As I said, it's a very small number of cells that you can see in the circulation, but in the 7.5 milliliters of blood, they were able to find a median of 1 cell. And although it seems like there was a difference between sevoflurane and propofol, these are just isolated cases. So in the totality of the picture, there was no difference between the groups. Question here remains is that, okay, sevoflurane and propofol, maybe there was no difference, but is there a difference if you have lidocaine as an infusion intravenously? Because as I mentioned earlier, lidocaine stops multiplication of cells and so on and so forth. So if you have an intravenous infusion of lidocaine, maybe it is able to kill those few cancer cells that are circulating. Also, the other question is that, is it possible that one can, through other ways, preserve the immunological functions and thereby reduce these circulating tumor cells? We have no information on that today. So looking forwards, how does the future look? What we need really is prospective studies with adequate follow-up, not just short-term follow-ups. If you're looking colorectal cancer, it's obligatory 5 years, breast cancer maybe 10 to 15 years, and so on. RCTs would be the absolute ideal way, multi-center studies, including patients from all around the world. But these studies are extremely expensive. We don't have that kind of money. Nobody's interested in anesthetics. Everybody focuses on oncological therapy, new cytostatic drugs, cancer therapies, new methods to do surgical, like laparoscopic surgery or robotic surgery. So we have a problem there as anesthesia as a discipline, that we don't have money. And therefore, the alternative is to look at do observation studies, but very large number of patients included, in order to be able to come to some kind of a sensible conclusion, and then be able to sell this concept and say that, okay, in observational studies, we found some kind of a association between, for example, propofol and outcome, and therefore we may be able to procure more money to do randomized clinical studies. Also, what we need to focus is on, as was said this morning, that there is other aspects, not just anesthesia care, directly related to anesthetics, but of anesthesia care, which includes prehabilitation, like exercise, smoking, nutrition, and so on and so forth. We need to incorporate these enhanced recovery and early discharge programs using good anesthetic techniques, and also how quickly patients can return to oncological therapy. So this is a comprehensive program that we need to introduce, rather than just focus on one small aspect of anesthetic techniques. So one study that has been registered in the clinical trials is a study that we have started, where it's an observational study. We plan to include over 10,000 patients from around the world. Already 160 centers are registered in this study. It's starting on 24th October. And from India, I'm glad to say that there are 6 centers registered. If there's anybody who's interested in registering, please contact me, and I will ensure that you get all the information. We hope to collect at least 40 patients from each center from around the world. So it's not a huge, big problem to be able to include 40 patients. There's no intervention. You do exactly as how you're doing today. And this will ensure good quality information that we can use to look at associations between different cancers. And one study that is going on today, VAPOR-C, and this also on colorectal cancer. They're comparing total intravenous anesthesia with inhalational and intravenous lidocaine versus placebo, and they plan to include over 5,000 patients. So this will be interesting to follow up the results. And finally, just a word on what was said earlier, that to improve cancer outcomes, we need to minimize stress, we need to retain immunological function, we need to promote early recovery. And this encompasses a lot of different factors, not just anesthesia drugs or epidurals. This involves many, many factors which we need to work on as soon as we meet the patient in our pre-anesthesia clinics, and then follow up over a long period of time. So to conclude, retrospective database studies, both regional anesthesia, propofol-based anesthesia, and local anesthetic seem to be positive. However, prospective studies have not been equally promising. That does not mean that they are ineffective, but we need to study this a little bit more. And we need to improve pathways in the future by doing large international studies and involving enhanced anesthetic programs. So thank you very much. I think I took a few seconds extra. Thank you very much indeed.
Thank you, sir, for this highly educative and informative session. Now I hand over to Dr. Shubhra Bakshi for the next session.
Thank you.
Thank you, Dr. Noor. Good afternoon, everyone. Now we are moving on to session 4, which includes panel discussion and recent advances topic. It is our extreme pleasure to welcome Dr. Shashi Kiran, Senior Professor at PGIMS Rohtak, and Dr. Sonal Rastogi Das, Senior Consultant at TMC Kolkata. The house is deeply honored with your golden presence here. Over to you, ma'am.
Thank you, Shobha. So we have, good evening, everyone. We have an interesting session now. This includes a panel discussion and 2 talks. The moderator for the panel discussion will be Dr. Saket Sen Gupta. The panel discussion will be, is there any cutoff value for preoperative cardiopulmonary, hematological, and biochemical parameters? And then we have 2 talks. One is cancer-associated thrombosis versus recent, and how to manage intraoperative hemorrhage. So can I have a CV of Dr. Saket Sen Gupta?
Hello.
Can I have CV?
Ma'am, today's moderator are Dr. Shuparna Mitra and Dr. Kasturi Bandyopadhyay.
Okay, I'm sorry.
Dr.
That's fine.
Saket is not here.
That's fine. So the moderators for today are Dr. Suparna and Dr. Kasturi. Dr. Suparna is a junior consultant anesthesia in TMC Kolkata and consultant in Medica Super Specialty Hospital, Kolkata. So I invite moderators to take over the panel discussion. Thank you.
A very good afternoon, ma'am. Am I audible?
Yes, yes.
Yes, you are audible.
A very good afternoon to the esteemed panelists here, to the chairpersons and friends who are there in the room. We are indeed having a great brainstorming session since morning, and I'm sure we are all eagerly looking forward to a well-conclusive discussion on this topic. We have lined up 3 cases and we'll be discussing the questions according to the cases. Over to my co-moderator, Dr. Suparna, to start off with the first case. Dr. Suparna, please.
Yeah.
Can we have the...
welcome to this session. It is perioperative cardiopulmonary, hematological and biochemical parameters. Is there any cutoff value? So without further delay, am I audible?
Yes.
Yes.
So without further delay, I would like to go directly to the case. So
yes, you're audible, but your voice is breaking, Suparna.
Okay.
No, it's fine.
Okay. So should I start?
Yeah, please start.
Okay. So our first case, it is a 72-year-old lady who is frail, 45 kg, hypertensive, hypothyroid, presenting with repeated history of bleeding per rectal since past 3 weeks. She is presented to the emergency ward with syncope and palpitation.
I'm sorry to interrupt. I'm sorry to interrupt, Dr. Suparna. Are you sharing your slide? I mean, we are not being able to see any slide here.
Yes. No slide is here.
You're not able.
Okay.
Yes.
Now.
Yeah.
Okay.
Thank you.
Thank you. Sorry.
Yes.
So it is a 72-year-old lady who is frail, 45 kg, hypertensive, hypothyroid, presenting with repeated history of bleeding per rectal since past 3 weeks and presented to emergency ward with syncope and palpitation. Her lab report showed hemoglobin 5 gram percent with INR of 1.7, platelet 1 lakh, serum sodium 131 with potassium 4.1. All other investigations were within normal limit. ECG is also normal, only sinus tachy and left axis deviation is there. And echo showed concentric LVH with good ejection fraction, no regional wall motion abnormality. Chest X-ray, in chest X-ray, there is no significant abnormalities. In the colonoscopy, it is showed that there is ulcerative growth at the rectosigmoid junction. So it is a case of CA colon actually, and the size and extent of the growth was later confirmed by the CECT abdomen. She already had received 2 units of PRBC and injection vitamin K 10 milligram IM for last 3 days. Now she is posted for lower anterior resection and iostomy, and that is to be followed by radiotherapy later. So I'd like to ask my first question to Dr. Shagun Bhatia, that ma'am, what other investigation do you like to ask for this patient?
Respected chairpersons, esteemed moderators, and my dear colleagues, a very good afternoon to all of you. And thank you for inviting me to give my views on this important topic. So the two main issues with this lady are, firstly, a hemoglobin of 5 g/%, and secondly, an INR of 1.7. So a major and prolonged surgery like LAR in a frail geriatric lady like this demands certain extra investigations. So the additional investigations I would ask for would be confirmatory investigations for IDA or iron deficiency anemia and a thromboelastography for her coagulopathy. Now, as we all know, 10% of IDA patients have GI cancer, and conversely, 40% of GI cancer patients have iron deficiency anemia. So an iron deficiency panel, which includes serum iron levels, transferrin saturation, total iron binding capacity, reticulocyte count, peripheral blood smear, would all have to be done ideally. And a reduced mean corpuscular volume, mean corpuscular hemoglobin concentration, all these are sensitive indicators of IDA in absence of B12 and folate deficiency. But instead of doing this battery of tests, I would suggest going in for serum ferritin levels. That is because serum ferritin is an acute phase protein which rises in presence of infection, in presence of malignancy, and also in chronic inflammatory conditions. So the normal level of serum ferritin is 20 to 200 microgram per liter. But in this case, a ferritin level less than 100 is diagnostic of iron deficiency anemia. So in presence of malignancy, a ferritin level less than 100 microgram per liter indicates iron deficiency anemia. So this is one test I'd like to do. And the other one would be thromboelastography. That's because thromboelastography gives a real-time measure of clot dynamics. It'll tell you about clot formation, clot stabilization, as well as clot lysis, unlike PT, PTTK, INR and all, which do not take into account the cellular components like platelets and all. So these are the two additional investigations. In a nutshell, ferritin and TEG.
Okay. So ma'am, do you like to do, this patient is a hypothyroid one. So do you like to do the thyroid profile in this patient?
Definitely, that was already included. I mean, that is a basic routine investigation. This is above the routine investigations. This is above the KFT, LFT, CBC, thyroid, protein, all that. This is over and above all that.
Yeah, so what would be your cutoff value of TSH in your institution you were accepting the patient for this 2 to 3 days surgery probably? We will have only 2 to 3 days in our hand. So what is the cutoff value? Suppose the patient is having a TSH value of 8, 9. I mean, what is the cutoff? Suppose
see, if everything else is all right, even up to 10 would be okay, in this case. Normally we say 4.5 to 5 is all right, but then we can give her a leeway, we can say 10 is acceptable. I mean, if you reduce the fentanyl amount and if you reduce your sedatives accordingly, then you can manage with a TSH of 10.
So, So would you like to do along with that free T4 level? Because it may guide us whether it is
exactly.
subclinical.
So T3 and T4 levels definitely, because if these are deranged, then I'll not go. Then raised TSH becomes significant. But if T3 and T4 are normal, then TSH would be
up to 10. We can
up to 10 is all right.
Yeah. So, ma'am, what cutoff value of hemoglobin would you like to target to take the patient into the OT?
This particular patient has a hemoglobin of just 5 g/%, which is not acceptable to anybody, So a target hemoglobin in our case would be this thing, 8 g/% in her case, because she's actively bleeding, And to achieve this 8 g/%, we have several measures at hand. We can see oral iron is out because oral iron will not be absorbed properly. She has a GI malignancy, so oral iron absorption, plus she must have undergone chemotherapy. So all these things make absorption of oral iron difficult. So next option is parenteral iron. Parenteral iron, you have Imferon and so many other preparations. And the advantage is that, it'll go straight into the IV. And it'll improve the reticulocyte count within a week or two also. You see an improvement in the reticulocyte count as well. But what happens is that you need time for that. So another option would be erythropoietin therapy. Erythropoietin given subcutaneously, human erythropoietin, recombinant erythropoietin, 30,000 units subcutaneously every week. But that would again take a month or so for optimization. We don't have that much time with us, So what do? You don't have that much time. Ultimately, it boils down to packed red blood cells. So if you have to take up the patient within a week, you have only 3-4 days for optimizations, it's packed cells. So I would like to go with packed cells, even though, they say packed cells, erythropoietin, all these increase the rate of infection. And then there are concerns about tumor progression, immunosuppression, cancer progression. All those concerns are definitely there. But the point is, if we delay surgery by a month, then her cancer would have progressed to the next TNM stage. And this would obviously worsen the outcome irrespective of any BT given. So give a BT now, and then that is far-fetched at this moment to think about, cancer progression at a later date, maybe after 5 years. So I would say we go in for BT.
Okay. So ma'am, what should be the cutoff value of important coagulation profile, like platelet cutoff or a cutoff for INR in this patient? So is there
this particular patient, like you said, had a platelet count of 1 lakh. So a platelet count of even 80,000 would be acceptable to us. But if you're considering putting an epidural, because LAR requires an epidural. So if you're putting an epidural, then you require a count of at least 1 lakh. Which is there in this patient. So platelet wise, she's okay. But an INR of 1.7 is not acceptable for surgery as well. So, and as per the ASLA guidelines, if you require to give an epidural, you need an INR of 1.4. So even I would like to go with 1.4. There are several other anesthetists who would like to differ. They might say that 1.2, 1.3 is safe. But then even up till 1.4 is safe, because you have a definitive guideline, and a prestigious one at that. ASRA guidelines say that 1.5, 1.4 is okay. So it's fine with us. Otherwise, we can even go in for a tab block. If not an epidural, if the INR is deranged and surgeons are ready to do it at 1.5, 1.6 INR, then you go in for a tab block for post-op pain relief. And then coming to PTTK. PTTK, up to 40 is acceptable. But then let me tell you, I would like to highlight, we had a case of MRM. The PTTK was 120. We got the surgery done. Patient woke up as well. There was no bleeding. So PTTK in isolation, it doesn't make much of a difference if the rest of the parameters are okay. And like I mentioned, TEG also, I'd like to elaborate on that. TEG values are important, I say, do I have time? I can.
I know. So I'd like to go to the next question. Dr. Kasturi.
Ma'am, Dr. Shagun, thank you for your inputs. Of course, we did discuss that it has been long postulated that blood transfusion does cause immunomodulations. PRBCs prior to the surgery, because she came in very tachycardic with syncope. So what would your perioperative blood transfusion? During the perioperative period? Hello?
Hello, yes.
Yes, ma'am, Dr. Shagun.
Yes, actually there was a connectivity issue. I think, what have you asked me? Could you just slightly repeat the question once again?
Yes, ma'am. I was just wanting to know that we have already discussed the limitations of blood transfusion in onco patients. But then here, as you mentioned already, that
we'd like to go for a target hemoglobin of 8 gram%. Am I audible?
Yeah, ma'am. Yeah, you're audible.
Okay, so we'd like to go in for a target hemoglobin of 8 gram%, and for that we'll give PRBCs. And as far as platelets and FFP is concerned, we like TEG to guide us on that, So we look for the R value in TEG. So the reaction time or an R value of more than 10 minutes in TEG would prompt us to give the patient FFP. And a maximum amplitude of less than 50 millimeters in TEG would prompt us to give platelets, because that would be due to either a deficiency of platelets or due to a platelet dysfunction. So guided by R value and guided by MA in the TEG, we'll go in for platelet and FFP. And if that also doesn't suffice and INR does not come down, we can even go in for prothrombin complex concentrates, either 3-factor, 4-factor, right?
Right, ma'am. Because what we point 1.2 to 1.4, as you said, of the INR, isn't it?
Ma'am, there are connectivity issues. Yes, like I said, I would like the INR to go down to 1.4 by giving FFPs and PCC. And of course, I would like to see that the R value is less than 10 minutes as well.
Thank you, ma'am. Thank you so much. Shall we move on to the next case? Our next case is a 68-year-old gentleman who is diabetic with ischemic heart disease, and he has a post-PTCA status. 4 years ago, he had stenting of 2 of his coronary arteries, and with neck dissection, following which the radiotherapy was done about recurrence. Inverted T waves in 2-3 AVF with occasional VPCs. The left ventricular ejection fraction was 50% with regional wall motion anomalies, abnormalities, and an inferior wall hypokinesia. There was a further twist in the tail, that is the carotid Doppler showed narrowing of both right and left coronary, right and left carotid. Patient was already on dual antiplatelets, on oral hypoglycemic agents, on angiotensin receptor blockers and nitrates. The surgical plan was to go ahead with the resection of the recurrence along with ALT free flap reconstruction. My question to Dr. Rayani, how should we plan the evaluation of the cardiac status in patients, sir? Since this patient already is wheelchair bound, should we go directly for DSC or CAG, keeping in mind the backdrop of a CVA and a bilateral carotid stenosis? Dr. Rayani.
Good afternoon. Am I audible?
Yes, you are audible.
Yeah, I would thank the organizers and everyone here for having me here. Right. Perioperative myocardial infarction has a very high rate of mortality, ranging from 30 to almost 70% from the various studies. So somebody like this patient going for a non-cardiac surgery should have a thorough evaluation before we take him up for surgery. Initially, when you're going ahead with the history, you can do the revised cardiac risk index to understand to what level you need to do the risk stratification. This patient has had has a coronary artery disease with a stenting. He's had a CVA 6 months back, and he's a known diabetic. Diabetes with insulin, patient on insulin therapy is another risk factor. And he's on ARBs for his hypertension, I perceive. So hopefully I would assume that his creatinine is reasonably within the normal range. creatinine more than 2 milligrams per deciliter is a risk factor for perioperative cardiac complications. So I would do, after the risk stratification, we would do the investigations. 2D echo by itself is a poor predictor of perioperative complications in these patients. The question was whether I would do a DSE or a coronary angiography. Based on the recent Canadian Cardiovascular Society guidelines, I would actually look at doing a NT-proBNP if it is available, or a BNP if NT-proBNP is not available. NT-proBNP has shown to be a very good predictor of risk stratification for perioperative myocardial infarction. NT-proBNP more than 300 has been shown to be very sensitive for picking up the risk of perioperative myocardial infarction. If you are doing a BNP, it is more than 92 milligrams per liter. Earlier, if our cardiologist had not done the stress test, we used to send the patient back for them with a request saying it's a major surgery and we would want a stress test done. But if after cardiac evaluation they haven't done a stress test, now we actually go ahead and do an NT-proBNP, and based on that we do the risk stratification. So doing a DSE or a coronary angiogram is not compulsory. And as I've already told you, the Canadian Cardiovascular Society, from their recommendations, they say they discourage doing a DSE or thallium scanning for risk stratification, though the level of evidence is low to moderate. So yes, NT-proBNP can be used for risk stratification in this group of patients.
And so actually, it is a known fact, sir, that patients, survivors of head and neck cancers do have radiation-induced carotid stenosis. So would you suggest that these patients should have a carotid revascularization? Because in his case, he's having a symptomatic stenosis with plaque. That means he has had a CVA just about 6 months back. And so would that give us an indication that we should refer this patient, or we should ask for a carotid revascularization either in the form of stenting or endarterectomies? Keeping in mind again that if we have a stent in, we cannot stop the antiplatelets, dual antiplatelets for another 3 months down the line. So what would be your view on that, sir?
Yeah, perioperative stroke was not given enough importance earlier, but with the recent evidence, it has shown that if the patient has had a stroke within 6 to 9 months prior to the surgery, they have a very high risk of perioperative stroke. If it is 3 months or less, the incidence of stroke is as high as 65%. And if it's beyond 2 months, the risk of perioperative stroke comes down to around 20%. And beyond 9 months, the risk comes down significantly. So this patient had a stroke 6 months back with the persisting hemiparesis. So he is high risk for perioperative stroke. There has been a scientific statement from the AHA and the ASA in 2020, where they said if you're doing an ultrasound to assess the carotid stenosis as stenosis more than 70%, and if the patient is symptomatic, you can think of a carotid revascularization procedure. Our patient, he had a symptom, he had a stroke 6 months back, but the level of stenosis is less than 70%. So in our patient, I think we wouldn't go for a cardiac revascularization procedure, because revascularization itself is a high-risk procedure, and the patient can have a stroke during revascularization. So I wouldn't push for a revascularization procedure. But this patient is having a free flap of the ALT free flap transfer. So I would be concerned about the vasculature to which they anastomose. I would discuss with my surgeon, the plastic surgeon, telling them that there is a significant carotid artery stenosis, and the patient has undergone a radiotherapy. So there would be proliferation of the endothelium and the intima. So the vessels might be stiff. The anastomosis and the post free flap perfusion of the flap may be a concern. So I would discuss with them, with the surgeon and the plastic surgeon, before taking up this patient for surgery. I wouldn't actually push for a carotid revascularization procedure.
Right.
Recently, we had a patient who had a 80% carotid artery stenosis, and our vascular surgeon had suggested a revascularization procedure. But yeah, again, once you do the revascularization procedure, patient will be on dual antiplatelets, and bleeding is a concern.
Yeah.
And you normally, if you can wait for 3 months or longer, I think a revascularization procedure will make sense. Otherwise, you are actually putting the patient at a higher risk.
Yeah, thank you, sir. So I think our next question answer is already given by Dr. Rani.
Yes.
Yeah. So my last question for this case, I would like to ask to Dr. Barnhart. Is he here, sir? Yeah. Hello. Hello, Dr. Barnhart. Okay, so my question to Dr. Rani again. So should we stop clopidogrel straight away? What will be your bridging therapy plan for this patient?
Yeah, this patient has a cardiac stent in place. So I would think about stopping the clopidogrel 5 days prior to surgery. That is our normal practice in our institute. We would continue low dose aspirin 75 milligrams perioperatively. But if this patient had not had a stent in place, we would stop the aspirin 3 days prior to surgery and restarted the second or third post-operative day if he was on prophylactic antiplatelets without a stent in place.
So,
that would be the plan.
Yeah. So, sir, do you think there is any other agents available for bridging therapy apart from this low molecular weight heparin or unfractionated heparin? According to the Society of Thoracic Surgeons and Australian New Zealand guidelines.
Normally, we don't use bridging therapy regularly. The only one indication where we use bridging therapy in our setup is if the patient has had a coronary stenting within the last 3 months, where we continue a single antiplatelet and put them on a bridging therapy with low molecular weight heparin. And the last dose of the low molecular weight heparin is given 12 hours prior to the surgery, and we would continue the low molecular weight heparin in the post-operative period. Otherwise, bridging therapy for any other indication we are not using at the present moment. Yes.
Okay.
Okay.
Yeah. So I would like to go to our third case. We are running short of time, so straightforward to the case. It is a 45-year-old lady, weight 45 kg with BMI of 19, with a history of bronchial asthma. She is on regular medication, that is inhaled bronchodilators and steroids. Presented with painless progressive abdominal distension, significant weight loss along with shortness of breath. In further investigation and imaging revealed invasive ovarian cancer stage 4 with pelvic lymphadenopathy, moderate ascites with bilateral moderate pleural effusion. The MDT decision was to go for interval debulking surgery and HIPEC after 3 cycles of chemotherapy of carboplatin and paclitaxel. In pre-operative workup, all the blood investigations were acceptable. Only serum albumin was 3.2 gram per dl, and latest post-chemotherapy CT scan showed mild to moderate pleural effusion, mild ascites. There was partial response to chemotherapy, and on auscultation, bilateral diminished air entries there in the lower zone of the lung. Her post-chemo ECG and echo were normal, and she has moderate effort tolerance with dyspnea on exertion. And there is no immediate past history of exacerbation of bronchial asthma or any history of hospitalization. She has no other significant comorbidities. So my question to Dr. Deepa, ma'am, what investigation should be advised for respiratory assessment in this patient pre-operatively?
Yeah, sorry to interrupt in between. Suparna, we have only hardly 1 minute and 50 seconds. Please, you have to hurry up. Thank you.
Yeah. Okay, ma'am. So, Dr. Deepa, ma'am, please quickly answer this. What investigation would you advise for the respiratory assessment? Dr. Deepa? Yeah. Dr. Shagun, are you there, ma'am? Any of the panelists? Dr. Rayani? Hello.
Yes, we can go in for a lung ultrasound, and lung ultrasound is in fact more sensitive than a chest radiograph for detection of pleural effusion.
Yeah.
Then, so we should go in for that as well. And then to answer,
hello,
since
am
we
I
have only
audible?
30 seconds.
Suparna, am I audible?
Yeah, just
Yes.
now. Yeah, Dr. Shagun has started giving the answers.
Fine, let Dr. Deepa continue.
Oh,
Okay.
okay.
Okay, Dr.
Though this case, very good evening to everybody. Though this lady has undergone CT scan, I will prefer to do an HS CT scan here, because that will give us my 4 of the informations. First of all, post chemotherapy pulmonary toxicity. HS CT scan will tell us better than a plain CT scan, like ground glass opacity. ground glass opacity and interseptal thickening, and then the second HSCT will also tell about the quantification of the pleural effusion, and HSCT again with volume scan, HSCT will tell us about the volume of the lung, and again HSCT will tell the most importantly the pulmonary pulmonary metastasis, means parenchymal metastasis or pleural metastasis. If these are diagnosed by HSCT, then the case is questionable for CRS and HIPEC. So HSCT is most important, and then the spirometry. Spirometry is very important because here the patient is of bronchial asthma, though she is not on glucocorticoids or no history of recent exacerbation. So we can consider her to be on well-controlled asthmatic patient. But spirometry will tell us whether she is having any restrictive pattern or obstructive pattern.
So, ma'am,
again,
any cutoff value for this spirometry value?
Yeah, the FEV1 value, if it is
Dr. Deepa, I'm very sorry to interrupt. I think the time is up, and please, can I request moderator to sum up the cases of 1 or 2 points which you want to highlight? I'm very sorry for that.
Suparna?
Yeah.
Do you want me to answer any specific question? Yeah.
Fine.
As Chairperson Madam is saying.
Yeah.
One input I would like to get from Dr. Deepa, whether these type of patients we usually have, we have to do at times paracentesis before we take up this patient. So how much, what should be your, what is the volume you're looking to volume of paracentesis you would like to do, and what would be your management of fluid while you are doing this paracentesis? So hemoglobin, if you have seen, ma'am, it's around 3.2 grams per DL. So
actually, if you do a slow paracentesis, there is no requirement of volume replacement at that time, and she has a mild to moderate effusion, so we can go for paracentesis up to 1 liter without any fuss. We can go up to 1 liter, and there is no need of very regular IV fluid replacement for that. And beyond 1 liter, we need to be careful at a single go. But up to 1 liter is very safe. But yes, we should do it very slowly. And with albumin, these patients actually, if you don't remove the disease, they have this pleural effusion and ascites. And they will, you have to take up the patient with this ascites and pleural effusion. Only thing is that you have to stratify the risk with the lung PFT, DLCO, and if necessary, other risk stratification measures. We will also like GFR, glomerular filtration rate in case of HIPEC is very important. One of the important areas for cytoreductive, Ida Society for Cytoreductive Surgery has said that glomerular filtration rate, frailty index, these should be taken into account while preoperative nutrition scoring. These are very important. Other than cardiac and pulmonary assessment, along with total metabolic panel, complete blood count, and coagulation profile. These are very much, and in this case, the restrictive pattern, if we go by advanced PFT, as you have, I'm seeing in your slide, advanced PFT DLCO will be very much helpful to tell us the restrictive pattern is due to extrapulmonary disease or due to parenchymal disease. Whether it is due to this pleural effusion or patient has a metastasis or another parenchymal disease, or she's suffering from her asthmatic pattern, that is obstructive type of disease.
I would request any other inputs from the esteemed panelists. Or Sonal ma'am, would you like to put in any other inputs from your?
No input. I think we have discussed it in a very comprehensive and fruitful way. And since we are running short of time, so I would like to ask if there is any question. Otherwise, we can close this session and proceed on the next session.
Right. Thank you very much for having us here.
So thank you all the panelists and moderators.
Thank you, ma'am.
Thanks.
Yeah. Thank you. Yes.
যেটা বয়সের ওটাই হলো টাইমটা টাইমিংটা
Yeah, Sona, please introduce the speaker.
Okay, now we have Dr. Raghu Thota. He's a professor in Tata Memorial Center, and he has many honors to his credit, like he has a fellowship in pain management and Navratna Award by Om Padmashali Seva Sangh, and there are many other awards to his credit. Now I would like to invite Dr. Raghu Thota to speak on the cancer-associated thrombosis, the recent advances. Please, mic to Dr. Thota.
Good evening, everyone. All right, so I will be speaking on cancer-associated thrombosis recent advances. It's a very major and important topic because in cancer, the second leading cause is the thromboembolism. Other than the cancer itself, the patient dies because of the thrombosis. So that's why it is very important that we need to take care of these patients with respect to his thrombosis and give them adequate prophylaxis, as well as if needed the therapeutic regimes in this group of patients. So we will come to know, we will come to this how to go about it. So before that, little bit about the history. So if you see that, so Trousseau's sign. So I think during our medicines we might have come across this terminology called Trousseau's signs. So he published in way back in 1865. He proposed that there is a close interrelation between the cancer and the thrombosis. So if at all there is a thrombosis, especially it's a migratory thrombosis, so it goes from one place to another place. For example, if it is in the forearm, so it will keep on moving up. So in such case, so you should always suspect a cancer. So there is an interrelationship between these things, and that is how the Trousseau's syndrome was proposed way back in 1900s. So thrombosis can be the first presenting sign of occult cancer. So, and presence of cancer cells, there are cancer cells which are there in a thrombotic material. So if you take out, do the pathology, and you can see the cancer cells in there. So that itself states that a thrombosis, if it is there, so first rule out cancer. So that's an occult sign. We are all aware of the Foucault's triad in cancer-associated thrombosis, and these are the three important features which relate or which is a vicious cycle which happens in relation to the appearance of the thrombosis. So that is a hypercoagulability, endothelial damage, and venous stasis. So these three in combination will lead to the venous thromboembolism. So what happens in endothelial damage? The endothelial damage can itself be because of the cancer cells, or it can be because of the cancer related therapy in the form of radiations or chemotherapy. So what happens, there is a lot of endothelial cell activation which causes adhesions of the molecules or adhesions of the circulating tumor cells and all this. Also, because the patient is sick, there is a lot of immobility in this group of patients, which leads to venous stasis, and also a lot of inflammatory cytokines are released by the tumor cells, because of which there is an hypercoagulability states. And all these three triad, which we call as a Foucault's triad, can further accentuate and potentiate to the formation of venous thromboembolism. So before going to that, we just a brief outline of about what is the prevalence and risk factors in this group of patients. So approximately 20% of the first venous thromboembolic events occur in patients with active cancer, and VT is a common cause of death in patients with cancer. And the recurrence rate is twice as high in patients with VTE and cancer compared to those only with VTE and no cancer. So you can see with this this beautiful paper which has come in 2006 in American Journal of Medicine. So he's quoted, Stein has quoted that so the recurrence rate of VTE is twice as higher as if there is a VTE with no cancer. And if you see the risk factors, so there are many risk factors which are categorized, and the broadly categorizations are grouped as patient characteristics which go in favor of the advanced age, gender, ethnicity. So if you see, the African and American have a higher incidence of forming a VT than our Asian ethnicity. Even if you see the advanced age has more potentiation to form VTs compared to a younger age group. Coming to the cancer related factors, again it depends on the type of cancer and the cancer site. It is very, very important. If you see, the brain and the pancreas are the utmost and the commonest cancers which have a high incidence of VTs even in the advanced stage patients. And coming to the biomarkers, the increase in the platelet count, even the hemoglobin count, or even the total leukocyte counts also play a major role in increasing the incidence of VTs. And again, immobilization or hospitalization, there's a treatment related factors or major surgeries, or if the patient is receiving bevacizumab, which is very which can cause which increases the risk of formation of VTs, as well as the thalidomide group of regimens or lenalidomide group of regimens, they also increase the chances of VT in this group also. So how do we do a risk assessment in this group of patients? So there are many scores which are available in the literature, but the commonest one used is the Corona scores, which categorizes into three groups: high risk, intermediate risk, and the low risk. And this score includes the biomarkers which I have already stated in the previous patient risk factors or the risk factors. That includes the hemoglobin level, platelet and leukocyte counts. Clinical parameters includes the cancer type, for example, the brain tumor or pancreas or stomach or the multiple myeloma group of patients, and the patient factors with respect to the body mass index and all. So there is other Vienna Cancer and Thrombosis Study Score or the PROTECT score, which are not very commonly used, but the widely used is the Corona score. And again, if you look at this, the incidence is higher in pancreas, brain, then comes the stomach, and the least one is in the breast and the prostate group of patients. So overall, the journey of the patient, the cancer journey of the patient is like a diagnosis, we start a therapy, then there is a remission phase, then there is a relapse phase, then there can be a advanced and metastatic phases. So how the VT risk increases? So at the diagnosis, yes, there is a chance because the patient is having a cancer. Okay, so there is a risk. But as and when the days prolong and we start till the patient gets a chemotherapy, the chances keep on increasing for the formation of VT. And once you start a chemotherapy in this group of patients, the risk of VT drastically comes down, and it almost touches up to as good as the general population. And then the remission phase, it's a plateau, and again if there is a relapse, again the chances of VT keep on increasing until the metastatic phase. So that is how the risk cancer journey and the VT risk journey is correlated. So what is important for patients? So whenever we offer a therapy to the group of patients, so the patients have these 6 major questions. This study has been done by Nobel and published in Hematologica 2015, and very wonderfully they have asked the patients, it's a questionnaire questionnaire survey, and they ask you what is more important, how do you go about if you want to start the therapy of. So they said that there should not be, almost 40% of the patients said that there should not be any interference with our cancer treatment if you are starting with this therapy, or they wanted to know about the efficacy or the recurrence of the VT. There should not be major bleeding problems. Almost 20% of the patients were asking. Only to monitoring and minor bleeding, only 2% of the patients were interested in. So the most important point was that there should not be any interference with their ongoing cancer therapy when you are starting this therapy. So to date, the pharmacological anticoagulant agents most frequently used are the LMWHs, or we call it as the low molecular weight heparins, and DOACs, that is a direct oral anticoagulation agents. We will come to that, what are they and all. So there was a real world analysis which was done and it was published in 2020. It's a recent study, real world data regarding the management of cancer associated thrombosis, and from September 2018 to January 2020, and they found out the LMWH was the most common initial anticoagulation treatment for VT in patients with cancers, and DOS, that is a direct oral anticoagulants, were the most common initial post-discharge outpatient options. So if you see, the LMWHs are not oral, so they are all injectable formulations, and these oral anticoagulants, so they can just pop in, so they can take it home. So that's why while discharge, this are the medications which were commonly prescribed. So coming to the updates, so we will divide the updates with the placebo versus the low molecular weight heparin prophylaxis. Then we will compare the low molecular weight heparins with the vitamin K analogs. We will compare the studies of the low molecular weight heparins with the direct oral anticoagulants, and the direct oral anticoagulants versus the placebo. So coming to the placebo versus the low molecular weight. So this is a famous trial that the name itself is famous. This is a dalteparin or a fragment trial, which we call it. It's a fragment advanced malignancy outcome study, which was done way back in 2004. So even our Tata Hospital was the center of this trial. It's a multi-center trial, and they had included almost around 400 patients, and where they were giving placebo nothing in one group of patients, and dalteparin 500 international units per day in another group of patients. And they selected advanced or metastatic breast cancers or lung cancers or GI, pancreas, and all these things. And the treatment or the study duration was for 1 year, and they found out that the outcome it favors was that dalteparin gives a good prognosis. So what is a good prognosis is that the recurrence of VT is less in this group of patients who had received dalteparin or fragment. So it is also called as a fragment trial, or the famous trial. The second trial which was done is a malignancy and low molecular weight therapy, or the MALT trial we call it as, and it's a double-blinded study again in patients with venous thromboembolism. Again, here the drug used was natroparin versus the placebo, and again they use the same group of patients, that is metastatically and locally advanced cancer, and the therapy was the study duration was for 6 weeks full dose, and then for almost around 4 weeks, they had given half dose. And again, they had seen that the hazard ratio is 0.75. So that's a very good thing. And this study favored again natroparin. Same thing happened with dalteparin again. The Sidaris et al. Group has done, and they have also found the low molecular weight heparin favors good prognosis compared to the placebo groups. So coming to the VK or the vitamin K analogs, that is vitamin K antagonists, that is the warfarin versus the low molecular weight or the direct oral anticoagulant agent, anticoagulants prophylaxis. So the direct group in which the clot trial which has been done, and it's a comparison of the low molecular weight versus the oral anticoagulation. So that's a clot trial which was done by Lee et al. And it's an RCT, and it's a multi-central trial where they had used that's oral vitamin K. That's in one group they have used warfarin, and in other group they used low molecular weight dalteparin, and 1 month followed by 5 months on a low dose, and they had seen that this study has favored the low molecular weight heparins over the vitamin K antagonists, and also not only favoring the reduction of the recurrent VTs, it also favored that the the risk of bleeding was decreased in this group of patients, I would like to say. So they had seen two things here. So they had seen whether there is a higher chances of recurrence of VTE or there is a decreased risk of bleeding. So they had seen that low molecular weight favors both. So they have reduced the recurrence and they have decreased the risk of bleeding compared to the vitamin K analogs or the VKs, that is warfarin. The same thing has favored the other two, the CATCH trial as well as the Canthonox trial, the LIGHT trial, the Einstein DVT, and the RECOVER trial. So all these trials have favored the use of low molecular weights or the direct oral anticoagulation agents over the vitamin K antagonists. So vitamin K antagonists, so this is where from almost I think 2006 or 2007 the first trial was published, and from there the warfarins have gone out of use. So again, coming to the direct anticoagulation agents, versus the low molecular weights. Now, because it's very easier to use direct anticoagulation agents because they are just oral formulations compared to the low molecular weights, which are injectable formulations, because the patients may not like to take injections for a long period of time around his abdomen or his forearms subcutaneously. So this became very famous, the DOAs, so especially the rivaroxaban or the endoxaban and apixaban. But one thing which was not favoring this group was two things, not one thing. One was they were associated with a higher incidence of bleeding. Second is the cost wise. So these two things were not in favor of this group of group of drugs, DOAs. Again, low molecular weights, though the DOAs were much better in reducing the recurrence of VTE, but the bleeding risks were higher with DOACs compared to the LMWH. So if you say the LMWHs were decreasing the risk of bleeding, but not compared to the DOAs with respect to the recurrent VTEs. So there are many trials which we have done. The SELECT D trial is the selected cancer patients at risk of recurrent VTEs, or the ADAMS trials, the apixaban, that's the ADAM VTE trial, that is the apixaban and dalteparin in active malignancy associated VTE trial. And there are other two trials, that is the API apixaban trial and the CONCO trial, which are ongoing and they have not yet published yet. So they have also done DOAC versus placebo. Definitely it gives much better results, the AVA trial and the Cassini trial. So based on this data, so what we conclude is that the one size doesn't fit all strategy. So it's not that okay, you can give apixaban to all group of patients. No. So we have to personalize, or the Taylor regime or the best fit strategy has to be taken into consideration. So what are the factors which needs to be considered when we want to use which group of medications, either an LMWH or DOACs? It's based on these four parameters. That is the tumor type and stage, the bleeding and the VTE risk, potential drug-to-drug interactions, and the patient's preference, so that we have optimal therapeutic management for the cancer-associated thrombosis. So this emphasis on personalized approach and patient preference is reflected in one of the ongoing trial, which is reflecting or which is evaluating the patient satisfaction with DOAC versus LMWH treatment. It's still under ongoing and not yet published. So the regular review and consideration for anticoagulation is very, very important. It's just not that you have started LMWH and just see that the patient will continue till death. It's not like that, because the patient's risk for the VT, the recurrence risk or the bleeding risk, keeps on changing based on the patient's cancer treatment and many other factors. So also there was one more important aspect which all these studies have not looked into, that is the appropriate length of anticoagulant therapy, and most of the trials had looked for up to 6 months or the maximum up to 1 year. So this is APCAT trial, or the apixaban cancer associated thrombosis trial, is there to assess the safety and efficacy of extended treatment of CAT, and it will provide an insight into this area. 3 minutes remaining. All right. So the treatment guidelines, actually there are guidelines which I wanted to say, but since I am having only 3 minutes, I will go mostly towards the end, that is anticoagulation therapy in special population, cancer associated treatment in medical oncology patients, and thrombosis at unusual sites. So there are ASCO guidelines and NCC guidelines which are there in the literature. You can just go through that. Since we are short of time, I thought I could catch up with it. So coming to this, which I wanted to say. So the treatment of CAT. So how will you treat it? So as per the ASCO guidelines, initial anticoagulation should involve the LMWH or ultrafraction heparin or rivaroxaban, and among the parenteral agents, LMWH are preferred, and based on the renal impairment and other things. Coming to the most important thing, the insertion of an IV filter, it should not be offered to patients with established or chronic thrombosis or to patients with temporary contraindications to anticoagulation. There is no role of IVC filters for primary prevention of VTE, but they must be offered to patients who have an absolute contraindication to anticoagulation in the acute settings if the thrombus burden is considered life-threatening. Then only you should offer this IVC filters. So that's why I thought I will just specify this. And if you see this, in pregnancy, there are no specific recommendations. Even in thrombocytopenia, they have not given any specific indications, recommendations, especially the ASCO guidelines. And if there are primary or metastatic brain tumors, the anticoagulation should be offered as it for other patients. Okay, so it's not that. So another aspect, important thing which I had found out is that thromboprophylaxis in palliative care settings. So it should be considered for all patients, irrespective of that. But there are certain factors which we need to see, that if the patient's life expectancy is less than 3 months, we should withhold the thromboprophylaxis. The thromboprophylaxis should not be given. So the NICE guidelines clearly state that, and it should not be offered. That's what I'm saying, in the last days of life, and the thromboprophylaxis should be reviewed daily in this group of patients. And even the NCCN doesn't have any guidelines specifically. Also, even the ASCO guidelines have no recommendations for this except for the NICE guidelines. So that's all with this. You can reach to me if you have any queries on my mobile number or my email ID, or you can tweet me. Thank you very much.
Thank you, Dr. Thota. Nice presentation, I must say. Is there any question? Okay. Can I ask you one thing, Dr. Thota? Since we have talked about the management part, the prophylaxis, prevention, and the management part, I just want to ask you, have you come across any study or any reference stating the role of any screening method in cancer patients for CAT, cancer-associated thrombosis? Have you come across any studies?
So that's what I told you. So there are certain assessment criteria, risk assessment criteria. There's a Corona score and all. So we just
So would you like to suggest to do such screening methods routinely for our patients?
Yes. It's just a 5-point score. That's it. So we can just do that. But that is most oftenly done by our medical oncologist and surgical oncological colleagues. So rarely the patients do land up with us.
Because that will definitely make the difference in overall management and outcome of the patients, rather than having a surprise that patient is coming with something. Definitely. That is why. Thank you, Dr. Thota. A very nice presentation. I would like to invite our next speaker. Our next speaker is Dr. Ravi Shankar Rao Bakadi. I hope I am pronouncing the name correctly. He is a consultant in anesthesia. and perioperative medicine in the Royal Marsden NHS Foundation Trust, London, UK. So he'll be speaking on management of intraoperative hemorrhage. So welcome, Dr. Rao. Please go ahead.
Thank you very much. First of all, thank you to the organizers for inviting me for deliver this lecture. Fantastic meeting. I think I've been up since morning to watching most of the lectures actually, and we ran a masterclass as well. Great presentations and great teamwork. I was listening to the previous panel discussions and also listening to my friend Raghu Thota's lecture on thrombosis, and also following this, there is I can see in the program there is a debate as well. So a lot of things will be discussed about blood today, I could see. So this will be the most up-to-date what's going on in the hemorrhage world, and why I was involved over the years with the management of anemia and hemorrhage, and also some of it is a personal view, and also our practice in the UK. So your practice in India might be different. These are all my conflict of interest and nothing personal, or most of it is research and education. I've been involved with the blood world from last 16, 17 years since I've been a consultant at Royal Marsden. I have a special interest in anemia and hemorrhage management. We run a program for bleeding, clotting, hemorrhage seminar. Last year it was attended by more than 1,000 people. And this year is the 17th anniversary. This is where I work in the bank in the central London. As you know, Royal Marsden is a cancer hospital, exactly like your Tata Memorial Hospital. Is the first hospital in the world to care for cancer patients, established in 1852. I just go through, though it says cancer bleeding, but I think the majority of the bleeding blood world, what we learned is from the trauma. Trauma means both civilian trauma and war trauma, and how we can adapt the practice to our day-to-day bleeding, be it the trauma bleeding, be it the surgical bleeding, be it the obstetric bleeding. If you ask me 2 decades ago, how do you manage bleeding, any bleeding patient? So this is John Hardy's work, which said, okay, give crystalloid, give colloid, which is non-blood colloid like hemacil, gelafuscin, then go for the packed cells, then go for the plasma or cryo, then go for the platelets, and then think about alternatives. The whole thing as ideology has changed. It's actually other way around now, and I'll explain that going through. If any of you are practicing still this, I know that some of the institutions still follow this, which is completely wrong. You need to update your knowledge and also the practice on transfusion. Many times in the conference, I asked this question, okay, have a look at this blood gas. This is while I was managing a major hemorrhage, took a blood gas and showed it to my trainee. What is it? So, okay, I got all sorts of answers on the left side. Okay, the answer is none of the above, which is the last one. This is from a bag of blood. You're about to give it to the patient. You just, so next time you're doing a list with any of your trainee or colleague, do this experiment. So just take a small sample from the bag of blood, run it in the blood gas machine, and have a look at it and see what you get. And this is what you are transfusing to your patient, your sick patient. So you know that why the potassium goes up when you have massive transfusion, why the acidosis get worse, and what's the hematocrit, and what's the other things. The question I've been asking all along is, do we understand blood? Most of us think we do, but we don't. It's a complex story in any perioperative blood practice. This is from the anesthesia a few years ago. Be it the transfusion, be it the transfusion-associated reactions, whether it's the tip of the iceberg, whether you report properly, whether you understand, and also in cancer, whether it's we should practice. I think there's a debate later on whether we should be practicing restrictive transfusion or we should be liberal, or is it just to say there is nothing called restrictive or liberal, just optimal case by case. This is another one you need to try with your trainee, okay, to understand the basic mantra of our medical life, oxygen delivery. So do we have a good pump? Do we have a good exchange mechanism, which is your lung? And often forgotten, do we have enough blood enough hemoglobin in our blood to carry this oxygen to every cell in the body? Again, a lot of people say hemoglobin so much, so what? It doesn't say much to what's going on unless you know the volume status of the patient. The patient can be with a hemorrhagic shock, but hemoglobin normal. Doesn't mean that the hemoglobin is normal because of euvolemic. At the same time, normal volume hemoglobin can still be the same, but patient had wonderful anesthetic, wonderful surgery, and anesthetists have given 6 liters of fluid and a further another fluid, 2 liters of fluid in ICU. Hemoglobin drops to 9, everybody starts jumping up and down. But actually, it's not surgical hemorrhage. It's just we induced hypervolemia in the post-op patient, and hemoglobin is dropped. So unless you know the hematocrit, you shouldn't be commenting on the hemoglobin. Why the hemoglobin is important? Because don't forget, hemoglobin is red blood cell is crucial to the circulation. Below 7 grams per deciliter, I know you still use the deciliter. So below 7 grams, it's a look at the mortality if your hemoglobin drops. The message we've been trying to get across to every clinician and every nurse is blood should be reserved for a bleeding patient. If the patient is not bleeding, you should not be transfusing. There is other ways of treating anemia. I know we all heard about this patient blood management, originated in Australia a few years ago, now adapted across the world. Even the WHO is written about this, patient blood management. It's all about maintaining hemoglobin concentration, optimize hemostasis, and minimize blood loss during surgery and trauma to improve patient outcome. It's all about patient outcome. Of course, there are 3 pillars. The 3 pillars are optimize erythropoiesis before any major surgery, and then optimize hemorrhage during operation. And this is what we are discussing today. But do not forget, just at the end of the surgery, you continue the process till the patient is discharged and goes home and gets back to their life. Of course, there are enough guidelines. Doesn't matter where you go in the world. There are every country has every continent has written guidelines. The most important thing about these guidelines is, one, you must read them, you must understand, and then you must adapt to your nation, you must adapt to your own clinical practice. There should be a hospital-wise guideline what to do when there is a hemorrhage. One of the big message came out of the NICE guidelines published in 2015 is single unit blood transfusion for a non-bleeding patient. You have no right to give another 2 units of blood in a non-bleeding patient unless after giving 1 unit of blood, you check the clinical parameters, you check the patient, and then decide whether to give another unit of blood or not. Again, transfusion trigger, this is another major change in the clinical practice. You should not give transfusion unnecessary in a non-bleeding patient unless the hemoglobin drops to less than 7 grams per deciliter or 8 grams per deciliter if the patient has symptomatic ischemic heart disease. Of course, during major hemorrhage, you must maintain the hemoglobin between 7 and 10, depending on what goes on, because remember, red blood cells also play a big role in preventing coagulation. Man on the right here is David Knott, vascular surgeon, who's been to every war zone in the last 20 years or so. Man on the left is an anesthetist in Syria who has been bombed and killed a few years ago, and he used to help him to manage trauma patients. He gave me an interesting data when he went to Syria in 2013 to operate on trauma patients, or both civilian and war trauma patients. Everybody who had a hemoglobin of more than 5 survived his operation on a makeshift operating table in a car park. Anybody who had hemoglobin less than 5 did not survive. So just to understand the importance of hemoglobin and what should be the hemoglobin during major hemorrhage. Of course, we say that we should try and encourage use cell salvage and tranexamic acid, anybody who has a major loss of more than 500 ml. Of course, tranexamic acid is safe, and you can use, and then there are enough evidence now both in the trauma world and also women trial. Always people ask me, what's the incidence of tranexamic acid in thrombosis? There's no data on that. There are 128 clinical trials saying that tranexamic acid is safe. The only thing to avoid with the tranexamic acid is avoid more than 50 milligram per kilogram dose. Self-salvage, yes, you must use it. Cancer is not a contraindication for self-salvage use as long as you use leukofilter and you inform the patient and take consent. There's no evidence that cancer recurrence worsen if you use self-salvage blood in cancer patients. Blood components, of course, you should have your own policy and it should be available, and in small children, it should be volume rather than number of units. You should have your own guidelines, okay? So some of this is more the science, and you know what to do and what should be given or shouldn't be given, what to ask, 6-unit 1-to-1 ratio, or what to ask. That's not the point about, just the point about the guidelines. You should also have them. Sometimes it's not about what the product, you know what to give, you know where the blood is available, but sometimes it's who is going to get those blood. Finding a porter, finding somebody to run, as finding and a lot of hospitals have the blood bank in somewhere else in the building, in the complex. So who can run there and get those? So this information must be available, especially because rapid turnover, because you have trainees coming all the time. They should know how to react and what to do and whom to contact when there's major hemorrhage. Again, group A negative must be available. Every clinician must know where it's available in the building and how to access that. And if you don't have Go negative, at times it's difficult. Even the group specific red cells can be achieved within 10 minutes and can be administered safely. Of course, red blood cell and FFP has been an ongoing debate over the years. So just to make sure you understand what happens during the coagulation and why you should concentrate on clotting factors. It's a simplistic way of explaining the coagulation. Though we think there are 13 factors, actually no, there are more than 1,000 factors. But I think what's important is triggering of factor 7A relating, and then the activated platelets, remember platelets are required, and then the activation of various factor 10, 5, 10, and then 13, and then huge thrombin generation, and then in the end, we need a stable fibrin plug, and which we known this for more than 15 years or so. Okay, don't forget at this, every point of this step is calcium plays a role. Okay, unless you have a calcium, none of this will get activated. Another thing to understand during a major hemorrhage is a circulation, okay? Where the blood is coming from, where the blood is going. And remember, cardiac output, majority 70% of the cardiac output goes to descending thoracic aorta. That means 70% of the heart's blood returning to the heart is through the IVC. So if you are in a major abdominal cavity and surgeon pressing on various organs, and so at this one there is no return, that means heart will be empty. That's the time to manage the flow, understand the flow versus pressure. If you give too much vessel pressure on an empty heart, you induce myocardial injury. So that is the reason we say accept hypotension during major hemorrhage till the volume is sorted. And then once the pressure is, when the volume is okay, when the flow is okay, then consider optimizing the pressure as long as surgeon is happy with the hemostasis. In terms of dilational coagulopathy, just to say that every time a major trauma happens, there is a huge thrombin release, okay? And thrombin causes fibrin plug. But this is just four graphs to show that if you dilute this by 25%, which is the black one, then the green one at 50%, and then the red one by 75%, what happens in the hemodilution? So your thrombin generation is 50%. That means you're not going to get enough hemostatic plug. Any major hemorrhage, in uncontrolled hemorrhagic shock, all you have to worry is concentrate, what am I administering? Because surgeon or a radiologist is concentrating on hemostasis, and you should be worried about what fluid I would give. It should either clot or carry oxygen, i.e. blood or coagulation product. Of course, RBC and fresh frozen plasma, cryoprecipitate, and the platelets are available in most countries as coagulation products. And in some countries, they don't use plasma. You have PCC and fibrinogen concentrate. Of course, we know about plasma, and of course, people go by mils per kilo. I would say it's rather than mils per kilo, either you go 1:1 or 1.5:1 ratio use. Of course, you can keep the thawed plasma and cryoprecipitate up to 24 hours. Of course, most trauma units have a readily available plasma at the moment. And platelets, yes, maintain the number 75. Remember the number 75 during major hemorrhage. And of course, people keep asking about neuroarterial blockade. As long as it's more than 50, it should be fine. PCC, yes, if you can't give plasma, not available, you should not be hesitating to give during major hemorrhage if you're given 4 units of blood and patient is still bleeding. Same thing goes to the fibrinogen concentrate. You can't give excess cryoprecipitate, you're not available. To maintain the fibrinogen concentration more than 1.5, you can give fibrinogen concentration. Of course, I'm not going to go argue about the ratio, but as long as it's either 1:1 or 1.5:1, doesn't matter. As long as you maintain the numbers and monitor them, should be fine. Again, monitoring is a simple monitoring will give you lots of information. And don't forget the one at the bottom, which is a biochemical, your own simple blood gas analysis will give you lots of information, especially the calcium, and do not forget the calcium. Of course, TEG or ROTEM, if it is thromboelastography, if it is available, you must use it. It's not a must, but I think most units in cardiac surgery and trauma units have it. Even in obstetric hemorrhage, I think it should be available, and you should know enough training to be available to use it and how or what to do with that. And obstetric unit also now started using thromboelastography. Again, they also started using the similar ratio as trauma. Do not use crystalloid to replace blood loss because it can induce coagulopathy. Okay, once you're happy with the coagulopathy bleeding, and then you can institute some water replacement. Of course, you can use your own ratio, and the most important is avoid unnecessary vasopressors and maintain hypotensive anesthesia. Of course, you can have your shock packs in a combination of red blood cell plasma and platelets. We have our own 441. Okay. And this is just to know, I got 1 minute now, just to know, this was my practice. This is one of the surgeons took one of our patients' blood gas analysis way back in 2005. And just to show that things can be kept very simple. This is to show on the right, the blood loss was 4-point-some liters and total transfused 4 liters. What did we transfuse? And I think the gelafusing 500 ml was when I quickly went for a coffee and then came back, and somebody, a trainee, has started gelafusing. Other than that, it's just 2 liters of crystalloid and all blood and products. I'm not going to go into this. Do not forget transfusion overload and TACO, which is underreported and not well understood. And risk factors, these are the risk factors, especially cardiac failure, patients with comorbidities. You have to be very careful, especially with the hypoalbuminemic patients, which is common in cancer. So do not forget transfusion overload. Again, another thing not to overlook is unnecessary blood sampling, because it can cause more anemia just by doing so many unnecessary blood tests. With that, this is a quick whirlwind tour of the hemorrhage world, which is a vast topic. And I think it's very important to save blood, because blood is essential for any major bleeding rather than avoiding and abusing the blood and blood products. Thank you very much. Once again, thank you for inviting me to participate in this wonderful conference.
Thank you, Dr. Bakari. There is no question from the audience. Can I ask you something? Yeah. Since you have mentioned about the cell salvage.
Yeah.
So what is your opinion and practice in UK for other blood conservation techniques like pre-op autologous donation, or because there are many risks associated with the allogenic blood transfusion. So what is your practice over there?
Our practice, honestly, two things. One is autologous transfusion is banned in the UK, and it's practiced in some countries in Europe.
Banned for some major
it's
reason?
mainly because when it was in practice, there are a lot of mistake errors happen, human errors, and also some of the products were wasted. And so that's the reason it was not practical. And number two, cell salvage, we had it for a few years. We used it in some of the major IVC reconstruction sarcoma patients. Again, the problem is it's not about using unless you have a trained staff. So because what happened was over the years, the massive hemorrhage was so rare because one a month. So it's so rare and difficult to train the staff and to use it. So we rarely use it. We have it available if somebody needs it with the Luca filter, and you can use it, no problem. I think we need to select the patient when surgeon says, yes, this patient is likely to bleed 5 to 10 liters, and the patient is probably Jehovah's Witness, and if they're likely to bleed, so you can use it, no problem. And also some people use straight from the suction washed with heparin that can be used. And again, that is practiced in some of the cardiac centers where they use major vascular resections. But we rarely do such procedures because it's done in major vascular reconstruction done in cardiac centers. But in cardiac surgery hospital, they use it.
Okay, we have one question from Dr. Manas Khan. That is, how does hematocrit helps in knowing the actual hemoglobin?
Because you need to understand that hematocrit is, normal hematocrit is around 40 or 45. And then you know that's related to hemoglobin. But at the hemodilution, when the hemoglobin goes down, then you need to know whether hemoglobin goes down because it is due to the low hematocrit, or is it hemodilution, or is actually patient has lost blood. So that will make you understand whether you caused hemodilution or not.
Very true. One more question. What is your practice of blood transfusion in cancer patients, especially like colorectal cancers? What is the practice
Colorectal cancers, as I said,
because here surgeons, they do not prefer us.
Yeah, we have
and studies are also there. Yeah.
We have very good anemia service. We catch the patients during the cancer journey, during chemotherapy itself. They get their iron infusions and vitamin infusions, number one. We give transfusion only if the hemoglobin drops to less than 70 or 80, otherwise very rarely. And the surgical techniques have improved so much because most of our surgeries are now either laparoscopic or robotic, and rarely use 100 ml of blood. Only time we may need blood transfusion is somebody who's having a massive exenteration with sacrectomy, otherwise, no.
Okay, thank you, Dr. Bakadi. There is one question to Dr. Thota. Dr. Thota? Is he here now?
Yeah,
I think he has. Dr. Raghu Thota?
Yeah, hello.
Okay, I think.
Hello.
He's there.
Hello.
Okay,
hello.
Dr. Thota, there is one question from audience that what is recommendation for prophylaxis in patients with thrombocytopenia?
In thrombocytopenia,
would you like to give your opinion on this?
Yeah, the ASCO guidelines have no specific recommendations, but what NCCN says is that if the platelet count is more than 50,000, you can use enoxaparin or the low molecular weight heparins, the same dose, regular doses. But if it is less than 50,000, so then it's your clinical judgment, and if it is less than 30,000, don't use it.
Okay. I think we should wind up this session by thanking Dr. Thota and Dr. Bakadi. A wonderful presentation. Thank you. Thanks a lot.
Thank you. Thank you, everyone.
Thank you, Chairperson and Speaker. It has been very intriguing discussion. Now I would like to hand over to Dr. Swati for the next session.
Now we will proceed to our last session of the day, that is fluid and blood management. I'm delighted to invite the chairperson, Dr. Jyotsna Goswami, Senior Consultant and Head, Department of Anesthesia and Critical Care, Tata Medical Center, Kolkata, and Dr. Deepika Patil, Associate, GCRI, BJMC, Ahmedabad. Over to you, ma'am.
Good afternoon, everybody. We reached now with the last session of the day, and a very interesting topic now to discuss in the panel. Restrictive fluid therapy in perioperative period improves outcome in major GI oncosurgery. So for that, the moderator will be Dr. Palash Kumar. He is a dynamic anesthesiologist, consultant anesthesiologist in Scientific Secretary, ISC West Bengal, and he is attached to Woodlands Hospital, Kolkata, West Bengal. Palash, over to you.
Good evening. Am I audible?
Yes, you're audible.
Thank you. Thank you, Dr. Goswami, for your kind words and the invitation to this prestigious conference. I've been given an extremely talented and experienced faculty, so my job has been made very easy. Dr. Saurav Vig, the youngest in the panel, he is an assistant professor in the Department of Onco-Anesthesia and Palliative Care, the National Cancer Center at All India Institute of Medical Sciences. Also on the panel is Dr. Raj Tobin, who is the Director and Head, Department of Anesthesiology and Pain Management at Max Super Specialty Hospital in New Delhi. Then we have Dr. Kalpana Balakrishnan, who is Professor and Head of the Department of Anesthesiology, Pain and Palliative Care at the Cancer Institute in Adyar, Chennai. And lastly, we have Dr. Anjali Pingle, who is a consultant anesthetist associated with PD Hinduja and MRC Mumbai. So since we have limited time, I would like to directly proceed to the topic per se. So today what we're going to discuss is the restrictive fluid therapy in the perioperative period improves outcome in GI oncosurgery. For the last couple of decades, there has been a lot of work and a lot of evidence-based work in this field. And most of the anesthetists who are doing any big general surgery or oncosurgery have changed their practices mostly in favor of using restrictive fluid therapy, especially in case of abdominal surgeries and abdominal oncosurgeries. So let's have a look at the different aspects of it, how it helps us, and how the different anesthetists use this in their daily practice. So let me begin with first by defining, what exactly is our conventional fluid therapy. So Dr. Saurav, could you please tell us what exactly is the conventional fluid therapy or the rationale behind conventional or regular fluid therapy that is used in these kinds of surgeries or used to be used in these kind of surgeries?
Good evening, everyone. Am I audible?
Yes, you are.
I thank the chairperson and the organizers for inviting me to this talk. So the rationale of the conventional fluid therapy. The conventional fluid therapy was a fixed type of fluid therapy which was based on the weight, nature of fluid losses, and the phase or the nature of the surgery. So it used to be in practice, and it had major components that there was a fasting component. The patient was fasting, and fasting was to be covered. Third space losses was a major component of this concept, and maintenance and insensible losses were covered, and blood losses were covered. So on ml per kg fixed calculations were done for per hourly fluid calculations, and Holiday-Segar rule for pediatric or adult 2 ml per kg for maintenance were used to calculate, and all these components were added to make a hourly fluid chart for the patient. And this usually ended up in giving 12 to 18 ml per kg per hour of fluids, which in a major surgery ended up around 5 liters, 4 to 5 liters. Over the years, this was found to have negative and adverse effects on patient outcome. And the concept has progressed to goal-directed and to restrictive fluid therapy.
So basically, when you're talking about conventional fluid therapy, we sort of already define how much fluid we are going to give to this patient even before we start the surgery, depending upon patient factors and the surgical factors that we assume. And now, after we have sort of defined this regular fluid therapy, how do you define this restrictive fluid therapy, or how this is different from the usual conventional mode of fluid therapy? Dr. Saurav.
The concept of restrictive fluid therapy, it has gained populance in the last decade or 15 to 20 years. This is also called as a zero balance fluid therapy. So it takes into consideration that only the maintenance and the insensible fluid losses has to be given intra-op as at a rate of 1 to 3 ml per kg per hour. and there is no third space, no cover for third space, no cover for fasting. Third space concept is out. There is no cover for fasting, and there is no role of preloading, even if there is a neuroaxial block. And this leads to a main target is a zero balance. Whatever is the output and the blood loss has to be covered with fluid, and the transfusion triggers have to be seen to give transfusions. And this has some anesthetic variables like depth of anesthesia and stage of surgery have to be taken into account in actual practice of restrictive fluid therapy, which we'll be discussing.
Okay, so we'll take up a few of the points. So conventional fluid therapy, we sort of define how much fluid we are going to give almost beforehand, and restrictive fluid therapy, we are seeing what are the losses and the insensible losses and only covering for that. So Dr. Tobin, so what are the strategies or the techniques that we use so that we achieve this restrictive fluid therapy, or as Dr. Saurabh has said, that zero balance fluid therapy. So when we end the surgery, we do not end up with any excess fluid in the patient's body. So how do you achieve that target?
Good evening, everyone, and thank you for the invite, SOAPCCON team. There is, of course, the clinical. We are, as anesthetists, we rely a lot on our clinical parameters, whether it is pulse, blood pressure, urine output, CVP in a patient. But they come with their own limitations. So this is one way of dealing with. Pulse may not give you a correct picture if the patient is on beta blocker or any aldosterone receptor blocker drugs. If you're looking at CVP, it has its own fallacies. We all know about it, the impact. It doesn't really tell us the preload that well. Urine output, again, especially in cancer surgeries, sometimes surgeons may open up the bladder, or he may ask you not to fill the bladder. So, these things do not work for us a lot of time. But still, clinically, we can assimilate quite a bit of information from these, plus looking at the lactates. Well, I am a big proponent of looking at lactates to look at the sufficiency of the volume. So basically the aim is maintaining the volume, the circulation, the perfusion, the oxygen delivery. And I think we can get a lot of these things. But apart from that, we have certain technical backups, technology which has come to our support, especially when we talk in terms of goal-directed therapy, especially goal-directed therapy with zero balance. The term zero balance, as Saurabh also mentioned earlier, is basically the aim is that patients pre-surgery and post-surgery weight should be the same, which is not very feasible for us, in every time to weigh the patient. Not every hospital has that facility to weigh the patient in the post-op period. However, goal-directed therapy now, where we use technology, so there is esophageal Doppler. Many of those who don't have a cardiac setup may not have that technology with them. We do have a company which is focusing a lot on these goal-directed therapies, which has FlowTrack and which has EV1000, and now the new one which they've come is called the Hemosphere. So I have used a lot of FlowTrack. I still use it, but mostly for supra-major surgeries where I know there's going to be a lot of fluid shift, surgeries go on for long hours. So moderate duration surgery, moderate loss surgeries, I still go with my clinical equipment and, I manage the patient with the restrictive strategy of, as you said, 1 to 3 ml per kg body weight, compensating only for the blood loss or any ascitic fluid which has gone up, or if there is any other thing which has to be seen to like a patient of sepsis. The problem with using the technology is that's like SVV. So I like using SVP, but I do understand that it doesn't help me when the thorax is open. It does not help me if the patient puts a pack to look at to do the dissection of para-aortic lymph nodes. So as long as you can understand the limitation of technology has is of good help. Is of good help. It is of not much use if you've extubated the patient. And the problem with technology is that it comes at a huge cost. So, FlowTrack is 10,000 rupees per patient. And if you use the newer one, which they have been showing me, which I have not used as for now, the Hemosphere, which says that you can predict hypotension much earlier than patient presents, there the consumable is up over 20,000 per patient. So whether in a cancer, especially in a cancer setup, we can put that kind of cost every patient, we have to do analysis of cost and benefits against whatever. And as far as I'm concerned, when I'm looking at fluids, I don't jump at anything new which comes in. So I like to rely on my experience also. And I've also seen that becoming too restrictive, I think we'll come to it later in the panel, has its own
we'll have to deal
disadvantages.
with that. Yes. So most often you would rely on your clinical judgment to sail through the case. And if you are having doubts, maybe using lactate, and in super major surgeries,
we
would
use
like to use advanced
invasive
technologies.
lines, we use invasive
So
lines.
maybe if
and
the
we
costs
use,
were more, you'd be a little more freely using them. But
absolutely.
right now, cost would preclude
cost
their
is
routine
so
use.
we do use it in my the place, fortunately, where I work. Affordability is not such a big factor, but we get a whole spectrum of patients.
So we have to keep all the patient spectrum in
Yes.
And so it's
and
possible.
We individualize.
Right. So from I think the take-home message should be that it's possible to depend on our clinical judgment in most of these cases, maybe a few ABGs, and in difficult cases we resort to the advanced techniques.
Yes.
Okay. So as the discussion initially went towards the third space loss, Dr. Anjali, third space loss used to be a really big thing previously. Now nobody seems to be compensating for third space loss. So I would like your opinion on this thing.
So third space loss is a big thing, as you said earlier, because in the 1960s, there was a study in the surgical journal, and they used sulfate tracer techniques to estimate the extracellular fluid volume in patients undergoing major abdominal surgery. And due to a fallacy in their methodology, they found that the extracellular fluid volume loss was exceeding the blood loss that occurred during the surgeries. So they postulated that there is this third space. So other than the intravascular and the extravascular space, there is a third space. And this third space was not anatomically defined, but it was supposed to reside in the damaged tissue or the GI tract. So this was their assumption, and this became a widespread practice all over the globe that we started giving fluid for the third space loss. Now, as time has gone by, there have been several studies, and there has been a very good systematic review by Bradstrup and colleagues, which showed that this methodology of the study was flawed, and there is no such thing as a third space. So this has made a lot of change in the current practice. Gradually it's come in, but now it's being accepted that you do not need to compensate for this non-existent third space loss. And what we've been doing all these years is we've been giving fluids, and this hypervolemia causes the glycocalyx of the capillary endothelium to get disrupted. This causes a lot of interstitial edema. And this is a cause of a significant number of all-cause major morbidity and mortality. So this has really gone out of the picture, and this has improved our outcomes.
Okay, so third space, which was sort of space we couldn't define beforehand, was mostly the result of faulty techniques. And as you pointed out, a lot of extra water fluid used to be given to the patients, and they had complications. Now let us move towards the next part of our discussion. Dr. Kalpana. So, most of anesthesia begins before, our planning begins before the surgery. So when we're talking about restrictive fluid therapy, is there some kind of preoperative period when you start thinking about therapy, like anything that you plan preoperatively in types of surgery, or specific patient characteristics or surgeries that you look for when you decide that you are going to use restrictive fluid therapy in the surgery?
Yeah, good evening. Thank you to the organizers and Dr. Jyotsna for inviting me. Yes, Dr. Palash, it's very true that we as anesthetists, we always start with a preoperative assessment and preoperative planning. So when we see the patient, you start like an anesthetist to find out whether the patient's intravascular volume is normal or is it already constricted. So that is one thing that we evaluate, go into the history, find out whether the patient has been vomiting. Maybe there is some intestinal obstruction. How is the intravascular volume? Is the patient already dehydrated? You try to find that out. Also, the next thing would be to find out the patient's comorbidities. How sick or how robust the patient is. A patient who's perfectly robust with good intravascular volume that you can assess by your assessment without any comorbidities would probably be a candidate. So the other thing, so you look at the comorbidities. A patient with a poor vascular cardiac problems, a patient with many comorbidities probably will be slightly wary to go in for a restrict. Somebody with a slightly higher creatinine to start with, maybe. So you look into the patient's comorbidities. The next thing, like in any preoperative assessment, you try to find out the extent of surgery. You try to find out the type of surgery. What type of surgery is it going to be? Just finding out the type of surgery is often not enough, because same type of surgery, the volume of disease could be extensively different. So a CRS can be a 2-hour case with hardly any blood loss or fluid loss, or it can be a 6 to 8 hour case with 3,000 ml of blood loss and vascular volume. So you speak to the surgeons, go back to the CT, go back to the, try to find out the volume of the disease. How long do you expect the case to go on? How much fluid shift do you expect? So all these keep in mind the patient's hemoglobin. Is the patient's preoperative likely that is he in a good patient condition? So we always have a box wherein the extent of surgery and the patient's comorbidity. The extent of surgery is not much, and the patient's comorbidity is okay. They come into the lower part of the graph, and then that's where you probably would decide to choose a restrictive fluid therapy. If at any point you think the patient's comorbidity warrant more intensive or more invasive investigations, then certainly go for it. So yes, restrictive fluid therapy has a lot of role to play in a particular type of surgery. When you talk about the type of surgery, if it's a minimally invasive surgery, patient is going in for a ERAS protocol, patient is going to have a laparoscopic surgery where there is going to be hardly an anatomical manipulation during the operation. There's going to be not much of an evaporative fluid loss. You would go in for a restrictive fluid therapy. So it depends upon so many other factors by which, like any anesthesiologist in any situation, you would build a case towards restrictive fluid therapy. Yes, restrictive fluid therapy has a lot of role to play, especially today. There's enough evidence to go in for restrictive fluid therapy, keeping in mind the type of patient and the type of case that you're going to go in for.
Right. So, especially if the patient has comorbidities and the surgery is going to be bigger and likely to have complications, you have to be more careful, and planning beforehand would be necessary. So, Dr. Kalpana, I also would like to ask you about certain specific situations that we face in these patients and how do you deal about these things. So, how do you deal with the fasting period?
Like I said again, if the patient is fasting because he is vomiting, I would be wary. If the patient is fasting because the surgeon decided or the anesthetist decided to fast them, that is not the norm anymore. Today, there are some evidence to even say that you can continue to drink clear water up to the time of going into the theater. Certainly 2 hours before, there is enough and more evidence that there is no need to fast. And having said that, there is no evidence to give any correcting for the fasting so many ml per hour for so many hours. All that is gone. You do not have to replace fluid for fasting. So that is a part of the restrictive. Yes, that is very clear.
Right. And what about neuraxial block? So patient gets an epidural, and maybe would you start the epidural right away, or you start it after the surgery is over?
So again, we could go in for a lesser, there is no hard and fast rule to say that I will start or I will not start. There is some evidence today with the cancer recurrence and the local anesthetics helping out. We could start a very low concentration without producing neuraxial block in a big way. But when you know that there is a big neuraxial block, and that is why a hypotension is happening in the perioperative period, it can be circumvented by starting a vasopressor. So either you don't start the epidural at all during the intraoperative period and use it only in the postoperative period. That's an option for during restrictive fluid therapy. Or if you have started it, use a vasopressor to vasoconstrict and not give more fluids which are going to go into the interstitial fluid area later.
Right. And how would you deal with, say, the bowel preparation which some surgeons use, or intraoperative bleeding? How are you going to tackle these two situations?
Bowel see, the recommendation is not to use bowel preparation, but like most surgeons, very difficult to convince them. Very, very difficult. What we could try is, try to ask them to use isosmolar bowel preparation. Try to, decrease the thing. Ask the patient to drink as much as possible. And if, again, the history helps. You ask the patient how much they have lost. And to a large extent, you do not replace any fluid volume, keeping in mind that so much is lost. morning of the surgery electrolyte may give some idea of where we are to help us in our fluid management.
Right. And for bleeding, what happens to intraoperative bleeding? You replace blood with blood or use some crystalloid or colloid initially?
Every hospital has a transfusion trigger. So today, the transfusion trigger in a patient with a stable cardiac condition, it has come down to a level of about 7 grams. Maybe if not 7, at least definitely 8 grams is where you would go with a patient with a stable cardiac profile. So in such a situation, we could replace with a colloid or with a crystalloid the ratio of crystalloid that's being used has come down tremendously. It is only about 1.3 to 1. 1 unit of blood you will probably replace by 1.3 of crystalloids. You could still go with crystalloid for a large time.
Right.
Yeah.
Okay, Dr. Anjali. So this question has partly been answered by Dr. Tobin, but I would also like to have your opinion. So how much fluid do you use? How do you decide? Clinical parameters, urine output, invasive tests, invasive monitors. What is your usual practice?
Yeah, Dr. Tobin has already addressed the most important bit, which is that you'd like to have stroke volume and cardiac output monitoring if it is possible. But depending on the case and depending upon what we actually have, we may not actually decide to institute all this monitoring. One thing about major abdominal surgery is that we would mostly place an intra-arterial line. And that intra-arterial line gives us a lot of information. So if you have your pulse pressure variation activated onto your monitor, which a lot of monitors provide nowadays, so you just need to configure your monitor, and that itself will give you the an idea about the left ventricular stroke volume, how it is varying with the respiratory phase. So if this is more than 15%, then your patient is fluid responsive, and you could give a bolus of fluid to check out how things are going. Now, if you do not have, or if in a certain case you've decided not to place an invasive arterial line, then you still have plethysmographic variation index, which is available in Masimo monitors. And it is similar to the PVV, but PPV. But the thing about that is that it is a non-invasive parameter. So you could use it more frequently. The fallacy being that if your perfusion falls, then you would not get reliable readings. Here also the cutoff is 15%. So at 15%, if the variation is 15%, then you would consider giving a bolus of fluid. Now suppose you don't have either of these, but you have placed an arterial line. What parameters you get is you get beat-to-beat monitoring of the blood pressure, and you could look at the pulse pressure. So if you look at the pulse pressure, it tells you whether if the pulse pressure is narrow, it means that your stroke volume is falling and your patient will benefit from a volume load. Whereas if you have a falling BP, but a wide pulse pressure, it means that your patient is well filled, and could be that you need to look at vasoconstrictors or inotropes depending upon the other parameters that you're monitoring. Now, the reason why I said that you should have a PPV, meaning you could just look at the swing. A lot of us just look at the swing in the arterial trace, a swing in the pulse, the plethysmograph trace. So what happens is, if you have a PPV installed, then you get a numerical value. So you're not guessing. So that is important. Hence, it is better to have the software and go with that rather than go with the swing in the trace. Now, what it really means is that PPV is a sort of a specific and sensitive index to have. If you are relying on the others like heart rate, blood pressure, or even CVP. Now CVP is discredited, but we know overall if you look at the trends, then if it's more than 12, then you would really not consider fluids. So all these things, because they have low specificity and sensitivity, you need a lot more data, and also you need very good interpretation skills. So if you do have PPV, I think it's not going to cost you much, but it's going to give you a lot of info.
Right. So apart from clinical judgments, pulse pressure variation, which does not cost the patient much, once we have got the monitor, would be very, very useful. Thank you. So we have about 6 more minutes left. So let us try to go through the few points rather briefly. So Dr. Tobin, what are the basic drawbacks of excessive fluid? When you give too much fluid.
I'm sure many of you who also look after surgical ICUs, when you walk into the ICU in the morning and you find that a patient who was otherwise no major comorbidity and you find a saturation of 91, 92, you invariably look at the fluid status and you put your stats on the chest and you do find that maybe this patient needs diatol. So there is a, as Dr. Anjali mentioned, the effect on glycocalyx, the impact comes on lungs. So saturation, there's a drop in saturation. Lungs can get soggy, become more prone to pneumonia and infection. There will be increase in afterload, more so impact on a cardiac patient, especially the low EF, and so that's a worrisome thing. We are worried about the wound becoming soggy. We don't want the bowel to get bloated and the stitches to bite into it. The patient has too much fluid, because that is a body's defensive mechanism, so that the body tends to hoard fluid because because of the response to surgery, and that if you have added fluid, we kind of make it very worse. And if you weigh such patients, you will find them about 5 to 10 and sometimes 12 kgs overweight. This obviously delays gastric motility. You cannot mobilize patient, because patients are not comfortable we try to get them out at 6 o'clock in the morning next day. They are a little reluctant. They are not very happy about it. It may also prolong my ICU stay. My cost goes up. And in case this leads to any major morbidity, like I said, a bowel wound dehiscence or an anastomotic dehiscence, then it impacts the cost.
Right.
It takes away the goodwill from the patient. So these are some of the things we look at, when we try to hold the fluid.
Dr. Pinkley, what are the benefits specific to our topic, that is GI oncosurgery, that we should expect if we are able to follow restrictive fluid therapy?
So one of the major benefits that most of the studies quote is that the GI motility returns early. So you have less nausea, vomiting, you have less ileus, you have an early return to elementary nutrition. And all of this also contributes to less wound dehiscence. Also, anastomotic leaks are less. This is one major thing, that the anastomotic leaks are rare if you are practicing the restrictive fluid therapy. Also, post-operative pulmonary complications go down. So these are the advantages. Length of stay goes down in the ICU, and some studies have shown overall length of stay going down as well.
Right. So there are multiple benefits. Okay, Dr. Saurav, what about the fluids in the post-operative period? Do you use any kind of standard guidelines, or how do you go about the post-operative therapy?
Sir, for the post-operative period, what we are practicing is, we see the extent of resection, the amount of tissue removed in the patient. What I'm usually practicing is, I give around 1.5 ml per kg per hour of maintenance fluid and try to restrict the overall 24-hour fluids to around 2 liters, which would include the dilutions for the antibiotics and other drugs. And then I'll practice an hourly urine output charting. I would not be very wary if the urine output is between 0.3 to 0.5 ml per kg per hour. But if the surgery is a HIPEC, which a patient has had intraoperative chemotherapy with an extensive resection, these kind of surgeries, we have seen in our practice that they require a lot of fluid in the post-operative period, and maybe going with a goal-directed therapy, even in the post-operative period with a closed abdomen, we've seen better return of hemodynamics with that.
Right.
So it depends on the type of surgery and the extent of resection. And also we always watch out for the lactates. Even if there is a no arterial line, I practice a morning ABG and an evening ABG for a major resection. And just to see the trend of lactate, hourly urine output charting, and our goals have to be very dynamic. And just on the back of the mind, in a normal surgery, I try to go around 2000 ml in the post-operative.
Okay. So Dr. Tobin, very briefly, what are the drawbacks? I mean, we are also talked about positive things. So what about the bad things that we are supposed to look out for?
So as I said at the start of this panel, that I hate any kind of over enthusiasm and jumping at the first literature which comes into hand. So I have been very pragmatic about fluids right from the beginning. So I am a big supporter of restrictive fluid, but yes, I'm very focused on the impact on kidneys. And as the earlier several panelists have said, lactates are a major focus in our department, and we watch them for major and supramajor surgeries for next 24 to 48 hours if required, especially if the patient has had a very massive CRS followed by hypec. So lactates are something we kind of go for even in non-cancer prolonged robotic surgeries, because I think it's a very excellent biomarker, and with an arterial line it is very good. So if you go overboard with fluid, especially in our patients who are coming to us after the neoadjuvant chemotherapy, we don't know. Urea creatinine will not tell us if there is an underlying renal hit. So in these patients, we have to be very protective of a patient, and we watch the creatinine next day in the morning, urea and creatinine. We make sure that even if there is a slight urine drop in the night, even at 2 o'clock in the morning, the action is taken immediately, because we don't want to cause any harm to the patient just because we are trying to hold so hard to a fluid. So that is always at the back of our mind. So kidneys, and I think there was an article in 2018 in New England Journal, I'm still not sure the content, where they have said, they've compared the liberal and restrictive, and they found that the incidence of acute renal AKI is 8%, and that in a liberal was just 5%. So there are advantages of restrictive, but if you go too much on one side, you are causing harm. So that one has to
So
watch.
we have to be very careful with patients with renal compromise. Can we?
Yes.
We
And
have
you
one
don't
more
want
question.
tachy,
Can I
the
proceed?
next day in the morning, patient becomes tachycardic. That also becomes a problem. So you must watch for the fluid, whether it is due to excessive fluid or because patient is too under, and that is the patient's tachycardic.
Okay, so we are out of time, but just one question that I would like to touch upon. So we have heard this term goal-directed fluid therapy a number of times in the discussion. Dr. Kalpana, would you please tell us how this goal-directed fluid therapy would be different from restrictive fluid therapy, and if you have a little preference for being, using goal-directed therapy?
Like I said, whenever you think the surgery is major or the patient have comorbidities, you need to evaluate and monitor the patient more. And one of the commonest monitors that is used is non-invasive measurement of blood pressure, non-invasive measurement of cardiac output. And the way to do it is with just with the peripheral arterial line and with the trend of stroke volume variation and the pulse pressure variation. But to a large extent, if you look at the stroke volume and the trend of the stroke volume, it gives you an idea of where we are. And the way to do it is, not to give continuous maintenance fluids, but to give intermittent as and when needed. You give a bolus when the stroke volume variation goes above maybe 15 to 18, which is the percentage of the variation. That's when you start giving a bolus of fluid. Generally, a crystalloid is given. There are some proponents to give a colloid, but we give crystalloid balanced salt solution of 250 ml and see where the the SVV goes. If it comes down by about 10%, then you feel that you've achieved your goal, and you look at your stroke volume and fix that stroke volume and go on till the next time the stroke volume goes up over stroke volume variation goes over 18%. So this is a dynamic parameter which we keep on monitoring and give intermittent boluses of fluid to achieve our goal. So that's why it's called a goal-directed.
We are still sort of within restrictive fluid therapy, but we are just using monitoring to making sure that we are not overdoing it, right? And maintaining an adequate cardiac output.
And there is no continuous maintenance. It's just boluses of fluid.
It's just boluses of fluid to have an cardiac output that you want to achieve and prevent a fall in cardiac output.
At this juncture, I'll also like to say that it's not the cardiac output. It is, you have to keep remembering, it is the oxygen flux.
It is the oxygen flux that
which is
very,
the most
very important
thing. Yeah.
Right. I think the last slide from the previous presentation where Dr. Ravi said that it is oxygen that takes you to the top of the Everest, and I think we can end by the same saying that it is oxygen that takes you to the top of Everest, and this is what we're trying to achieve, and do not fall short on oxygen supply. Thank you. There are a few questions.
Yeah, there is some questions. If you can take that.
I think there are two questions about the use of lactate. So I think the panelists have mentioned that they are using lactate as a guide to fluid therapy in the intraoperative period for longer surgeries, and also in the intensive care unit they are monitoring, not only also to note their improvement in the postoperative period.
Yes,
and
marker. Another question is on albumin infusion.
Albumin infusions in major oncosurgery. So are any one of you using albumin in your day-to-day practice?
Yes.
Yes, we do.
Okay, so
we do. If there is a lot of blood loss, there is a lot of, you expect that you're going to shift the patient with a lot of interstitial edema, then we certainly use albumin. there are, I think some places in our country uses 5%. We have only 20% available, so we use 20%.
100%.
And we use at a very slow rate as the background infusion.
So most of us do not have 5%. I think 5%.
People, I think,
5%,
TMH convert it into, 20% into 5%.
So
if there is a lot of ascitic fluid drained at the start of surgery, then if there is a sudden decompression of hemodynamics, we usually prepare a 5% by diluting it in NS, the 20%, and give it fast. Otherwise, to cover the extent of resection and the protein loss, we give a 20% on the background. But I need to be sure about the cardiac status, and the patient should not go into fluid overload. Cardiac status should be known at the pre-op. And we do not usually give albumin if it is on the lower side. If the patient is sustaining in the pre-op period, we expect that if there is no major resection, it will be sustained in the post-op. We take a call by discussion with the surgeons in the post-op period, the extent of resection, and then we give 3 days of albumin, 20% once a day.
So you are not chasing a plasma albumin level.
No. So this is the practice, I think, when we follow that we start 20% and we give a touch of diator in the infusion, so that just to be on the safer side. Mostly for very extensive surgeries.
Okay.
CRS,
so there are
HPAC,
2 more questions. One about the NEGM study in 2018 that was mentioned, where they showed that with extreme restrictive fluid therapy, there's an increased incidence of AKI. And there is also one question from Rudronil Londi, who also said that post-operative renal dysfunction. Please comment. So I think the comments has already been made that there is a bit of evidence.
I think that mild study had a lot of controversy regarding that study.
Correct.
Let's not take back saying that study said no restriction. So I think we should go more into the details of the study before taking back that.
And as all of you said, emphasize the fact that intraoperatively you cannot take a decision once and forget everything about it. So throughout the procedure, you are monitoring, you are looking for ways to figure out if your oxygen delivery to the tissues is adequate, if your perfusion is adequate. So all this
the patient should be the focus.
Absolutely, the patient should be the focus, and the changing dynamics of the operative field, operating scenario should, we should adapt to that and change our management. So that way we can prevent that.
And even in the relief trial, the 30-day outcomes were the same. So the immediate outcomes can be overcome. It is just a transient phase. We should stick to the.
That's as I said, over enthusiasm is, we have to use our clinical sense and individualize it to every patient. Instead of following a protocol
is more important.
Okay.
Patients tend to recover in another 4 days. If for the first 2 days you do have AKI and it's mild, they do tend to recover. So
yes,
we need to look at that. And I would just like to thank Dr. Jyotsna and her team, and they've had a wonderful day. Congratulations.
Yeah, Jyotsna. Excellent.
So Palash, did we finish the session?
Yeah, sure. Thank you. Thank you, panelists.
Thank you, Dr. Palash.
Thank you, Dr. Goswami. It was an excellent, enjoyable discussion.
Yeah.
Thank you, everyone.
It is very nice interactive session. Thank you, Palash, to nicely moderate it, and thank you all the panelists. Really, it is very nice and interactive session, and it's very interesting topic also, so that we all can interact with me nicely. Okay.
Thank
you very much.
Thank you.
We'll end this
Have
session
a nice
here.
evening, all of you.
Thank you. So now the ProCon session. My co-chairperson, Dr. Deepika Patel. Deepika, you are here?
Yes, very good afternoon, everybody. And our last discussion is on restrictive transfusion trigger is ideal in oncosurgical patients. And Dr. Meghna M. Natkarni will talk on PRONS. She is consultant anesthesiologist at ACI Kumbala Hill Hospital, Asian Cancer Institute. And now I request Dr. Meghna Natkarni to kindly talk on the PRONS of the restrictive fluid therapy.
Hello, everyone. Hello, everyone. I hope I'm audible.
Yes, you're audible.
Yes, ma'am.
At the onset, I would like to thank the organizers and Jyotsna ma'am for inviting me for this conference, and especially to the technical team for making everything so seamless. I would like to start my presentation now. So basically the topic is restrictive transfusion trigger in oncosurgical patients, whether it is ideal or not. Now, why are we doing this topic? For years together, the standard teaching in our hospitals and practice has been to maintain a hemoglobin above 10. And it was always a 10/30 rule, where the hemoglobin was always above 10 and the hematocrit above 30 in scenarios where we were seeing the patients preoperatively or postoperatively or in the ICU. This was basically so that there was no imbalance between the demand and supply of oxygen, so that there was no problem to the patient at the cellular level for oxygen extraction. Then came an era where HIV and hepatitis infections were introduced, and these were highlighted because of the transmission of blood-borne pathogens through blood transfusions, and blood transfusions sort of gained a negative impact. In 1998, however, there was a consensus conference which paved the way for change. It was on perioperative red cell transfusions, and it somehow started thinking as to whether this hemoglobin of 10 was actually an ideal thing in a patient. Now, why are our patients so different as opposed to other normal gynec patients or simple surgical patients? Because we have tumors which are very, very big. Sometimes it can be secondary to any bone marrow depression, post-radiotherapy, complex surgery, or chronic anemia. Therefore, in oncosurgery, there has always been a trend towards a liberal approach towards blood transfusion and fluid transfusion. Now, by restrictive versus liberal, we mean that these are strategies to maintain a lower hemoglobin level, usually between 7 and 9, and the trigger being around 7, as according to today's literature. Versus liberal, where it aims to maintain a higher level, that is the trigger being around 10. Now, we all know what are the hazards of blood transfusion, whether it's infection, volume overload, hyperkalemia, several allergic reactions. What we are concerned with today is basically the immune reactions, that is the TRIM, or the transfusion-related immunomodulation that is seen in patients. This was first recognized in renal transplant patients. They saw that the patients who were given multiple blood transfusions prior to doing the surgery, transplant, showed an improved renal allograft survival. Now, this was in an era before immunosuppressant drugs were used. And the reason for this was the immunosuppression helped the kidney to survive. Now, Gant stated his belief that blood transfusion in patients with malignant tumors would give the tumor a better chance to survive. Basically, it's the same theory that immunosuppression gives the tumor a better chance to grow. This is supposed to be because of the suppression of the natural killer cells and activation of the lymphocytes. Now, these are some trials which are very, very important, which paved the way for change towards a restrictive transfusion strategy. The TRIC trial, which was in a critically ill patients, was basically seen and introduced in 1999, basically, where they saw that the restrictive strategy was as effective, possibly superior to a liberal strategy. However, this was not in patients with acute MI or unstable angina, because they saw that the complications increased. Similarly, after cardiac surgery, transfusion after cardiac surgery, the TRACS trial, they resulted in a restrictive strategy, was a non-inferior, with a sort of similar rate between the restrictive and the liberal strategy of transfusion. Similarly, the CRIT trial showed that the more the number of RBC units transfused worsened the clinical outcome in critical ill patients. Now, the prototype for cancer has always been colon cancer because it's one of the most frequently seen cancers. Now, this is a paper that came out in 1998, where they showed that the effect of perioperative blood transfusions on the recurrence of colorectal cancer, where they showed 32 studies with a number of patients being 11,000 odd. showed 20 of these studies showed a detrimental effect, with blood transfusion being an independent risk factor for the recurrence of colorectal cancer. The same study was reviewed in 2004 after a period of about 6 years by the same authors, which validated the studies of the results of the previous study. Now, there are various papers on colon cancers, and this is a recent one that has come up: the perioperative transfusion and the prognosis of colorectal cancer surgery, a systematic review and meta-analysis. Now, this showed that if you give a restrictive transfusion strategy is applied in patients, it decreases the increases the overall survival. Basically, a decrease is seen in patients whom you give a transfusion, a decrease is seen in the cancer-specific survival, and an increase in the post-op complications, increase in the anastomotic leaks and re-explorations. Now, we come to the other cancers, like blood transfusions affecting the outcomes of patients with lung cancer. In a similar case study, a systematic review and meta-analysis, they saw that a number of patients with lung cancer who were given blood transfusion showed a decrease in the overall survival, decrease in the disease-free survival, and an increase in the morbidity following blood transfusions. Gastric cancers, pancreatic cancers too, similar meta-analyses have shown that whenever you give blood transfusions to a patient, just based on the hemoglobin trigger, to increase the hemoglobin above 10, you will see an increase in the morbidity and mortality and increase in the hospital stay. Now, how low should we go? This was a recent systemic review and meta-analysis on the impact of restrictive red blood transfusion strategies in oncology. This is one of the very first things to compare liberal versus restrictive, where they've studied 983 patients and taken 6 studies into account, where they have shown that if you restrict the blood transfusions in the patient during surgery and post-operatively to maintain a trigger factor of around 7 to 8, there are better results with less post-op complications, improved recovery of the patient, and less hospital stay and cost. Now, what is post-op infections and blood transfusions? Now, another thing that we have to consider when we consider post-op infections is blood transfusions are known to increase the post-op infections, increase the hospital stay and morbidity. Every unit of blood transfused increase the risk of infection by 20%. Now, this is related to not only skin infections or organ infections, but also pneumonias, increases your risk of re-explorations, increases the risk of wound infections, basically hospital stay and cost. So in conclusion, I would like to say that restrictive transfusion strategy has proved to be beneficial in cancer patients versus liberal. Benefits are seen with overall survival, disease-free survival, with less post-op complications, less morbidity, and low hospital stay. Now, there are a number of papers that are seen, which is impossible to cover in this 7 minutes. But I don't think I need to prove more than this, that a restrictive strategy is much better in oncosurgery versus a liberal one. Thank you.
Thank you, Dr. Meghna. Thank you. It was an excellent discussion lecture. Now I'll request Dr. Meenakshi VV. She will talk on the restrictive transfusion trigger, ideally in oncosurgical patients, cons. She is an associate professor in the Cancer Institute, Adyar, Chennai. Over to Dr. Meenakshi. Dr. Meenakshi.
Good evening. Greetings from Cancer Institute, Chennai. I thank the organizers of SOAPCCON 2021 for the opportunity to speak in today's pro and con session. I speak in favor of a liberal transfusion trigger in oncological surgeries. The content of this talk pertains only to adults with solid organ malignancies. Most studies define the liberal transfusion trigger as less than 9 grams per deciliter, while a restrictive transfusion trigger is less than 7 grams per deciliter. In Dr. Juan Carter's words, anemia, its treatment with transfusion, and their combination are each associated with poor outcomes. Anemia is commonly seen in cancer patients, and it is caused by the tumor biology, the treatment modalities such as chemotherapy and radiation, and perioperative losses due to long and complex surgeries. Therefore, blood transfusions are often necessary to correct anemia to improve the oxygen delivery and correct coagulopathies. The biological consequences of transfusion include transfusion reactions and transfusion-related immunomodulation, which actually translates to tumor proliferation, invasion, and metastasis, leading to detrimental surgical outcomes. So what does the evidence say? Blood transfusions have been associated with poor oncological outcomes in patients with colorectal, lung, and hepatobiliary cancers. The association is somewhat controversial in ovarian cancers, renal cancers, and bladder cancers. No clear association has been found after prostate cancer surgery. The TRISOP study, published in Anesthesiology 2015, examined the transfusion requirements in surgical oncology patients. This was a prospective, double-blind, randomized controlled trial in adult patients with solid organ cancers admitted to the ICU following major abdominal surgeries. And they were randomized to receive leukoreduced red blood cells for either a liberal transfusion trigger of less than 9 grams per deciliter or a restrictive trigger of less than 7 grams per deciliter. Among 31 outcomes measured, differences were seen in the composite outcome, which was 30-day mortality plus cardiovascular complications. Differences also noticed in the occurrence of abdominal infections. The liberal treatment arm saw fewer major postoperative complications. Another elegantly designed randomized controlled trial was the TRICOP study, published in 2017. The transfusion requirements in critically ill oncological patients was observed in 300 patients who were randomized to the liberal or the restrictive arm. The primary outcome was a 28-day mortality, which was definitely lower in the restricted group. There were no differences in ICU or hospital length of stay. There was significant difference in the 90-day mortality. The liberal group performed far better than the restricted group. The authors concluded an improving survival trend in the liberal transfusion arm in patients with septic shock as compared to the restrictive arm. More recently, a large cohort study applying propensity score matching was performed in patients who underwent surgery for colorectal cancer. This study found that blood transfusions were associated with shorter disease-free survival and overall survival. They also found that larger transfusion volumes was linked to higher overall mortality, but not to cancer recurrence. This study had a lot of limitations. It was not only retrospective and observational in design, patients were not randomized, and clinical care was not standardized. In addition, there were several unmeasured confounding variables which could not be evaluated. Another review saw no difference in mortality between strategies. There were no differences in adverse events reported between the restrictive and liberal transfusion strategies. As oncoanesthetists, we often have to give anesthesia for patients undergoing brachytherapy for curative treatment of cervical cancers. A liberal packed red blood cell transfusion strategy has been recommended by consensus in this cohort to overcome hypoxia-induced radioresistance. To conclude, transfusion is frequently a necessary evil in the surgical and non-surgical management of cancer patients. Though there is mounting evidence that red cell, platelet, or plasma transfusions may adversely affect the outcomes in cancer patients, it is not clear from the published evidence that a specific dose or a transfusion trigger can be recommended in this special population. Therefore, when deciding to transfuse a patient, it might be a good idea to not only look at the hemoglobin level, but also ensure normovolemia and look at other measures to mitigate blood loss. Thank you for your patient listening.
Thank you. Thank you, Dr. Meenakshi. So, Dr. Meghna, do you want to say over Dr. Meenakshi anything?
I'm muted.
I think what is important to understand when we mean a restrictive transfusion strategy is we have presumed that the patient is normovolumic. We have presumed that the patient is not actively bleeding anywhere. We have presumed that patient has no cardiac comorbidities which have shown to have an increased complication rate if a restrictive transfusion strategy is applied.
Yeah. So, but Dr. Meenakshi?
Yes, I agree with my co-speaker. I think she's got it all. Yeah, so if most of the studies, unfortunately, the methods of transfusion was not clinically standardized. So the normovolemia had not been, ensured. So there are a lot of faults in the design. So I think with goal-directed management, we need not, restrict ourselves to just the transfusion trigger, the number. We have to look at the picture all, in the entire clinical context. So look at the hemoglobin, look at the goal-directed fluid management goals, and by side by side, you do have to look at measures to control your blood loss during surgery, because that is increasingly in the literature's talking about ways to curtail the blood loss, curtail the surgical time, because most of our surgeries are very complex. So the timing and the loss during surgery is extremely important. So that is a big player in all the studies. So
I think it is important to basically look at each patient individually and not, have fixed protocols in the ICU or in the operation theater that, you have to give fluid only, give blood only if the HB is below 7.
Yes. Also, there's not much evidence in case of other surgeries. We have a lot of evidence in colorectal surgery.
Yes.
We have lung surgery, some say, but not in, suppose, in ovarian cytoreductive surgery and all those surgeries. There is not much evidence on restrictive blood therapy, but it always depends on your clinical judgment and the scenario, and then every patient, it should be individualized what is needed for that particular patient at that particular moment. So I think that should be our all clinical judgment what we do in our day-to-day practice. Right?
Yeah.
Yep.
Okay. So thank you very much. Very well discussed, Dr. Meghna and Dr. Meenakshi. Both
Thank
of
you,
you.
ma'am.
Thank you,
Thank you, ma'am. Thank you, Dr. Meenakshi.
Thank you, Dr. Meghna.
Thank you. Okay, so today we'll end the session. Swati, you are here?
Yes, ma'am. Thank you, ma'am. It was a wonderful session on fluid and blood management. With this, we wind off our today's program. We will be waiting to meet you all tomorrow at 11 a.m. to complete our journey through rehabilitation to palliation, SOAPCCON 2021.
Thank you.
Thank you.